Good morning to one and all assembled here. A warm welcome to all the dignitaries and delegates who have made their way here today to expand their knowledge on the relevant topic, stroke. I hope you make the best out of this conference. And with this, let me start off the official function. I welcome the dignitaries onto the dais. Dr. Paul G. Alapat, our chief guest for today, Chief Consultant in Interventional Neurology from Calicut MIMS, Dr. Gopakumaran Karta, Dean of Dr. Bhuban's Medical College, Dr. Arun Aravind, DMS, DMMC, Dr. Manoj Narayanan, MS of Dr. Bhuban's Medical College, Dr. Anish Bashir, Head of Department of Internal Medicine, Dr. Charian, Head of Department, Cardiology, and Dr. Sarfraz Sheikh, Head of Department of Emergency Medicine. I would request Dr. Sarfraz Sheikh, Head of Department of Emergency Medicine, to deliver the welcome speech.
Good morning, all. I welcome respected Dean, Dr. Gopakumaran N. Karta, our Medical Superintendent Manoj Sir, Head of the Department of Medicine Anish Bashir Sir, Head of Department of Cardiology Dr. Charian, and Interventional Consultant at MIMS, Dr. Paul J. Alapat. It's a great opportunity for all of us assembled here to get more knowledge on the topic, that is stroke, which is the third leading cause of death in the entire world, and one of the most reversible thing like our MIs. In last 1 year, almost 1.5 year, we opened our exclusive stroke unit. I still remember Dr. Bashir sir opening it. Okay, since then we have moved a lot. On and around, if I get statistics, we have thrombolized around 89 cases in last 1 year. But for our great misfortune, 80% of the cases that were coming to our hospital with outside window period. May it be the lack of knowledge, may it be the lack of resources that are available in Wayanad, or may it be the lack of imaging, or delay in transportation, say whatever it may be. Dr. Pradesh here will be knowing it was great difficulty or a difficult situation for us to see patients who were reaching outside window period, and that too of young age. The prevalence of stroke has increased, especially post-COVID era. You're getting lot of strokes in your 4th, 5th decades of life. There is a topic to be researched yet. Okay, so once again I welcome you all. I'm very happy we have all assembled. So let us all dive into a great deep sea of knowledge of stroke, and by the end of the session of CME today, hope you all get knowledgeable. Thank you.
Thank you, sir. Next, I would welcome Dr. Gopakumaran Karta, Dean of Dr. Bhuban's Medical College, to deliver the inaugural speech.
Good morning to all. We are already delayed, say about 1 hour. I think there is no sanctity for having a very elaborate, extensive, exhaustive inaugural speech. I congratulate the Department of Emergency Department to come forward with such a very relevant, very important, significant topic, and I hope that it will be very meaningful, and it will spread a lot of knowledge and throws light into certain unexplored areas, like as Sarfraz really mentioned, that we are losing so many patients and the irreversible neurological damages because of the time of intervention. I think this particular session will be definitely focusing on how we can do the best for these stroke patients, and the problem or the damage can be reverted back or can be normalized back, and let all the stroke patients will be having almost a near normal life once they come out from this medical catastrophe. Nothing to add more about it. I think we have already laid. So I think there is no much significance for any an extensive inaugural sessions like this for an academic program. So I, with all permission, with the permission of Almighty, I officially declare that this academic session is being inaugurated, and I wish you all the very best and a very academic feast for all of you. Thank you.
Thank you, sir. Fire, being the strongest amongst Panchbhuta, according to Indian tradition, is the one that cleanses everything without being impure itself. With that note, I would welcome the dignitaries to proceed with the lamp lighting. Next, I would request Dr. Arun Aravind, DMS, DMMC, to deliver a felicitation note.
Good morning all. Respected Dean Dr. Gopakamaran Karta, respected Medical Superintendent Manoj Narayan sir, and all the dignitaries on and off the dais. I'm very happy that the Department of Emergency Medicine has come up with, actually they are conducting CMEs regularly in important topics like stroke. Last time it was trauma con. And we know that with respect to stroke, we know the golden hour, the importance of time in managing stroke. And unlike the olden era where most of the stroke patients were they will be having lot of disabilities after getting a stroke, but the scenario has entirely changed in the recent time because of the advance in the medical as well as the surgical field as well as the rehabilitation. So even though it has advanced so much, the awareness among both the public as well as the medical professionals is very less. So conducting such CMEs will definitely help us to learn more about the newer techniques and facilities which are available in treating stroke. So I wish all the very best for the CME. Thank you.
Thank you, sir. Now I would request Dr. Manoj Narayan, Medical Superintendent, to deliver the keynote address.
Good morning all. Respected Dean and other dignitaries on the dais, dignitaries of the dais, delegates, my dear colleagues. To put it short, this effort, the stroke conference, and highlighting and upskilling the skills of those in the periphery and in the tertiary care centers in giving a better shape of life to those who have undergone stroke. And roughly going by whatever statistics I could access, if you take the population of Wayanad as 20 lakhs, maybe a bit less than that, and the Sri Chitra stroke registry showing some 120 to 140 per lakh of stroke incidents. Maybe it is not representative of the entire state or our district, and going by the population, roughly around 2,600 per year in Wayanad having stroke, and with the mortality of somewhere around 25% and 40 to 50% of the others having moderate to severe disability throughout life. As healthcare professionals, our duty to save lives and give a better quality survival for anybody who goes or undergoes any such calamitous incidents in their life. That's what this conference is aiming at, to give them a better shape or a better quality of life having undergone stroke, for which we have a stroke team. The departments of emergency medicine, radiology, neurosciences and general medicine coming into play. And the idea or the concept of golden hour, that is initial 60 minutes, initial meaning the onset of symptoms. In that window period, if such patients reach the stroke center, the maximum possible could be done. That is the idea of it. And just like the inaugural, the welcome address, our ED chief was saying, 80% of the cases are coming off the window period. Maybe something can be done if they reach within 4 hours or even 6 hours, depending upon the decision of the stroke team at that time. But the golden hour, that is violated almost 80 to or maybe even 100% of times. So this conference for the district of Wayanad, with all its backwardness, should be so crucial. And I wish all the best for the district, for the population of Wayanad and the stroke team to have a very, very satisfying outcome for the patients, and very satisfying sense of having achieved or done something for the society, for the entire stroke team. All the best for this conference. Thank you.
Thank you, sir. Now I request Dr. Gokumaran Karta to hand over a token of appreciation to our chief guest, Dr. Paul Alapat, and further Dr. Paul to speak a few words.
Good morning. It's always a pleasure to be back here in Wayanad, seeing all the good infrastructure. And I was here for 1 year, 2 to 3 years back into 2020, 2021. So good to be back, because always when you see the atmosphere here, we always feel like coming back here. Only the travel is the most difficult one. I would just make one point and end this. That is regarding the amount of thrombolysis. It is good work, because I don't know if it was, maybe it was there before also, but initially when we had started during that time, we had few cases, but 89 thrombolysis in a year, it is a very good number. But every world over you, people miss thrombolysis because of the time, they miss the time. So for that, actually, more than these conferences and educating physicians, we have to go to the community, because you have to make the community aware. So you have to develop programs to make the community aware that there is a treatment for this. And this is the only treatment in the initial few days or the few hours which you can do. And so I think because the management also is here, So you have to put in more efforts because what you're doing is big. Because when last time there was a controversy in Wayanad regarding a tiger death, and then I was just thinking when I was seeing the conference, like the person, because I know this hospital, I've come and you see the facilities, you know that everything is being done here, but people do not know sometimes that they can come here, and in that also the cost also should be supported. Cost, whenever you're doing a community outreach, the cost also should not come into it, and you have to support every single patient. That can also be done with a bit of effort, because a lot of people is willing to help. So I would like to end by saying that you should give more emphasis on community outreach and being with the community, so that people know that they have to come, because most people do not know that where it is available. So that has to be done. Thank you.
Thank you, sir. Now that would be the end of the official function. I request the dignitaries to join the delegates of the dais. So proceeding with our first session, we have Introduction and Pre-Hospital Management of Stroke by Dr. Shinu Shinsi. She is the senior resident of Emergency Medicine Department in Dr. Mupin's Medical College, who completed her MBBS in Thrissur Medical College and badged her DNB Emergency Medicine in Baptist Hospital, Bangalore. I would request Dr. Arun Aravind to chair this session.
Very good morning to one and all. Today I am here to present pre-hospital management of stroke. So over the past 28 years, the treatment of stroke has evolved enormously. From the initial LINS trial in 1995, where Altiplase was found to be effective in management of acute ischemic stroke, to the ICAS trial 3, where the time period for thrombolysis was extended to 4.5 hours. The treatment has been evolving. So in 2015, the revolutionary Dawn and Diffuse trial was published, which showed that in patients with large vessel occlusion with perfusion imaging, a selected group can be mechanical thrombectomy can be done even till 24 hours of onset of symptoms. So what I'm trying to say is the stroke treatment is always time bound. So there should be a coordination between the emergency services, the emergency department and the stroke care team for the management of stroke. So let's look at the chain of survival for stroke. So initial is the recognition of stroke. Here, recognition, bystander identifies the patient is having a symptom, then they call the emergency medical services where they dispatch the paramedics. The paramedics reach the site of the patient, location of the patient. They evaluate the patient and transport in an ambulance to the emergency department where further imaging and further management is taken care of. So according to studies, 70% of the patients with acute stroke does not reach hospitals in India. So where can we work? It is basically in the community level, and also we can strengthen the pre-hospital setup. So the patient at least reaches the hospitals in time, that is within the window period. So AHA 2019 has emphasized on the use of stroke assessment by the EMS provider. So there is a severity based stroke algorithm triage protocol. So first thing is that, as I told earlier, they dispatch, once the dispatcher gets the call, they dispatch the paramedics to the location of the patient, where the EMS personnel will assess the patient. If they are suspecting stroke, there are certain stroke scales to identify stroke on the field. And they also rule out other stroke mimics like a hypoglycemia. So if the paramedics identify it as stroke, the next thing is they will try to understand when is the last known well time. That is, when was the patient when was the patient seen normal the last, and when is the onset of symptoms. And they'll perform and document the results of, and they'll see the severity of stroke. The severe the stroke, the more chances of large vessel occlusion. So once large vessel occlusion is suspected, then they have two choices. They'll see whether the patient is, the symptom onset is within 6 hours or more than 6 hours. If it is within 6 hours, the patient is usually transferred to a comprehensive stroke center. These and all are Western guidelines. So to assess stroke, we have stroke scale, that is basically to identify the stroke on the location, and also stroke severity score to see how severe the stroke is, so that we can anticipate a large vessel occlusion. So stroke scales include Cincinnati pre-hospital stroke scale, Los Angeles pre-hospital stroke scale, BFAST, Melbourne ambulance stroke scale. These are all externally validated stroke scales. And stroke severity scores are NIHS's Rapid Arterial Occlusion Evaluation Scale and Cincinnati pre-hospital stroke severity score, about which I'll be talking a little bit in detail. So Cincinnati pre-hospital stroke is the easiest score to be followed on a site. So they'll see for facial droop, arm drift, and whether patient has any speech abnormality. It is said that if one is positive, it is 72% chance of ischemic stroke. That is basically anterior circulation stroke. If 3 are positive, 85%. But they found out that 14% of the strokes were missed with only this 3 components. So they added 2 more symptoms, that is balance and eye, that whether there is any acute loss of vision or the patient has any double vision or something. So with this, when BFAST was introduced, it is found out that the 14% stroke that was missed in the FAST exam only, that it reduced to 4.4%. Another stroke scale is Los Angeles pre-hospital stroke screen. So they have look for age more than 45, history of seizures, symptom duration if it's less than 24 hours, at baseline whether patient is wheelchair bound or not, blood sugars between 60 to 400, obvious asymmetry between the both sides, facial smile, that is any facial nerve palsy, grip and arm strength. So this is also an externally validated sensitivity of 91% and specificity of 97%. Thing is that it eliminates the stroke mimics to a better extent than the previous 2 scales. So once EMS personnel identifies that patient is having stroke, then they have to see how severe the stroke is. So this is basically to triage the patient to a place where there is a chance of mechanical thrombectomy, where there is a facility for mechanical thrombectomy. So basically the EMS stroke scales that has been used is RACE stroke scale, that is Rapid Arterial Occlusion Evaluation Stroke Scale. It predicts large cerebral arterial occlusions. There are 6 components: facial palsy, arm motor function, leg motor function, head and gaze deviation, aphasia in case of right hemiparesis, and agnosia in case of left side hemiparesis. So it has a sensitivity of around 85% and specificity is around 68% if a score is more than 5. This is to have a large vessel occlusion, and a positive predictive value of 76%. Another simpler stroke scale that can be used to assess the severity of stroke is Cincinnati Stroke Triage Assessment Tool. It is simpler compared to the other one. So they see for conjugate eye deviation, level of consciousness, arm weakness, etc. It has a sensitivity of 92%, but specificity is little less, 52%. And the most commonly used stroke severity score is NIHSS only, but it is not used in the field because it is little difficult. It has 11 categorical neurological examination, and it takes time for the person to get accustomed with assessing NIHSS. But it has higher inter-rater reliability, and it taken within 48 of acute stroke, the NIHSS can predict 3 months and 1 year clinical outcomes. And it's well validated to measure stroke severity and can be assessed via telemedicine also. So the current scenario, the stroke is the 4th most leading cause of death and 5th leading cause of disability in India. And incidence is around 108 to 172 in 1 lakh people per year. And in Kerala, it's around 117 in 1 lakh people per year, and 51% of which is females. So many people in our area does not even get access to the hospital services. There are many factors. One is limited awareness of stroke symptoms, large distances to travel between the home and the hospital, lack of ambulance and staff and transportation, and availability of alternative non-hospital therapies that people may consider as effective after stroke, and limited finances to cover the cost of care, and limited number of specialists. So in 2020, in Stroke Journal, they have published the interventions that can be brought into so that the stroke care in India can be improved. So short-term solutions like free cost of medicines in public hospitals, National Stroke Helpline, etc. And easy to achieve, you can see CT-equipped mobile stroke units. This mobile stroke units has been there for the past 10 years in all Western countries. So mobile stroke units are basically specialized ambulances equipped with personnel and a CT scanner. It is capability so that they diagnose on the field, and they reduce a time of thrombolysis in the ambulance only. So as you can see, in the first case, that is normal standard of care, the EMS personnel will reach, the first aid is given, they transport to the hospital, the diagnostic workup, and from there, from the ED, they identify it as ischemic stroke and they thrombolize the patient. Whereas in ambulances, that is in mobile stroke units, the EMS personnel reach the scene, and first aid and diagnostic workup has been done in the ambulance only, so that the time for thrombolysis is reduced and the patient can go to a like if the center with mechanical thrombectomy facility is farther away, it gets time for them to identify and reach the patient. So as I told earlier, it reduces the time for thrombolysis. If the patient has an IC bleed, immediately we can reverse the anticoagulants if they are using any, and comprehensive pre-notification for in-hospital services. Okay, so take up points. So early identification of stroke is vital in reducing mortality and morbidity. Then stroke scales and stroke severity scores help in reducing the delays in treatment of acute stroke, and MSU is the future for stroke treatment. Thank you.
Thank you, ma'am. Now I would request the chairperson, Dr. Arun Aravind, to hand over a token of appreciation to Dr. Shinu Sinsi. For the next session, we have Dr. Arjun Chandrasekharan, consultant in the Internal Medicine Department, briefing on the topic localization of stroke. I would request Dr. Paul G. Alapat to chair the session.
Good morning to all. Myself, Dr. Arjun. I am Assistant Professor in the Department of General Medicine. And before going into the topic proper, I would like to thank the organizing committee, organizing chairman, Dr. Sarfaraz sir, and scientific committee chairperson, Dr. Anish Bashir sir, for giving me this opportunity. And now, coming to the topic, today I'll be dealing with localization of stroke. So, we'll be looking the topic under these headings. Let's have a walk through why clinical localization is still relevant in the era of modern neuroimaging techniques, why clinical localization is still relevant. Then we will see the general approach to localization in neurology. It will be very brief. And the next thing will be when to suspect a stroke and how to exclude the mimickers. We will be briefly touching that topic. Then identifying or localizing the type of stroke. Then we will go through brief review of a blood supply and functional anatomy of brain, which are essential in localization. Then finally localizing the vascular territories. Then we will also see a brief summary. So coming to clinical localization of stroke. Why is stroke still, clinical localization is still relevant? When a CT or an MRI, which can give the exact site of lesion, and an angiography can give the added idea regarding the culprit vessel, is clinical localization still relevant in this scenario? I would say yes, because it is important in many aspects. Being the first one being clinical localization is very important for safe patient care and rapid diagnosis. I would like to tell an example. When a patient who is known to have vascular comorbidities present to the ED, or referred from a periphery hospital in view of thrombolytic therapy. And when we are seeing the patient, if the patient is having symptoms which are bizarre and cannot be localized to a vascular territory, we have to think of a stroke mimicker. We can suspect a functional reason for the patient's symptoms. And if such a patient receives a thrombolytic therapy, such a patient receive antiplatelets and end up in a complication, that will be very disastrous. So for safe patient care and rapid diagnosis, clinical localization is still relevant. Next is ensuring appropriate timely investigation. Appropriate and timely investigation are requested. This is to be taken care of, especially in the emergency setting. When the patient comes with a sudden onset neurological deficit, we are having a suspicion of stroke. But we have to rule out the common mimickers first before proceeding further with the neuroimaging and other investigation. Because I would like to tell an example which happened during my house residency. I was in the medicine casualty. There was the PG as well. So around 60s, a woman in her 60s was brought to the casualty by the onlookers after she collapsed in the bed stand. So when the PG examined the case, he just looked at the patient was drowsy, and he just looked at the pupil and he then proceeded with examining the plantar. The right plantar was extensor and the left plantar was flexor. So the PG straight away suspected a stroke, went on with the neuroimaging, and the patient came after neuroimaging in the same situation. The provisional CT report was normal. The consultant who was present in the ED at that time asked for a GRBS, and the GRBS value turned out to be 25. So after correction of the hypoglycemia with dextrose, the patient's neurological status completely reversed. And the one thing we can understand from this is that the most important common causes should be ruled out before confirming the diagnosis of a stroke or proceeding with further investigation. So the patient had a history of right-sided weakness, CVA, previously, and the neurological deficit completely improved, but the extensor plantar was persisting in the right side. That was the reason for right-sided extensor plantar. So coming to the third reason for why clinical localization is still impressive, it is basically the health economics, unnecessary investigations adding on to the overall health burden in terms of finance. And also medico-legal concern. If without proper clinical examination and without clinical judgment, if the patient gets an unwanted treatment or undergoes an unwanted investigation and finally ends up in a complication that can arise, there is a possibility of medico-legal issues. So coming to localization of neurology in general, localization in neurology is just answering three basic questions. What is the exact neurological deficit? Where is the reason, or where is the site for this neurological deficit? And why is there a neurological deficit? For answering the first question, what is the exact neurological deficit? We need to have a complete history and detailed neurological examination. And if we are missing any neurological deficit in the history as symptom or in the examination as a sign, we may end up localizing the lesion to a different site, which will be wrong. And the next question being, where exactly is the lesion? That is an anatomical localization. So where exactly in the neuraxis the lesion that could produce this set of symptoms or signs? The third question is why. The third question is why, and this question is particularly answered by the onset and progress of the illness. If we are having a chronic progressive nature, we should be suspecting a neoplastic or a degenerative condition. Subacute onset, we should be suspecting an infection or a demyelinating cause. And sudden cause, sudden onset neurological deficit, we should be having a suspicion of a vascular accident. So this is the usual dictum in localization in neurology. How it is different in a case of stroke? Because we already suspect a stroke first when the patient comes with sudden neurological deficit. So we already have the answer to the question why. Then we proceed with what is the exact neurological deficit so that we can localize it to a arterial territory. So we already have the answer to this question why in case of stroke. So when to suspect a stroke? So any sudden neurological deficit without any obvious history of trauma, we should be having a suspicion of stroke. And it is always important to rule out the stroke mimickers. So the neurological deficit can be anything. It can be motor weakness, it can be sensory loss, it can be vision loss, it can be behavioral change, it can be alteration in the consciousness. All this can be a stroke. So, but it is always important to exclude the stroke mimickers. Coming to the common stroke mimickers, the common stroke mimickers are seizure with postictal neurological deficit, complicated migraine or atypical variants of the migraine where we can have hemiplegic migraine, ophthalmoplegic migraine, retinal migraine where the patient can have vision loss, and infections, the systemic infections as well as the neurological, nervous system infections like meningitis, encephalitis, all can present with neurological deficit. The fourth mimicker is brain tumor, especially in the setting where the tumor or the space occupying lesion is complicated with an internal bleed or development of edema surrounding the tumor, the patient can present acutely. There can be toxic and metabolic disorders which can mimic a stroke. The most common toxic cause will be alcohol-related neurological deficit, acute alcohol intoxication, alcohol withdrawal, all those can present with neurological deficit. Metabolic disorders, the most common we encounter in our ED are hypoglycemia and hyponatremia, along with other metabolic causes like hepatic encephalopathy, uremic encephalopathy, all these can present with neurological deficit. Another common stroke mimicker is positional vertigo, which can present similar to a cerebellar syndrome. And last but not the least, we have to always think of conversion disorder, especially in a setting when the neurological deficit is not pointing or cannot be localized to a particular arterial territory or particular site in the neuraxis. So these are the common stroke mimickers. Localizing the type of stroke or identifying the type of stroke. Basically, we have two types of stroke, that is ischemic stroke and hemorrhagic stroke. Ischemic stroke can be further classified into thrombotic and embolic type. Coming to the thrombotic type of ischemic stroke, that is usually present as a wake-up stroke. The pattern of progression will be in a stuttering or stepladder pattern. And usually a single vascular territory is involved, and the patient can have vascular risk factors like diabetes, hypertension, dyslipidemia, smoking, etc. Coming to embolic variety of ischemic stroke, again the patient's presentation will be, the patient can have maximum deficit at the onset, and sometimes the patient can have rapid improvement in symptoms if the emboli is getting dislodged. One thing to remember in embolic stroke is the patient can have symptoms in single or multiple arterial territories, and especially in a setting of bilateral stroke, one should always consider the possibility of an embolic stroke. The risk factors can be atherosclerotic risk factors in a case of artery to artery emboli, and the risk factor can be a cardiovascular risk factors like atrial fibrillation, mechanical valve, valvular heart disease, infective endocarditis, all these can lead to cardioembolic stroke. And the thrombotic stroke, which usually comes as a wake-up stroke, whereas embolic stroke usually happens in activity. Coming to hemorrhagic stroke, the usual progression will be rapid progression or maximum deficit at the onset, and the focal signs may not be localized to a single arterial territory because the bleeding enters into other parts of the brain, causing dysfunction in other areas of the brain. So it is very difficult to localize a hemorrhagic stroke to a certain particular arterial territory. Altered consciousness is common. Seizures may occur because blood is very irritant and can cause seizures. The usual risk factors are hypertension, trauma, bleeding diathesis, old age, etc. And just like embolic stroke, hemorrhagic strokes are also common during activities rather than wake-up strokes. So now we are coming to more detailed into the topic of localization. For that, we need to have a better understanding of the blood supply and functional anatomy of the brain. Blood supply and functional anatomy of the brain. First, we are dealing with the basics of blood supply, but we will be going in an integrated manner. Like we will be integrating the blood supply and functions of different aspects of the brain together, so that it will be easy for us to remember the arterial territory and which functions will be affected. So coming to the blood supply of the brain, blood supply of the brain basically is by two main arteries, the internal carotid arteries and the vertebral arteries. Internal carotid arteries arises from the common carotid bifurcation. They run upwards anteriorly and enters the skull through the carotid foramen. And this is the internal carotid artery picture. We can see the two internal carotid arteries arising from the carotid bifurcation, running anteriorly in the neck and finally entering the cranium through the carotid foramen. And once they enter the skull, the green arrow shows the internal carotid artery. They divide into two major branches. The first branch or the large branch being the MCA or the middle cerebral artery, and the second branch being the ACA. So internal carotid artery with its main branches, that is MCA and ACA, constitute to the anterior circulation. This is the anterior circulation. Internal carotid dividing it into the main branches MCA and ACA constitute the anterior circulation. So the anterior circulation mainly give blood supply to most of the supratentorial structures, or the structures above the tentorium cerebelli. So except the occipital lobe, most of the supratentorial structures except the occipital lobe is supplied by the anterior circulation. So coming to the next artery which is important is the vertebral artery. The vertebral artery arises from the first part of subclavian artery and they run upwards to the transverse foramina of the cervical vertebra and finally enters the cranium through the foramen magnum. So we can see the two vertebral arteries, and after entering in the foramen magnum, they finally join to form the basilar artery, and the basilar artery finally dividing into two terminal branches of posterior cerebral artery. So the vertebro-basilar system along with the posterior cerebral artery constitute the posterior circulation, and the posterior circulation mainly concerned with the blood supply to the occipital lobe, the brainstem as well as the cerebellum. And one more thing to add here is the anterior circulation and posterior circulation is connected by the two small arteries called posterior communicating arteries, finally making it a circle, and we have the circle of Willis, which is concerned with the entire blood supply of brain. Now coming to the functional anatomy and regional blood supply of brain. So we will be seeing the brain under four headings: the cerebral cortex, the subcortex, brainstem and cerebellum. So coming to the first part, that is cerebral cortex. So cerebral cortex, we can see the cerebral cortex is divided into different lobes. So we have the frontal lobe, then we have the parietal lobe, occipital lobe and the temporal lobe. I have specified two areas, the motor cortex and the sensory cortex, as separate entities, but one should always understand the fact that motor cortex is part of frontal lobe and sensory cortex is part of the parietal lobe. Why it is mentioned separately is because they are very commonly affected in the stroke. The patient can have muscle weakness as well as sensory symptoms, which are more common symptoms in stroke. That's why I have given it in a separate emphasis. So if the frontal lobe is affected, the patient can have symptoms or signs of executive dysfunctions like the thinking, planning, organizing, behavioral problems, emotional problems. All these can be affected in frontal lobe lesions. And if motor cortex is affected, obviously the movement will be affected. Sensory cortex, the sensations can be affected. Parietal lobe is concerned with the perception, making sense of the world, arithmetic, spelling, all this can be affected. And there can be difference in the manifestations of dominant and non-dominant lobe as well. Occipital lobe is mainly concerned with vision and temporal lobe with memory, understanding of language. So any dysfunction in or any stroke in any of these areas can lead to abnormalities in each of the functions. So one thing regarding motor cortex is that it is, if you can see between the motor cortex and sensory cortex, we have the central sulcus, and it is the precentral gyrus where the primary motor area is situated, and primary motor area along with the premotor area, which are both parts of frontal cortex, constitute the motor cortex. But one thing to remember here is that only 60 to 70% of the corticospinal or corticobulbar, that is a motor tract fibers, arise from the motor cortex. So where does the remaining 30 to 40% fibers arise? The remaining 30 to 40% of the corticobulbar and corticospinal tract arise from the sensory cortex. So not only frontal lobe lesions, even parietal lobe lesions can also give rise to weakness. The reason is this. So coming to the cerebral cortex blood supply, if you are looking at the lateral view, we can see the superior aspect of frontal lobe, andromedial aspect of frontal lobe, and the superior aspect of the parietal lobe is supplied by the anterior cerebral artery, and rest of the frontal lobe, parietal lobe and superior part of temporal lobe is supplied by the middle cerebral artery. Posterior aspect of parietal lobe, the whole of occipital lobe and inferior aspect of temporal lobe by the posterior cerebral artery. Coming to the medial view, most of the medial aspect of frontal lobe and parietal lobe is supplied by the anterior cerebral artery. Rest of the parietal lobe and the occipital lobe and the medial aspect, most of it is of the temporal lobe is also supplied by the posterior cerebral artery, and a small portion of the medial aspect of temporal lobe anteriorly supplied by the middle cerebral artery. Coming to the inferior view, we can see the medial aspect is supplied by the anterior cerebral artery, lateral aspect by the middle cerebral artery, and the posterior aspect by the posterior cerebral artery. So, as I already told, the most common area involved in cortical stroke are the motor cortex and sensory cortex. So we will have a better understanding of the structures or how the body's sensory system and the motor system is represented in the motor and sensory cortex. The left side it is showing the motor and sensory homunculus, whereas the right side it is showing the blood supply of each area. So if we are seeing the medial most aspect, the medial So if we are seeing the medial most aspect which is supplied by the anterior cerebral artery, we can see it is representing the lower limb, both in the motor area as well as in the sensory area. So any issue with the anterior cerebral artery can involve predominantly the lower limb. And if we are seeing the lateral aspect mainly supplied by the middle cerebral artery, the representation in the motor cortex is the upper limb and face. The same happens with the sensory. Upper limb and face is represented in the area supplied by middle cerebral artery. So middle cerebral artery lesions can mainly give rise to symptoms affecting the upper limb and face. So this is very important with respect to the localization. So lower limb predominant weakness with the minimal or no involvement of upper limb and face, one should suspect an anterior cerebral artery involvement. Upper limb and face predominant lesions with minimal or no involvement of lower limb, one should suspect a middle cerebral artery lesion. So that was all regarding cortex. We are coming to subcortex. Subcortex mainly involve the subcortical white matter, which consists of different tracts, connections, fibers and association fibers. All the nerve fibers constitute the subcortical white matter. And then we have some subcortical nuclei or subcortical gray matter which involve the thalamus, hypothalamus, basal ganglia, amygdala and hippocampus. So first coming to the subcortical white matter. Subcortical white matter, the one part of the tract, all the tract coming and going to the cerebral cortex, finally before entering the brainstem comes through a very compact area, and even a small lesion in the compact area can give rise to a very marked weakness or very marked neurological deficit, and that compact area will be internal capsule. So going superiorly, the fibers where the ascending and descending fibers are little more wide apart, we have the corona radiata. And further going superiorly, most of the clinical localizations which we study in the UG or even in the PG time, we have localization in the internal capsule and then we have localization in the corona radiata. And finally, the next site of usual localization is the cortex. So This leads to seeing an unfamiliar term in the CT and MRI brain reports when a fresh intern or PG starts his clinical practice in medicine. And that area, the part of central white matter which is most close or most adjacent to the cerebral cortex is the centrum semiovale. So these are the major areas where one can get a stroke. Considering the subcortical white matter, that is centrum semiovale, continuing below as corona radiata, and before entering the brainstem we have the internal capsule. So for better understanding, one thing we need to understand here is the blood supply of centrum semiovale and corona radiata. The part of white matter which are close to the cerebrum is supplied by the same artery which is supplying the overlying cortex. I am repeating that sentence. The centrum semiovale and corona radiata, which are part of the white matter close to the cerebral cortex, are supplied by the same arteries which supply the overlying cortex. So for understanding the blood supply of deeper structures, we will have an axial section of the brain at the level of internal capsule. So here we can see the medial aspect of frontal lobe is supplied by the ACA, the lateral aspect being and the subcortical white matter being supplied by the middle cerebral artery, and the medial aspect of the temporal lobe as well as the occipital lobe supplied by the posterior cerebral artery. Then we can also see the thalamus. This is the thalamus being supplied by the deep branches of PCA and parts of the basal ganglia. So caudate head is supplied by deep branches of ACA. The putamen and caudate nucleus is supplied by the deep branches of MCA. In this picture we can also see the internal capsule, but it will be very difficult to understand the blood supply of internal capsule from this picture, so we will be dealing in that in detail. So we further proceed with seeing the brain in a coronal section. There also we can see the blood supply, the medial aspect of frontal and parietal lobe being supplied by the ACA, lateral aspect by the MCA and its branches, the occipital lobe and medial temporal lobe by the PCA, again thalamus by the deep branches of PCA. So coming to internal capsule, where the fibers are very compact, where the fibers are very closely packed, the blood supply. This is the structure of internal capsule. We can see it has an anterior limb, genu and posterior limb. So this is the same internal capsule we can see here. When we are looking at the blood supply, we can divide the internal capsule basically into an upper superior part and an inferior part, and whole of the superior aspect of internal capsule, that is the anterior limb, genu and posterior limb of internal capsule, superior aspect is supplied by deep branches of middle cerebral artery. Superior aspect is supplied by deep branches of middle cerebral artery. The genu lower, for the anterior limb, the inferior aspect is supplied by branches of anterior cerebral artery. And for genu, there are branches from posterior communicating artery or direct branches from the ICA supplying the inferior aspect of genu. And for the posterior limb, inferior aspect of posterior limb, we have branches from the anterior choroidal artery. And if we are looking at the tracts, ascending and descending tracts going through the internal capsule, we can see most of the important structures are going through the posterior limb. We can see the corticospinal tract descending through the posterior limb. We can see the spinothalamic tract descending through the posterior limb. So a lesion involving the posterior limb of internal capsule can give rise to manifestations of motor and sensory manifestation, and that will be even a small lesion can lead to a very more amount of neurological deficit. That is the peculiarity of lesions in internal capsule. So the genu will be having fibers of the corticobulbar tract, the face and all those, and that is most important in our case. And also remember, if we are seeing the descending ascending tract, we can see optic radiation coming in the retrolentiform part. So patient can also have hemianopia if the retrolentiform part is affected. So after internal capsule, we have the brainstem and cerebellum. So again, we have vertebral artery. Both the vertebral artery uniting to form the basilar artery and finally dividing to form the posterior cerebral artery. So, certain areas of the occipital lobe and certain areas of midbrain are supplied by the posterior cerebral artery. Rest of the brainstem and cerebellum is supplied by the vertebro-basilar system, branches from the vertebro-basilar system. So, coming to a better understanding of brainstem lesions, occipital lobe, the functions we have already seen. The brainstem is mainly having three important structures. The brainstem has cranial nerve nuclei, the brainstem has ascending and descending tracts, also the brainstem has reticular activating system. So the most important aspect with respect to ischemic stroke is that here the long tract corticospinal, along the only the corticospinal tract is shown in this picture. Thank you. Sorry. Only the corticospinal tract is shown in the diagram. So we can see after the internal capsule, the corticospinal tract enters the midbrain, then the pons, and then the medulla. And after the medulla, more than 80% of the fibers decussate to the opposite side. So if there is a lesion in the brainstem, that is a lesion in the midbrain, a lesion in the pons, or lesion in the medulla, the patient, I told the important structures in the brainstem are cranial nerve nuclei, the ascending and descending tract, and reticular activating system. So the patient can have ipsilateral cranial nerve paralysis or ipsilateral cranial nerve findings along with contralateral weakness. So ipsilateral cranial nerve abnormality along with contralateral long tract signs. The long tract being either the corticospinal tract or the two ascending tracts, that is the spinothalamic tract or the dorsal column. So ipsilateral cranial nerve findings along with the contralateral long tract sign, we should suspect a brainstem abnormality. And if we are considering the rest of the areas of the brain, cerebellum is mainly concerned with coordination and movement. So there can be abnormalities in the coordination in the same part of the body. Cerebellum controls the same part of the body. So the patient can have ataxia and cerebellar dysfunction affecting same part of the body if the cerebellum is involved. So we have seen the functional anatomy and blood supply of different parts of brain. Now we are going to localize the vascular territory, localizing the vascular territory. So we can approach the localization of vascular territory in three different headings, that is ischemic stroke in the anterior circulation, ischemic stroke in the posterior circulation, and hemorrhagic stroke. So before going any further, we have already seen the anterior circulation comprises of internal carotid artery along with its two major branches, that is ICA, MCA and the ACA. So before proceeding further, we will have a closer look at the MCA. So the internal carotid artery divides into the anterior cerebral artery and the middle cerebral artery. And the middle cerebral artery then gives us this deep penetrating branches or the lenticulo-striate arteries. Then it divides into a superior division and an inferior division. This is the basic division and basic branches of the middle cerebral artery. So what happens to the patient if superior division of middle cerebral artery is involved? So we have already seen the part of cerebral cortex supplied by the middle cerebral artery, and in that part, this particular area, the area shaded in pink, is supplied by the superior division. This is the area of the cerebral cortex supplied by the superior division of MCA. So we know the structures which are present in this area. The first area, this marked by green, is the motor cortex, especially the fibers reaching the upper limb and face. The part of motor cortex representing the face and upper limb, that is this green structure. So it can give rise to contralateral hemiplegia, face and upper limb more involved than the lower limb. So coming to the next structure in that area supplied by the superior division of MCA, that is the sensory cortex. So again the patient can have cortical type of sensory loss, that is hemisensory loss, and more face and upper limb will be involved. Coming to the third important structure in that area is the frontal eye field, which is anterior to the motor cortex is the frontal eye field, and when the frontal eye field is affected, the patient can have conjugate gaze palsy, where the patient look towards the side of lesion. And the next important structure in that area supplied by superior division of MCA is the motor speech area is in the inferior frontal gyrus. So the patient can have expressive aphasia or Broca's aphasia if the dominant lobe is affected. So that is the clinical manifestations of the MCA superior division infarct. Now we can see this is an MRI image showing the MCA superior division infarct. We can see the anterolateral aspect of the frontal lobe along with parietal lobe, including the subcortical white matter is infarcted. This is MCA superior division infarct. So coming to MCA inferior division. So this is the area shaded in pink is the area supplied by the inferior division of the middle cerebral artery. So one thing we have to remember is that the motor cortex and the sensory cortex are spared. The motor cortex and sensory cortex are spared. So there won't be any motor weakness or sensory loss in a case of inferior division of MCA infarct. And the main structures which are involved in inferior division of MCA infarct are the main being the patient can have optic radiation abnormalities. Some part of the optic radiation goes through the parietal lobe as well as the temporal lobe. So the patient can have optic radiation abnormality, and mostly if one of the parietal lobe optic radiation is affected, the patient can have inferior quadrantopia, and if the temporal lobe fibers are affected, the patient can have superior quadrantopia. And mostly we can get, and if both the optic radiation fibers in the parietal and temporal lobe are affected, we can even get a hemianopia. But mostly we get a superior quadrantopia in the inferior division MCA infarction. So contralateral visual field defect, homonymous superior quadrantopia, pie in the sky, that is an area of quadrantopia. The common term is pie in the sky type of anopia, or rarely the patient can also have a hemianopia when both the optic radiation fibers in the parietal lobe as well as the temporal lobe are affected. The next important structure in the area supplied by inferior division is the Wernicke's area, that is the sensory speech area. So if it is affected, the patient can have Wernicke's aphasia, especially in dominant lobe hemisphere lesion. Since the parietal lobe is affected, if it is a non-dominant parietal lobe lesion, the patient can have abnormalities in visuospatial skills, behavioral disturbance. All this can be seen in non-dominant hemisphere lesion. So these are the usual manifestation of MCA inferior division. So coming to another MRI showing the MCA inferior division infarct, we can see the lateral aspect of the parietal lobe as well as the infralateral area of the temporal lobe is affected. So this is an infarct along with the subcortical white matter in MCA infarct showing MCA inferior division infarct MRI image. So coming to MCA stem occlusion. So MCA stem occlusion is basically the complete side supplied by the superior division as well as the inferior division is gone. So we can have all the clinical manifestation we have discussed so far. We can have contralateral hemiparesis and hemisensory loss with predominant upper lobe and face involvement. Patient can have contralateral gaze palsy due to frontal eye field involvement. Contralateral visual field defects along again homonymous hemianopia or quadrantopia. Patient can have global aphasia because both the sensory speech area as well as the motor speech area is gone, and there can be altered sensorium and seizure. This is an ideal finding because especially such a MCA stem occlusion stroke will be a very large stroke. There can be surrounding edema which can lead to altered sensorium and seizures. Coming to the third important branches of MCA, that is the lenticulostriate artery. We have already seen the lenticulostriate arteries arising from the MCA. So it basically supplies the basal ganglia as well as the internal capsule. So we have already seen how the fibers are arranged in internal capsule. So even a small lesion can lead to a very large neurological deficit. So usually the patient can have contralateral hemiparesis and contralateral hemisensory loss, and the hemiplegia will be dense. So this is an MRI image showing the infarction of the lenticulostriate branches of MCA affecting the the internal capsule as well as the basal ganglia region. So coming to ACA occlusion. So one thing regarding ACA is, unlike the MCA, the ACA was a very good collateral circulation by the anterior communicating artery. So even if one of the ACAs is completely infarcted, the area supplied by that ACA will get perfusion from the opposite side because of the good collateral circulation by the anterior communicating artery. This is one difference of ACA from MCA. So isolated ACA infarctions are very rare. But what if we get an isolated ACA infarction? So in the figure, we have already seen the part of brain being supplied by the ACA. It was mainly the medial aspect. So if we see the medial aspect, which the most important structures are, the structure marked in green is the paracentral lobule, and then we have the area marked in pink, which is the supplementary motor area, and then we have the area marked in blue. This is the prefrontal cortex. All this area is supplied by the anterior cerebral artery, and in isolated unilateral anterior cerebral artery lesion, we can get manifestation of all these. So what is the function of paracentral lobule? So the paracentral lobule is mainly concerned with the sensory and motor functions of the lower limb. So we can get contralateral predominant lower limb weakness with minimal or no involvement of upper limb and face, along with cortical sensory loss in the lower leg. That will be the manifestation of loss of blood supply to the paracentral lobule. So coming to the next area, that is supplementary motor area, where we have an additional area, micturition inhibitory center. So the patient can have loss of cortical inhibition of bladder control, and the patient can have urinary incontinence. Along with the supplementary motor area also have some important aspect in the speech production and understanding. So the patient can also have speech abnormality when the supplementary motor area is gone. The next thing will be the prefrontal cortex, mainly concerned with the major frontal lobe functions of personality, behavior, and all those aspects. So if the prefrontal cortex is affected, patient can have personality and decision making abnormalities. That is isolated ACA occlusion, how it will manifest. So this is again another diffusion weighted MRI image showing the ACA infarct. The medial aspect of the frontal lobe is gone, along with the medial aspect, some part of the medial aspect of the parietal lobe also. So this is ACA territory infarction. Now coming to the last part of anterior circulation infarction, that is ICA occlusion, internal cerebral artery complete occlusion. And one thing regarding the internal cerebral artery occlusion is that the clinical features can vary widely based on the collaterals as well as the mechanism of stroke. So mostly when the ICA is getting stenosed, due to atherosclerosis, the patient may get enough time for the development of collaterals. So when there is significant collaterals developing around the ICA, even with more than 90% occlusion, thrombotic occlusion of the ICA, the patient may not have any symptoms. That is the significance of type of occlusion. But if it is an acute occlusion as in the case of embolism, the patient can present with the devastating symptoms. So embolic occlusion will be symptomatic, affecting the MCA territory, ACA territory, or combined symptoms, and patient can have symptoms of loss of vision also due to emboli extending into the ophthalmic artery. So this is an MRI image showing a combined ACA-MCA territory infarction. We can see all the area supplied by the ACA and MCA have infarcted. Only the area supplied by the PCA, is spared. That is internal carotid artery complete embolic occlusion. So what is the significance of occlusion, or what is the significance of thrombotic stenosis of the internal carotid artery? A stenosed internal carotid artery can give rise to watershed infarction. How? Watershed infarctions are, the watershed area means the area where the two arterial territories meet. So we can have multiple watershed areas in the anterior circulation. First between the watershed area between the AC and MCA, and then we have another watershed area between the MCA and the PCA. And these two ribbon-like watershed areas where the superficial and the deep branches meet. So imagine the patient is having a near total thrombosis of the internal carotid artery. The blood supply to these area is already very much compromised in the anterior circulation. To that, an added insult by a shock or a hypotension, the patient will be having complication, the stroke in this, again decrease in blood flow leading to stroke in the watershed infarction, leading to infarctions in the watershed area. So these are MRI images showing infarctions in the watershed area, the PCA, MCA territory watershed infarct, and here we have multiple watershed infarct in the bilateral lobe. So these patients who have significant narrowing of the internal carotid artery are very prone for watershed infarctions. So that was all about anterior circulation. Coming to posterior circulation, instead of studying detail regarding what are the structures and different detail in blood supply of the posterior circulation, only few points are relevant clinically for localization as well as to diagnose a posterior circulation stroke. The most important structures in the posterior circulation are these 5 structures. The reticular activating system concerned with the consciousness, cerebellum concerned with the coordination, cranial nerve nuclei, the different functions of cranial nerve nuclei we already know, ascending and descending tracts, and the occipital lobe. So any of these structures can be affected in the posterior circulation stroke, giving rise to different set of symptoms. So especially in case of brainstem strokes, the patient has symptoms of cranial nerve abnormality. This can be diplopia, dysarthria, facial weakness due to 7th nerve involvement, and the patient can have facial numbness due to 5th nerve involvement, and the patient can have dysphagia due to 9th involvement. So these are symptoms of these are cranial nerve symptoms due to brainstem involvement. And the next is patient can have hemiparesis and hemisensory loss. These are due to the involvement of long tracts, that is corticospinal tract, spinothalamic tract, and dorsal column. So hemiparesis and hemisensory loss again can be a manifestation in the posterior circulation. Then the patient can present with hemianopia due to posterior cerebral artery involvement, occipital lobe infarction can give rise to hemianopia. Then there can be ataxia, vertigo, and vomiting due to the involvement of cerebellum or the vestibular system. Again, in cerebellar infarction as well as in brainstem infarctions affecting the medulla. Next important manifestation of posterior circulation stroke is the loss of consciousness due to involvement of the reticular activating system. So all this localization, all the arterial territory, everything which we have just discussed is only important in case of ischemic stroke, that is either embolic or thrombotic stroke. These are not significant in a case of hemorrhagic stroke. So why? The clinical manifestation usually does not confine to a vascular territory because the blood supply to the area supplied by the artery is compromised. Along with that, blood can seep into other areas of the brain and damage those areas as well, resulting in clinical manifestations which may not be confined to a single vascular territory. Loss of consciousness is very common, and the most common locations for a hemorrhagic stroke are the putamen, internal capsule, thalamus, lobar bleeds, cerebellum, and pons. And most common risk factor will be hypertension, which will be uncontrolled. And non-hypertensive risk factors for intracerebral hemorrhage include amyloid angiopathy, especially in old age patient, resulting in lobar bleed, bleeding diathesis, patient taking anticoagulants, vascular malformations, etc. The one thing we have to remember is all the localization principles we have discussed so far is only applicable for ischemic stroke. The clinical localization to a vascular territory in intracerebral hemorrhage is mostly errorsome. So that's all regarding clinical localization of stroke. Just to conclude or summarize the important points, the most important aspect which we have discussed today are suspect stroke in every case of sudden onset neurological deficit, rule out all the mimickers of stroke, and always take relevant history and quick targeted examination, because especially in a emergency setting, we want to give the patient thrombolytic therapy or necessary treatment for the patient. We cannot go on doing Rinne and Weber test in a case of stroke. So it should be a quick targeted examination, and also always try to identify vascular territory from the clinical symptoms. So then we can proceed with investigations as well as treatment. So that's all regarding clinical localization of stroke and its significance. Thank you all for the patient listening. Thank you.
Thank you, sir. Now I would request Dr. Paul G. Alapat to hand over the token of appreciation to Dr. Arjun. Moving on to the third session, we have CT versus MRI in stroke, which will be dealt with by Dr. Kahari Ahmed Saif, consultant in radiology. And I request Dr. Kevin Araujo, Head of Department of Radiology, to chair the session.
Slide change. Good morning all. I'm Dr. Kahiri Ahmed Saif, Senior Resident from Department of Radio Diagnosis. So today my topic is CT versus MRI in stroke. So before coming into my topic, I would like to talk about a concept. It is about penumbra. Okay, so this is an image of a solar eclipse. So what you can see is in the center, you can see a dark area. So compare it with our patient, you can consider this dark area as the infarct core. But surrounding it, you can see a rim of tissue. So this tissue is ischemic, but if left alone, it will go into the infarct core. So the infarct core will be expanding and the penumbra will be reducing with respect to time. So the crux of medical imaging is to identify the penumbra and as early as possible so that treatment can be given and maximum penumbra can be salvaged. So yeah, this is another depiction of the infarct core and the surrounding penumbra. So if the patient actually comes within 4 hours of the onset, there would be a larger penumbra. But however, as time passes more than 4 hours, the area of the penumbra will come down. But this depends upon collaterals, whether they are present or not. So each patient may not progress with the same rate. So we'll come to that later. So now I'll be discussing about the imaging tools which are available in ischemic stroke. So first is the non-contrast CT, then there will be angiography and perfusion with both MRI and CT. So the goal of a non-contrast CT is to rule out a hemorrhagic stroke. So you will have to do a non-contrast CT in the as early as possible so that you can decide whether a thrombolytic therapy, the intravenous tissue plasminogen activator, can be used or whether it is contraindicated. So then the other goal is to detect an stroke mimics or alternative etiology for neurological deficits and to look for a large infarct. So I'll show you an image. This is an axial CT section, plain CT. This is an MCA infarct. You can see that there is a hypodense area in the right frontal and parietal lobe with loss of gray white matter differentiation. So what we see here is cytotoxic edema. You can see that there is a mild pressure effect. This can cause midline shift and also the effacement of sulci. So this is how an ischemic stroke will look. And you can, in case there is a hemorrhage, you can see it as a hyperdensity or a bright area. In addition to that, there are certain subtle signs of stroke which can be identified in plain CT. You can see this is the hyperdense MCA sign. Okay. and seen in occlusion of the MCA at this level. This is the M1 horizontal segment of the MCA at the Sylvian fissure. And this is the MCA dot sign, the M2 segment or the insular segments of the MCA. If there is thrombus there, you will be able to see a hyperdensity, which is the thrombus inside the vessel, what we are seeing. Now, this is very subtle. If you can see on the left, compare the left and the right side, you can see the insular cortex here. You can, there is a differentiation between the gray and white matter on the right side, which is maintained. But on the left side, there is loss of it. You can see that there is hypodensity and there is loss of gray-white matter differentiation. This is the loss of insular ribbon sign. The area here, the basal ganglia and the overlying insular cortex, they will get the supply from the lenticular striate branches, predominantly for the basal ganglia and the internal capsule. But thing is, these lenticular striate branches are end arteries. So if there is any occlusion here, so the progression will be quicker when compared to an occlusion in the M2 segment, because there will be collaterals in this supply. So this is another axial CT image showing a loss of definition of the lentiform nucleus on the left side, seen in an MCA in fact. So coming to aspect score. So this is one scoring criteria which was developed. It is to assess and communicate the extent of early ischemic changes in a non-contrast CT. So what we do is, we take two sections in the NCCT. First, along the basal the section across the basal ganglia, and one section above it. And we will divide the MCA territories into 10. In the inferior section, 3 anterior, lateral and posterior cortices supplied by the MCA, then the caudate nucleus, the internal capsule, lentiform nucleus, and the insular cortex. Each of these locations will be given 1 point each, and similarly the 3 points each in the upper segments, upper section. And if any of the sections are affected, you will remove 1 point. So out of a total of 10 locations, you remove 1 for each affected. So studies have shown an increased risk of hemorrhage and poor clinical outcome if the aspect score is 7 or less. So not just that, in earlier studies had shown that this intravenous tissue plasminogen activator will not be effective or will show complications if the aspect score is less. But based upon the ECAS-2 and the early NINDS trials, it was shown that TPA, it is independent. Actually, there won't be any modification of the TPA with low aspect score. And currently, the AHA guidelines recommend a mechanical thrombectomy only if the patient has an aspect score of greater than or equal to 6. So, an aspect score will guide in a mechanical thrombectomy. However, further trials are needed to see whether mechanical thrombectomy can also be done if the aspect score is less than 6. So, also there is a study, there is an automated system which can calculate the Alberta's stroke score, and it is found to be as effective or quicker in getting to the Alberta score and guiding treatment. So, so we've discussed about NCCT brain. So, one more thing is, what we saw was in the first image was in cytotoxic edema. So to exclude tumors in the NCCT brain, you will see an edema called vasogenic edema. In that, there will be the gray white matter which is maintained. So what we are seeing is a loss of gray white matter differentiation. So next thing what you have to do is you have to look at the site of occlusion. The extent of the occlusion, whether a mechanical thrombectomy can be done. Suppose if it's in the distal segments like M3 or maybe M2, M1, it will be, it is possible, but M1 and M2 segments are also possible for mechanical thrombectomy, but for the distal segments it will be difficult. And also we have to look for collaterals. As I had discussed before, if the area of interest has a larger collateral supply, then the patient will progress at a lower rate, at a slower rate. So, access. So what we are doing is, we are taking the angiogram of both the cerebral and the neck vessels. So, we need to know the anatomy of the aortic arch and the carotids arising from it, because the interventionalist has to reach the occlusion. For that, he needs to know from where he has to access the site. And finally, perfusion imaging to identify the penumbra and the infarct core. So, I'll first talk about CT angiography. It provides valuable information relating to vessel occlusion and degree of collateralization. So what we see is a CT source image. You can see here, this is a plain CT scan, and NCCT at the level of the, across the level of the basal ganglia. You are not seeing anything significant in a plain CT. However, in the same patient, on doing a CT angiogram, you can see the area of hypoenhancement almost in the left frontal, parietal, temporal, and up to the parietal lobe, and you can see the difference it makes, and you can also see that there is the vascular, the enhancement, the vessels are sparsely located here. You can also have an idea about the collaterals. And with CT angiogram, you can also reconstruct the image into a 3D. And now, this is the same patient. You can see that even though in spite of a plain NCCT showing a normal showing normal, you can find that the MCA is occluded at the horizontal segment, M1 segment. And thrombectomy could be done. And this is a diffusion weighted imaging, MRI. So you can see that the CT angiogram with the source image is correlating with the diffusion restriction in an MRI. You can see that the area is similar. So this is that same patient. This was the contrast CT done, non-contrast CT done at day 5. You can see that the at day 1 the source image of the angiogram corresponded to the final infarct location at day 5. So when you combine a CT, non-contrast CT, a CT angiogram, and also perfusion, you can assess the acute stroke with a quality comparable to that of a stroke MRI. And you can also apply an aspect score to the source image data of the angiogram, and using a threshold of 7 or less, it has been demonstrated to be more sensitive than NCCT for final infarct prediction. So, and also this helps in misclassifying patients according to the aspects while using NCCT. Coming to CT perfusion imaging, so what we are seeing is we are calculating the contrast, how it is reaching a tissue and how it is leaving it. And then we are taking a graph. This is the time attenuation graph. So what we are seeing is when the contrast enters the tissue, it will be bright in a CT perfusion. So with respect to time, you can see that the tissue in question shows increased enhancement initially, and when it washes out. So certain parameters are considered while we do perfusion imaging. So the goal of perfusion imaging is to identify penumbra. Let's keep that in mind. So what we do is few parameters are identified in perfusion imaging using this graph, this curve. One is time to peak, the time taken from for the attenuation values to reach its peak. The cerebral blood flow. Flow is the rate at which the blood is entering the tissue. So that is the slope of this graph, and the volume, the cerebral blood volume, is the area under this graph, and the mean transit time is the time taken for the contrast to stay in the tissue in question. So we have cerebral blood flow, cerebral blood volume, mean transit time, and time to peak. So based upon these 4 parameters, we can actually identify the penumbra and the core infarct. You can see that in a penumbra, in both penumbra and in an infarct, you can see that what is red is like elevated. So mean transit time and time to max will be elevated. And the cerebral blood flow, the rate at which blood moves into the tissue, will be reduced in both a penumbra and an infarct. However, how do we actually differentiate between a penumbra and an infarct is the cerebral blood volume. You can see here that cerebral blood volume will either be normal or increased, and here it is reduced. So what we see in these four images are that of a penumbra, and this is an infarct, core infarct, which is non-salvageable tissue. Okay, so this is one. This is a set of images of what I have on my top is the plain CT showing just a hypodense area in the right frontal lobe, suggestive of an infarct. And also CT angiogram was done, and it also correlated with the plain CT. But when we did when a CT perfusion was done, you can see that there is an increased mean transit time also in the left parietal lobe, and there is a corresponding reduction in cerebral blood flow and cerebral blood volume. And on correlating with the diffusion weighted imaging or MRI, you can see a diffusion restriction which says that it's an acute, it says that it is an infarct. So despite of an infarct being missed in both a plain CT and an angiogram, a perfusion was able to pick up the infarct. And it was confirmatory in the diffusion weighted imaging. So aspect score can also be used in perfusion scanning, and it has been shown to be predictive of the clinical outcome. So specifically using cerebral blood volume data and utilizing aspects threshold of 8 has been shown to predict patients with major neurological improvement after 3 months. Coming to MRI and stroke imaging, the traditional MRI would take hours for the findings to come, that is the T1 and T2 weighted imaging. However, the diffusion weighted imaging will show findings within just minutes of infarct. So what we see is a diffusion restriction. I'll show you. Okay, so this is a diffusion, these two are diffusion weighted imaging, are components of the diffusion weighted imaging. This is the DWI, diffusion weighted imaging map, and this is the corresponding apparent ADC map. So what this sees is the Brownian movement of water molecules, how randomly they are moving. So with infarct, what happens is the sodium potassium ATPase inside the cells will stop working. So all the water will move inside the cells, and the extracellular water will come down. So there will be a restriction to diffusion of water in the extracellular component. That is what we see in a diffusion weighted imaging. So along with diffusion weighted imaging, you can do a T2 star weighted imaging or an SWI. It is also to rule out an intracerebral hemorrhage, and MR angiogram for thrombus identification, and also perfusion weighted imaging. And diffusion weighted imaging can be taken very quickly using echoplanar imaging techniques. So coming to MR angiography, MR angiography can be done without a contrast, and high resolution information can also be obtained. But you can even improve the resolution with thinner slices if you actually give a contrast, and it can be used to assess the thrombus. Coming to dynamic susceptibility contrast perfusion weighted imaging, this is similar to CT perfusion, wherein we are giving gadolinium dye, and it travels to the brain and washes out, and we get the graph with which we calculate the parameters, blood volume, blood flow, mean transit time, and time to peak. And this is an example. For this patient, an axial CT T1 weighted image does not show any abnormality. And on diffusion weighted imaging, you are seeing just a few spots of like lacunar infarcts. Bright in ADC and dark, bright in diffusion weighted imaging, and dark in corresponding area will be dark in ADC. But when we did, when we do a perfusion imaging, you can see that the mean transit time is elevated in that same location, but you see there is a larger area which is involved compared to the diffusion weighted imaging. And also when we check the cerebral blood volume, it is increased. So this, since it is not decreased, it is a penumbra. So you can see that there is a large penumbra and a small ischemic core. So this patient should be targeted for therapy, and we should make sure that this patient is a good candidate for therapy. So what we saw there is a perfusion weighted imaging, diffusion weighted imaging mismatch. So this mismatch will allow clinicians to select thrombolytic therapies in the 3 to 6 hour window, as it indicates the presence of penumbra that will benefit from reperfusion. So in the diffuse 3 trials, even 6 to 16 hours after the last time of initial onset of stroke, CT or perfusion imaging was used to select the patient for mechanical thrombectomy. And it showed that both CT and MRI perfusion are beneficial to the patient, but MRI is marginally better compared to CT when considering perfusion, as the benefit were greater for patients who were selected using MRI perfusion weighted imaging. The limitation is it is very sensitive. Even areas which do not come under the penumbra can be mistakenly identified as penumbra because with mild ischemia. So benign oligemia may be falsely identified as an ischemic penumbra. Another advantage we have with MRI is to identify hyperacute infarcts, the diffusion weighted imaging and flare mismatch. So this patient, 49-year-old woman, presented within 72 minutes after onset. You can see that on diffusion weighted imaging, there are a few hyperintense foci, there's an area of hyperintensity in diffusion weighted imaging, but the corresponding T2 flare sequences did not show any signal change. So we consider this to be a hyperacute infarct, and this mismatch told that it was at an early stage. So we can see here that an angiogram was done, and you can see there is an occlusion in the horizontal M1 segment of the MCA, and this is the pre-thrombectomy and post-thrombectomy images in DSA, digital subtraction angiography. You can see that the patient had revascularization following the treatment. So coming to a summary, so the verdict whether CT or MRI is better. What is important is to do an NCCT. So NCCT is the mainstay because you need to rule out a hemorrhage as quickly as possible so that you can start a thrombolytic. And MRI, problem with MRI is it will be, it takes a longer time, and the patients, the MRI screening may not take, but the regular MRI takes a longer time, and the patient, suppose if the patient is uncooperative, it will not provide an adequate image. So that way CT is better than MRI, but however the CT fails to identify microbleeds. So microbleeds are better identified in an MRI with T2 star weighted imaging or a susceptibility weighted imaging. Microbleeds can result in a hemorrhage on therapy, and also, we had also discussed that perfusion in MRI is marginally better when compared to the CT perfusion. Thank you.
Thank you, sir. Now I would request Dr. Kevin to hand over a token of appreciation to Dr. Kahiri. Any questions or doubts in the so far sessions? If there aren't any questions, then we would progress for a tea break. And kindly do return back within the next 10 minutes.
Good morning all. Presentation for this hour is evidence-based management of acute ischemic stroke. So we will be covering the topics under the following heading, but we will be mainly focusing on this IV thrombolysis, because just few minutes back Dr. Sarfraz was saying we have established a stroke unit and we have started thrombolysing and we are getting cases also, but we are finding some pitfall. Somehow we are getting the patients out of window period, and even sometimes even at the brim of window period, and we are under too much stress and we are often in a dilemma whether to go for with thrombolysis or not. So we have few insight regarding that also, so we will share during this presentation. So what is a stroke? Stroke is a focal injury in brain, vascular in origin, and what are the type of stroke that we might have already heard from the previous presentations, classification on the stroke and all. So coming to the management side, actually stroke management that consists not only acute, it has got secondary prevention and rehabilitation, follow everything. But that itself is a huge topic. There's a vast topic, different headings are there. It includes vasculitic syndrome with stroke, genetic conditions with stroke, and hematological conditions, especially in area like Wayanad. There may be a lot of sickle cell anemia cases which can also lead on to stroke. But that everything we will not be able to discuss in this 1 hour of presentation. So our aim is mainly to cover this IV thrombolysis. We will be highlighting that aspect. So before going to the topic proper, I would like to discuss one hypothetical case. And finally you have to say where was the pitfall in this case. It was a case of 40-year-old man. He's a young man, he's a smoker, present with a severe right hemiplegia. And when he presented to us, the onset duration of stroke was nearly 5 hours. So that I want to convey that it's just, we will be discussing that in detail, but beforehand, I may say it was out of window period, that 4.5 hours cutoff was over. So somehow that he was managed conservatively with antiplatelets and all, and patient didn't show marked improvement. And as you know, it's a young patient, relatives were concerned and they went against advice and reached some hospital outside. And there they pointed out some pitfall in our management. They found out some investigation were not done, some management aspects were not considered. So since the patient is young patient, all that opportunities was over and they started making trouble. So anybody can say what may be that person presenting out of window period for IV thrombolysis with a severe stroke, which other investigation should have been done or what else should be considered. Okay, ED people may be knowing, I expect from audience. Anyway, we will review this question at the end of the presentation and we will see whether you will be able to say or not. Okay, coming to the topic. So we are managing the stroke according to different guidelines. So this is one of the major one, that is AHA ASA guideline. So basically it is guideline last came in 2018 and there were one 2019 update. And we are presently managing based on this AHA guideline 2019 update. And there are of course other guidelines also, nice guidelines from UK, and our own India government has released a guideline based on guideline for stroke in 2019. So those who are interested can go for. So whenever we discuss a topic based on evidence, we have to keep this chart in mind. Even though it looks so cumbersome, we may make it simple. So basically there are two headings we have to remember. One is class of recommendation, second one is level of evidence. So class of recommendation, it is just 3 headings, 1, 2, 3. So whenever we consider a treatment strategy, whether it is an investigation or a drug, we will see whether it is, what is the class of recommendation for that. If it is class 1, it is strongly recommended, we should do that. And if it is not doing, if we are not doing, we may be able to explain why it is not done. So that is class 1, anyway we have to do. Class 2 means it is not as strong as class 1, but it may be beneficial more than risk. So that is class 2, that also we may consider for management. But class 3 is either no benefit or there is harmful or maybe harmful. So once we say a strategy is class 3, it is almost like contraindicated or not useful. And the second heading is level of evidence. So it is just saying what is the quality of evidence they have taken to form that recommendation. So overall, if we say this class of recommendation is more important, because if we take this AHA recommendation, we may think that they might have taken that evidence from a good quality study. So we are mainly focusing on this class of recommendation. So roughly this is what it is, a management of acute stroke, how this protocol works. So even though this seems to be complicated, it is just simple. A person, when he develops a stroke in his residence outside the hospital, basically his caretaker suspect it is a stroke. So he may be, in Western countries, what will happen is there will be one toll-free number, they will call into that, and some person will go and screen for stroke and refer to a stroke center. So in our part of the world, it is actually we only, hospital staff only screen for stroke. So patient has the stroke and he is screened for stroke. How he is screened? With some acronyms that we will see. So that screening is done, patient in the hospital, and next, if he is found to have symptoms of stroke, he will be evaluated either for thrombectomy or for IV thrombolysis, and we will proceed accordingly. That is basically what is happening. So coming to the stroke screening, we usually used to do this FAST acronym for stroke screening. So we may be knowing what is FAST, what the letters stands for. F for face drooping, A for arm weakness, S for speech difficulty, and time is that denotes time. That is, time is precious, we cannot waste time. And also that caretaker has to note the time, because everything is managed according to the onset of symptoms, that we should not forget when it started, the symptoms started. So other than this 4 letters, now we have added this BE also. These 2 letters are also added to this acronym. So what is B? B stands for balance symptoms. E for eye symptoms. So we were discussing that some pitfalls, some delay in referring to our stroke centers for thrombolyzing. So this FAST acronym, that face and arm weakness, that these symptoms are reasonably picked up by doctors sitting outside and timely referred to us, we may say. So, but this balance and eye symptoms, there may be some pitfalls, because balance, sometimes it may be taken for granted as BPP, positional vertigo, and he may be sent to an ENT doctor, and they may waste some time. And E for eye symptoms, that also initially will be seen by ophthalmologist. You may be referred to ophthalmologist and may waste time. So this is one pitfall that we want to give as a feedback. So let me ask, how many of you are practicing outside WIMS? Is there anybody coming from outside WIMS? Okay. At least few are there, because many of these things we have prepared to give as a feedback to them. Okay, so this is first and foremost recommendations regarding how to refer, in what case we have to refer. So it is said that once a doctor sitting at outside, practicing outside, and person may come with stroke symptoms. So they are clearly saying that there is no need for any investigation. He should be directly referred to a stroke unit where thrombolysis can be done. So that means that is another pitfall we used to see, because a person approaching a doctor practicing outside with the stroke symptoms, he will be immediately sent for CT or MRI. CT may become as normal because early changes may not be there, and even if it is we are taking MRI and it is showing some features of hyperacute stroke, it will be wasting time because there it may be delayed. Unlike in our hospital situation, we will be fast tracking the MRI and doing the thrombolysis. It will be delayed if it is done in outside. So they clearly say that if the patient comes to a practicing doctor outside, it should be immediately sent to a IV thrombolysis center. So if we, even if we are discussing so much of topics in this presentation, if you ask, this will be the most important point I want to convey in my presentation. So actually I have prepared this topic in an unconventional way rather than directly describing the recommendation for investigation and management. I have made this prepared in such a manner that a patient comes to an ED, what all preparations we do, how we will proceed, in that sequence only I have prepared. So we have seen that outside the patient is screened for stroke and he found to have stroke. Now he have come to the emergency department. So what all things we will do? As in every case in ED, we have to screen for airway, breathing, circulation, and make the patient stable. That is a minimum thing. And is it any need for oxygen for all stroke patients? No, actually the recommendation say AHA says it is only if it is less than 94 there is need for oxygen. And if I ask, before doing a thrombolysis in window period, is there any need for blood investigations, coagulation profile, anything need to be sent? Can anybody say which is the only investigation needed before doing a thrombolysis? Yes. Nothing else needed, only RBS needed to do. Otherwise, in rare situation, patients received anticoagulants already or on oral anticoagulants and we are suspecting any coagulopathy. On those conditions only we have to do other coagulation profiles. Okay, then we even checked RBS and now we have to assess the severity. So we know a clinical examination often can be subjective. A patient who looks with severe stroke to one doctor may not be if some other doctor examine it may seem to be moderate or mild. So there should be one uniform opinion. To make that objective component, this NIHS scoring system is added. So regarding the imaging, they say we have already seen our radiologists has said NCCT is all what needed usually, and it should be done within 20 minutes. And regarding CT also, we have to convey 2 points. Basically, it is mainly just to exclude hemorrhage, not to find out stroke in that. CT is done mainly to exclude hemorrhage. So even if it is showing some hypodensity and all, that is not an indication to withhold. And also sometimes may show some hyperdense MCS sign, and which may implicate is a larger occlusion, but these are all not an indication to withhold thrombolysis. This is just, I am showing this NIHS scale. It's 11 headings. We have to assess the severity of the stroke with this. So we have done that severity assessment also, and he is found to have non-mild stroke. Mild stroke will be excluded for thrombolysis. Other cases will be considering. So within 3 hours, any patient with more than 18 years, severe stroke, mild but disabling stroke, that we have to listen. Even if with NIHS screening, the patient found to a low score, maybe 3. So, but we can individualize even in such cases. Suppose only language is gone. If we look into the score, it will be mild. But suppose he is a teacher or he is a politician, even then it will be even more serious. So in that case, even though it is score-wise is mild, we have to go for, we can consider thrombolysis. Next is the main problem. When we started thrombolizing, this thrombolysis for only for initially 3 hours. Later studies began to come, and even 3 to 4.5 hours of window we started considering for thrombolysis. But that study initially excluded few patients with NIH score more than 25, already on taking oral anticoagulants, and this patient having both diabetes and stroke prior to this present stroke. These were not included, but we may say that these cases, even though it is strongly recommended that patients not with these features, we cannot say that these cases are excluded from this extended window. Actually, we will say that, see that later, even though it is not strongly recommended, thrombolysis is recommended even in this case also. Coming to other prerequisites, only few are there. We have to keep the BP less than 185, 110 if you are considering thrombolysis, and also blood glucose more than 50. Patient already taking antiplatelet monotherapy or dual therapy is not a contraindication for thrombolysis. So discussing few other contraindication. Patients with acute ischemic stroke within the past 3 months is actually a contraindication. They have clearly recommended class 3 recommendation for thrombolysis. We cannot thrombolyze. And if the patient at any time, if he had some IC hemorrhage, then that is also class 3 contraindicated. GI bleed within 21 days. Coagulopathy, they have put cutoff. INR more than 1.7, APTT more than 40, PT more than 15. These are contraindication for thrombolysis. Other contraindications, they say it is class 2 only. That means case to case basis we may consider. If the patient having recent trauma within 14 days, that is not absolute contraindication. We may consider lumbar puncture within 7 days, GI bleed more than 21 days, and this artery dissections, aneurysms unruptured. Even sometimes we may take MRI before thrombolysis, and they say up to 10 cortical microbleed, there is no need for concern, but even more than 10 also they say can be considered for case to basis for thrombolysis. And extraaxial neoplasms in brain, like some meningioma, these are not a contraindication, but intraaxial neoplasms are contraindications. And any cardiac condition like acute MI, recent MI, and pericarditis, all this has got class 2 recommendation, not absolute contraindication. Going further, that we have seen, no, we initially, because no, in this 3 to 4.5 hours window, very often when the patient comes to ED, even we advise for thrombolysis, there may be some concern from ED. Is 3 to 4.5 hours extended window, the patient is more than 80 years age and having features of severe stroke, whether we need to go for thrombolysis or often such doubts we will hear. So it is very clearly they have said that they have got a class 2 recommendation, not contraindication. Okay, and pregnancy also there is class 2 recommendation, and since it is Wayanad sickle cell anemia with stroke, this also class 2 recommendation. That means we can consider. And BP we have already seen, it should be less than 195, 110. This we have once decided for thrombolysis, now we are preparing that patient for thrombolysis. This BP, as we said, it should be less than 195, 110. After thrombolysis, it should be 190, 105. Suppose we are not considering thrombolysis, then what should be the BP when we have to intervene? So this is the cutoff. If we are not we are not considering thrombolysis, only conservative management, 220, 120 is the cutoff. We need to intervene only if it is BP exceeding 220, 120. Otherwise, there should be some other reason to control BP, like some concurrent MI or aortic dissection, eclampsia, like that, then only we need to intervene. Okay, now we have prepared that also, then we are going for administering this drug. So all the initial studies were based upon Altiplase. That actually 0.9 mg per kg we used to give. What is it? But here we are using Tenectase. You might have seen, even though all studies are with Altiplase, here we are using Tenectase. So what are the advantages with the Tenectase compared to Altiplase? So Altiplase, you see, we have to give as an infusion over 1 hour. So patient may be already coming at the brim of the window period. So if in case of tinnitus, we can give it all as a sudden. That is one advantage. And half-life is more for tinnitus. And the third one, actually, after IV thrombolysis, we are scared of this IC bleed. IC bleeds are found to have lesser in case of tinnitus. So these are the main comparison between altiplase and tinnitus. And after thrombolysis, which are the two major complications we have to expect? One is an anaphylaxis-like reaction. Second is ICH. ICH we have to, in case of altiplase, we are giving over 1 hour infusion, we can hold on that. But tinnitus, we will be giving like a bolus only. There is no option for holding. We will be sending coagulation profile fibrinogen. We will be administrating Tinexa and cryoprecipitate. Angioedema, we will be managing almost like an anaphylaxis. We have to maintain the airway. Mesial part, we have to give Randac, antihistamines and adrenaline we will be giving. Just few minutes back, our radiologist was describing wake-up stroke. So how we will move forward with wake-up stroke? Suppose patient last seen normal was 10 o'clock night, and he woke up at 6 a.m. with deficit, and 7 a.m. he came to our ED. So how we will move forward? Anybody? Can we move forward with the CT scan or something else to be done? MRI. What is actually happening? Patient last seen was night. So stroke might have happened at any time. It may be in the midnight at 12 o'clock or 1 o'clock, and it may be in 6 o'clock or just before he awakens. So we don't know actually. So we will get some evidence from MRI. That's for we will be looking into that diffusion flare mismatch. If there is diffusion changes with no flare changes, we may consider it as acute and we may move forward with thrombolysis. That is what class 2 recommendation. So other heading. Suppose the patient presenting after 5 hours. So which other procedure we have to consider? That is mechanical thrombectomy. So even that doesn't mean that within 4.5 hours we should not consider mechanical thrombectomy. Sometimes patient having severe coagulopathy and all, he may be a preferable candidate for mechanical thrombectomy. So if who are the patient suspected to have large vessel occlusion and considered for mechanical thrombectomy, we should get a vessel imaging. That is a class 1 recommendation. So very often in ED what happens is patients suspected to have large vessel occlusion tend to become altered sensorium, not cooperating for imaging. So we may be having difficulty in getting that vessel imaging and all, but that is not an excuse for withholding this vessel imaging, because once the patient goes outside, that centers will be just blaming us for not doing. At that time, this sedation issue and all won't serve us out. So it is class 1 must to do that. If your patient is suspected to have large vessel occlusion, this vessel imaging is must. So that about early vessel imaging. So often suppose that window is also over 6 to 24 hour, up to 24 hour case to case basis we can consider mechanical thrombectomy. After that hour there is hardly any option for intervention or thrombolysis. We will be mainly conservatively managing the case. So in that case do we do any vessel imaging? So in that case we will be doing cheaper images like extracranial imaging like carotid ultrasound, carotid Doppler and all we may be considering, because there is some benefit that patient having deficit on one side and same side having carotid stenosis. If you do some carotid endarterectomy or stenting, there will be some improvement. That has to be done within 7 days and this scan has to be done within 24 hours. So if there is no role for any thrombolysis or thrombectomy, we will be starting the patient on antiplatelets immediately. So what is the role of dual antiplatelets in case? Anyway, ecospirin we will be starting in which all condition dual antiplatelets are recommended. This AHS says it's patient with mild stroke and patient with TIA. Dual antiplatelets, that is adding clopidogrel to ecospirin has got advantage, and we will have to continue up to for 90 days. So usually patient may be taking antiplatelets and he may be coming to us with recurrent stroke. Usually what we used to do, if the patient is taking ecospirin 75 we may make it 150. And if he is already taking 150, we will be adding clopidogrel 75. So is there any evidence for that? Recommendation says there is no evidence for that. Regarding to statin in acute stroke, this may look complicated, but I may simplify it. Is mainly two things we will see: whether the patient who develops stroke is having any other atherosclerotic disease like CAD, peripheral occlusive artery disease, and also this LDL cholesterol we will monitor. These two things we will see and will decide. If he is having no other atherosclerotic disease, we will target LDL as 100. We will start Atorva 80 and we will monitor. And if he is having a CAD or POAD, we will target LDL as 70. We may start Atorva and also may add ezetimibe and even PCSK9 inhibitors also if needed, if it is difficult to control. Initial monitoring we will be doing at 3 weeks and every 3 months we will continue. So regarding some few complications, even though it may present in 2 days or 3 days period, I want to discuss it earlier because we were basically thinking for a doctor sitting at the periphery when to refer the patient to a stroke unit. So we have already seen that thrombolysis, mechanical thrombectomy, these are two are the main time points we have to consider referral. So even after that, we may think that now all such options are over, we may conservative management, do conservative management, but these are again some complications that may require referral. One is cerebral edema. So in that case, mannitol, this anti-edema measures like mannitol, 3% saline, hyperventilation or may help. Is there any recommendation for steroid in case of stroke? No, it is more actually class 3, that is more harmful for stroke than other conditions with SOL or tumor or infections we used to give. This is actually harmful because it may increase the chance for infection and sepsis. Some examples of patient developing cerebral edema. Which are the two conditions which may develop cerebral edema and cause rise to ICT? One is malignant MCA infarction, that's very huge, complete MCA like infarction. Later on will have some supraorbital edema on it and will compress the remaining brain and will cause rise to ICT and herniation. So this may require, we can see in this image now, 1/2 of the calvarium is missing. So due to this rise to ICT, one surgery was done to decrease the ICT. So that is a life-saving procedure we have to consider, otherwise patient may expire. Second one is cerebral edema. Patient with cerebellar infarct. Because this posterior cranial fossa volume is low and cerebellum once it develops infarct, it may directly compress on the brainstem and the patient may succumb. So in that case also posterior cranial fossa decompression may be needed. Regarding cardiac condition, we have an elaborate tack on cardiac strokes. So we may just say ECG has got class 1, must do investigation in case of acute stroke, and echo has got class 2. Recommendation may be useful. So one more thing I want to add about stroke with atrial fibrillation is when to start anticoagulants. So AHA recommendation, if we say, they just say 4 to 14 days interval we have to start anticoagulation. As I may say, a patient with atrial fibrillation developing stroke, so antiplatelet will not be sufficient to prevent further attacks. We may have to add anticoagulation. So initially, from day 1 itself, we may start an anticoagulant in case of moderate or large size infarct. It may become a bleed. There is a risk for bleed. That is our concern. So when to start anticoagulation in this situation is guided with this 13612 rule. It is not an AHA recommendation. I have taken it from European Cardiology Association recommendation. That is one, we can start anticoagulation in day 1 if it is a TIA. That means no infarct, just TIA. In day 3, if it is a mild, 6 if it is moderate, and in case of severe stroke, we may start anticoagulation on day 12 only. So when we were trained in our institute, what we used to do is in day 4 we will start heparin. And actually AHA nowhere there is recommended that heparin has to be started and has to be bridged with anticoagulation. They are directly starting anticoagulation, but for safety we used to do heparin and will be switching over to oral anticoagulation later. So this is regarding management of hypertension in acute stroke. That's also AHA guideline. So even though it is a large chart, we may just say, even though in case of simple hypertension, we may say it is 140/90 that has to be targeted. If the patient having stroke, acute stroke, for chronic management, he has to be targeted 130/80 as a cutoff. And which are the two drugs preferred for hypertension management in case of acute stroke? It is ACE inhibitors or ARB and thiazide diuretics. These two are the preferred drugs. Somehow some evidence are there. If you use these drugs for hypertension, there is chance for recurrent stroke is also less. Okay, this carotid revascularization we have just seen. Carotid Doppler we used to do, that has got class 2. That is maybe beneficial for some patient because this endarterectomy and stenting may be helpful in some patients. Few words regarding rehabilitation. We have a dedicated talk on rehabilitation coming. I may just say within 24 hours, high quantity, this rehabilitation is not recommended because that will hinder the progress. Within 24 hours, we may do simple light exercises only. And regarding DVT prophylaxis, which step has got class 1 recommendation, it is only pneumatic compression device. Other things we used to do, we may give some elastic crepe bandage or may give heparin. But compared to this pneumatic compression device has got high quality, highly recommended. And few words regarding supportive care also I may say. Should we keep the patient NPO in case of acute stroke? No, actually we have to start the feed immediately. Even though AHS say it is within 7 days, even we don't wait for 7 days. We will start immediately only. And if we have to screen for dysphagia, especially a patient with severe facial weakness or dysarthria, dysphonia, may be prone for dysphagia, we have to screen and give, otherwise he will aspirate and will develop some pneumonia. And if he is having difficulty in swallowing, we may put Riles tube and for initial days. And if he is improving, we will remove the RT. If he requires prolonged feeding, we may consider gastrostomy, tube and feeding and all. And regarding oral hygiene also, that is also found to be beneficial, that giving some chlorhexidine mouthwash will save the patient from developing serious aspiration pneumonias. So this I missed. So this one we just mentioned about feeding in acute stage only. So this is one type of diet that is useful to prevent acute stroke in chronic management. That will, even though it is coming in chronic management, I just mentioned. So some other complication I may say is this complete continuous blood drainage required in all cases of acute stroke? No, that will be more harmful. Patient may develop a UTI. So if the patient is continent alert, we may check for this sensation and remove it. And we have to monitor for bed sore. We have to change the position 2 hourly, keep the patient on both sides. We may use air mattress and all. We have to screen daily for aspiration pneumonia. Even though there is gross sudden aspiration, patient may be having micro aspirations. Even the saliva may get swallowed and patient may develop pneumonia. So daily we have to monitor for pneumonia. And of course IV cannula site for development of thrombophlebitis. Temperature also, fever, high grade fever is deleterious in case of high stroke. We have to monitor and we have to find the cause, where is the infection, where is this UTI or pneumonia, we have to manage accordingly. Regarding smoking cessation, so even though we are discussing this acute management, why I describe this smoking cessation in this acute management? Anybody? Actually, this acute stroke period, that is a tender period. If we motivate the patient to stop smoking in this acute period, he may be more compliant. So once he started improving, even we counsel, he may not be compliant to that. We may use counseling, nicotine supplements or varenicline and all for smoking cessation. We might have seen in stroke patients may be taking this citicoline and piracetam and all. Is there any proven benefit for those drugs? No, it's actually class 3, never found to be useful. And patient education is recommended to do. What is stroke? What illness he developed? How he developed? What were the risk factors that he developed this stroke? What are the medications? What are the mechanism of action? All we need to convey the patient, because when he is aware of that problem, he may be more compliant to advices we give. And also PST. That's a heading we should not miss. What is a PST in case of acute stroke? It is post-stroke depression. It's actually what need to be done in a case of a stroke, patient with stroke and severe deficit. he has to be, he should be motivated to do this physiotherapy improvement. But on the other hand, if he is depressed, how this improvement? He may not be doing any physiotherapy, he may not be complained. So we have to screen for depression. If he needs some drug, pharmacotherapy like acetylopam and all, we have to give that. And we have to finally, if the patient is having bedridden, we may have to suggest for palliative care, which is freely available in our government setup nowadays. So we will review that case. So we have said that for a 40-year-old man with severe weakness and presenting 5 hours, that means out of window period. So, but managed conservatively and later on developing complication and finally blame game started. So what could have been that mistake which investigation was not done? Anybody? Yes, MRI, angio should have been done, and he should be considered, he should have been considered for mechanical thrombectomy. So that may be the problem. And finally, so that point, be fast in identifying stroke. IV thrombolysis up to 4.5, we should not forget. And new thing, up to 24-hour case to basis, we may consider mechanical thrombectomy. And this urgent referral to thrombolysis center when the patient develops hyperacute symptoms, regardless of what is CT, not sending for any CT or MRI, direct referral, and early rehab and vascular risk factors.
Thank you, sir. That was fairly an interactive session. Does anybody have any doubts regarding referral, loading dose, or any investigations to be done? Please raise your hands. I'll get the mic towards you. I mean, there are many doctors who are practicing in the periphery and also within DMM. So any doubts regarding anything can be entertained now. If there aren't any doubts, we will be...
So we discussed about this wake-up stroke.
Yes.
Suppose there is a facility for this perfusion imaging done, and somebody comes within the window of 4.5 to 9 hours. I understand there are at least 1 or 2 studies which explored that. Thrombolysis in patients presenting within 4.5 to 9 hours.
IV thrombolysis.
IV thrombolysis.
Actually, we never used to do, sir. I heard up to 9 hours now we can consider, but AHI, even recent update, we are not done.
Okay.
I think Dr. Paul, if you are aware of that.
You can do it in 9 hours. Some studies. It is not yet in the guidelines, but the guidelines will come for that. I think the next guidelines it might come. When if you have perfusion, you can do even for the acunar small strokes. Patients are identifying one small diffusion restriction mismatch and thrombolizing. And there is a study in NEJM in 9 hours.
Regarding tenecteplase and alteplase, is the bleeding risk is less for tenecteplase or more comparing with alteplase?
No, it is more for alteplase. Bleeding risk is less for anthrax.
When I was doing my PG residency, one of our HOD of neurology, James sir, had told that if a patient comes after 3 hours, before 4.5 hours, better to do only alteplase because more risk for bleeding with the tenecteplase after 3 hours, between 3 and 4.5 hours. But recently in MIMS also they're doing giving tenecteplase even at 4.5 hours. If even if the patient comes at the brim of the window period. So what is the latest update? Is the real scenario, what is that?
No, actually in guidelines there is no discrimination between two even in this extended window period. But that your point may be that tenecteplase has got an extended half-life. It will act for long. So as you say, if he is presenting late and drug may act even after that window period, that may be creating the concern.
What is your experience?
No, we are doing only with tenecteplase only.
Even between 3 and 4.5 hours?
Yeah.
All right. Thank you, sir. I now request Dr. Anish Bashir, HOD of Internal Medicine, to hand over the token of appreciation to Dr. Pratish. Thank you, sir. Now, moving on to the next session, I welcome Dr. Santosh Narayanan, Consultant Interventional Cardiology in DMMC, to brief on his topic, stroke and cardiac conditions, including atrial fibrillation and valvular heart disease. I request Dr. Cherian, HOD of Interventional Cardiology, DMMC, to chair the session.
This one.
Last. Good afternoon, everyone. Today I'll be speaking on mainly about atrial fibrillation, how to prevent stroke in patients with atrial fibrillation, a primary prevention of stroke, and a few words about secondary prevention, and also about few slides on other heart diseases. So most of the talk will be on atrial fibrillation. So AF constitutes about 0.5% to 1% of general population, and also the prevalence increases with age. Around 8% of aged about 80 years have AF, and 60 million patients worldwide are found to have been suffering from AF. And prevalence in Asia, recently only the prevalence in Asia came out in JACC journal, and it is reported to be about 0.3 to 3.5% based on the community-based survey. And there is no proper registry in India, and it is basically the survey done in other countries like China, Taiwan, and South Korea. And the Asian population is, because of the lack of registry, there was no data on the burden of AF, but it is found to be increasing. Even in our hospital, in our day-to-day practice, we see about 3 to 4 patients with AF every day. So that is the burden of stroke. And there is 5-fold increased risk of stroke, and 1 in 7 strokes are due to AF. So this is a slide showing global prevalence of AF. The prevalence in Asia is lower because there is no registry. Actually, it is much higher than that of the Western world. So coming to classification of AF, there is lack of this classification. Till now, there was no proper classification, and there was much confusion regarding how to put patients into which group. So ESC has come up with this classification, that is, AF is classified based on the duration. So it is divided into paroxysmal AF, persistent AF, long-standing AF, and permanent AF. Paroxysmal AF means AF that terminates spontaneously or by about an intervention within 7 days of onset, usually within 48 hours, but within 7 days of onset, if it terminates, it is described as paroxysmal AF. And persistent AF is AF that is sustained beyond 7 days, including episodes that is terminated. Long-standing, that is persistent AF. Long-standing persistent AF is AF more than 12 months. Permanent AF is the terminology used when there are no further attempts to restore sinus rhythm. Already a pathology has set in, and we cannot revert back the rhythm. And some of the terminologies like lone AF, valvular AF, non-valvular AF are all terminology that should be abandoned. That it creates much confusion. The term valvular AF is actually used only for moderate to severe mitral stenosis and those with prosthetic heart valves. Patients, for example, patients with aortic stenosis or aortic regurgitation with atrial fibrillation are being classified as non-valvular AF. So the terminology creates much confusion. So ESC has recommended to abandon that term. So this is a summary. Paroxysmal means less than 7 days, usually less than 48 hours. Persistent means more than 7 days. Long-standing persistent, continuous AF more than 1 year. And permanent means no further attempt to restore the sinus rhythm. So ESC has recommended that an ECG recording showing a rhythm strip with no discernible repeating P waves more than 30 seconds. This is very important. No discernible repeating P waves more than 30 seconds and irregular RR intervals is diagnostic of clinical AF. And recently, as I told, an article came up about prevalence of AF in Asians. So we can now predict AF in Asians with 2 scoring systems, that is chest score and Taiwan AF score. If the patient is having these comorbidities, the incidence of AF increases, that is CAD, COPD, hypertension, elderly, heart failure and thyroid disease. Each comorbidity is given a point, and as the number of points increases, the incidence of AF increases. So we can predict the incidence of AF. Similarly, Taiwan AF score also takes into consideration the age and also the gender, along with other comorbidities such as ESRD, etc. So this is a simple scoring system to predict AF. Now, as I told, the burden of AF, the rate of ischemic stroke is around 5% per year in non-rheumatic AF, and it increases 2 to 7 times when compared with people without AF. And Framingham Heart Study has shown that there is 17-fold increased risk of stroke in rheumatic AF when compared with the age-matched controls. And these are the clinical issues related to AF. Not only stroke, chronic and persistent AF leads to cognitive decline and dementia due to cerebrovascular disease, and also it can lead to myocardial infarction and LV dysfunction, heart failure, rarely pulmonary embolism, and AF can coexist with cancer, and AF sometimes can result in CKD due to atherosclerosis, and also it can alter so many drugs, and also the pathology can alter the gut microbiome and sometimes venous thromboembolism if there is a shunt. So these are the clinical issues related to AF. The mortality is definitely doubled and hospitalization is more frequent. And there is wide variation in the clinical presentation. It can vary from no symptoms. Patients with AF may not have any symptom, and it can vary up to the extent that patient will be having severe heart failure. It's called tachycardiomyopathy, AF-induced LV dysfunction. So how the AF occurs? The basic mechanism of AF is there is a trigger, and the trigger is maintained by a substrate. The electrophysiological mechanism is actually called triggered activity. Once there is triggered activity, there are numerous micro reentrant circuit within the substrate, and the most common site of trigger is the pulmonary vein because of the shorter refractory period, and also there is abrupt change in myocyte fiber orientation. And the most common site of paroxysmal AF is the junction between the pulmonary vein and the left atrium. And sustained atrial fibrillation triggers an inflammatory response which leads to activation of myofibroblast and further inflammatory response and development of fibrosis, myocyte apoptosis. As with other pathologies, it leads to a chronic inflammatory state. Once that chronic inflammatory state is reached, there is electrical and structural remodeling of the atrium, that is called as atrial cardiopathy. This atrial cardiopathy leads to maintenance of the atrial fibrillation, and once that atrial cardiopathy occurs, there is persistent AF. In persistent AF, there is continuous conduction of several independent wavelets. There is micro reentrant circuit, and they propagate in a chaotic manner. Once persistent AF occurs, ablation is very difficult. And this is a picture showing, you can see there will be independent microcircuits, and among the microcircuits the current will propagate in a chaotic manner. So where to ablate and all, it will be localization of the reentrant circuit and all will be very difficult. Initially when the AF starts, it will be confined to the pulmonary veins, but once the chronic inflammatory pathology occurs, there will be development of micro-reentrant circuit and it propagates in a chaotic manner and treatment will be very difficult. So this is a natural history of AF. In the initial stage, paroxysmal AF we can control with rhythm control, and we can go for ablation and rate control. And as it progresses to persistent and long-standing persistent AF, only rate control may be possible. And obviously, we have to anticoagulate all the patients with atrial fibrillation. So how to approach AF? The ESC has put forward a unique approach. That is, we have to approach AF in this manner. We have to assess the risk of stroke, that is 1S, and we have to assess the symptoms. As I told, there will be wide variation of symptoms. We have to treat AF based on the symptom severity. Some patients may need only rate control, some patients need rhythm control. This is very important because we are dealing with primary prevention of stroke indirectly by treating AF. And also we should take into account severity of AF burden, whether it is how frequently the patient is getting paroxysmal AF, like that. And also we should take into account any other comorbidities which can alter the substrate, that is coexistence of other cardiovascular risk factors can all modify the substrate which can lead to progression of AF. So we have to assess the risk of stroke, we have to assess the symptom, we have to assess the severity of AF, and also we have to assess the comorbidities. This is the 4S approach. And one more assessment is called the ABC pathway. Once we diagnose patient with AF, we have to anticoagulate. We have to go for symptom control, better symptom control, and also we have to treat the comorbidities. This is known as the ABC pathway. I will be discussing in detail. Just you remember the ABC. So how to assess the risk of stroke in atrial fibrillation? We all know about the clinical scoring system, that is the Chadwa score. And beyond the Chadwa score, anything else is there that we will be discussing. How to assess the anatomy of left atrial appendage, and also is there any role of biomarkers, and whether we can predict the frequent occurrence of AF by ECG in a sinus rhythm. When the patient is in sinus rhythm, when he has paroxysmal AF, we can predict the further occurrence of AF by few electrical indices. So this again showing, once we have a patient with AF, we have to approach like this. Once we should do a clinical scoring system. This Chadwa score is the main scoring system. They have also put forward the, do we have a marker? Recently, some more scoring systems have come, ATRIA and ABC. And also, we can assess the anatomy of left atrial appendage, because some of the anatomical variants are more prone for thromboembolism. And these are nowadays widely used in the Western world. This assessment of left atrial appendage shape and assessment of LA fibrosis by cardiac MRI. In India, we are only using the clinical scoring system, but these might come into use in future. And also the biomarkers. Increased tropi and BNP in a new patient with AF carries high risk of thromboembolism, and also elevation of inflammatory markers like cytokines and interleukins also. ECG will be discussing. So this is the evolution of scoring system. Initially, we had a score known as CHARD S2 score. Then came the CHA2 DS2 WASC score. Then they again modified based on the studies ATRIA, ABC, and the latest is the Garfield AF tool. But this is only a research tool. In the day-to-day practice, we are using the CHARD WASC score. So initially it was only CHARD S2 score. Then came one more score known as R2 CHARD S2 score. They added 2 points for creatine. They found that it was even more better than the CHARD S2 score. Then came the CHARD WASC score. Then several modifications like that. The latest is the Garfield AF tool, and they have found out that this is a much better. This is a computed machine tool. And it has numerous variables by which we can accurately predict the risk of stroke in a patient with AF. So this is the CHARD-WASC score that we use in our clinical practice. As you all know, it has all these points, and the rate of stroke increases as the number of points increases. And the ATRIA score takes into account anemia, severe renal disease, elderly, previous bleeding, and hypertension. And if the score up to 3 is low, score 4 is intermediate, and 5 to 10 is high risk. And there are scoring systems to assess bleeding risk also. This is also more important because we will be anticoagulating all patients with AF. So patients who have high bleeding risk, we should be following up them regularly. Otherwise, they can lead up to catastrophic bleeding complication. So this is the Hasbled score that is used to assess the bleeding risk. One drawback of this Hasbled score is it takes into account the INR value. Nowadays, we are using the novel oral anticoagulant drugs. The novel oral anticoagulant drugs cannot be assessed based on the INR value. So this score can be applied only to patients who are on warfarin. This is one more score. This is actually relevant in the era of NOAC because this takes into account the time to therapeutic range. By taking into account these points, we can calculate the time to therapeutic range. So if in a patient with newly diagnosed AF needing oral anticoagulation, we can calculate the same TT2R2 score based on these points. And if the same score is more than 2, we have to consider NOAC. If the score is less than 2, we can consider warfarin and regularly assess the time to therapeutic range. We have to monitor every weekly. And if the patient is not achieving the therapeutic range of INR, we can again reconsider NOAC. So this is another scoring system to categorize the patient to receive NOAC or warfarin. So that is about the scoring system to assess the stroke. Now we come to how the LA appendage anatomy can help in assessing the risk of stroke. There are 4 types of left atrial appendage anatomical subtypes. It is again divided into chicken wing morphology and also non-chicken wing morphology based on the shape. This chicken wing type is less thrombus prone, whereas other types are more thrombus prone. And so they should be getting better anticoagulation. This is a LA appendage, and they are categorized based on CT images. In Western world and all, every patient with atrial fibrillation will undergo a cardiac CT and if needed cardiac MRI, and based on that they will divide the patients into based on the thrombus burden. We can divide into chicken wing and non-chicken wing, and follow-up is needed for these people because they are more prone. Even with the same CHARD-WASC score, they have conducted studies That is, patient will be having different LA morphology with same Chadwick score. For example, one patient will be having this morphology, other patient is having this morphology with a Chadwick score of 4. A patient with this morphology will be more prone to a thromboembolism. So that is the advantage by categorizing based on LA anatomy. And we can also assess the LA fibrosis by cardiac MRI. With more LA fibrosis, as I told, the chance of persistent AF as well as thromboembolism is higher. And also we can assess the LA function by echocardiography. We can assess the left atrial appendage velocity and also the LA volume. If the LA velocity is less than 35 and the LA volume is more than 34, it is not good. LA velocity less than 20 is very prone for thromboembolism. It is actually assessed by sophisticated method known as speckle tracking echocardiography. It is not available in our hospital, but in Western world they are regularly doing. And as I told, these are some of the ECG parameters. When the patient is in sinus rhythm, when the paroxysmal AF is reverted to sinus rhythm, if the patient has a prolonged P wave duration, more than 40 milliseconds, and also an abnormal P wave axis with a leftward P wave axis, and the abnormal P wave terminal force in V1, and also interatrial block. Interatrial block means there will be a biphasic P wave with the gap between the biphasic P means it is representing both right atrial and left atrial P wave, and the gap between the two is more than 40 milliseconds. If these parameters are present, these people are prone to have more episodes of AF and also subsequently risk of thrombus. So once we diagnose a patient with AF and also stratify the risk, how to manage. Anticoagulation is first and foremost, and then comes the rate control or the rhythm control, as well as acute management of AF and also long-term management. Some patients may present in hemodynamic instability requiring acute management. In the long-term management, we have to consider either rate control or rhythm control. Some patients will require rate control, that I will be discussing in detail. And we might have to go for, if the rhythm control is not achieved by drugs, we might have to go for ablation. And as I told in the beginning, we can modify the substrate in the pulmonary vein by giving ACE inhibitor and statins. ACE inhibitors and statins are found to be suppressing the this re-entrant circuit and thereby helping in maintaining the sinus rhythm. An approach to thromboprophylaxis in AF is based in the present day-to-day practice, it is based on the Chadwick score. If the score is more than or equal to 2, we have to go for oral anticoagulation. If there is only one risk factor, either oral anticoagulation or an antiplatelet can be given, but both ACC, American as well as European Society recommends OAC than aspirin. OAC is preferred over aspirin. If there are no risk factors, either we can give aspirin or no antithrombotic therapy. So once we diagnose patient with atrial fibrillation, we have to again categorize whether patient is having a prosthetic heart valve or a moderate to severe mitral stenosis. This term was previously called as valvular AF, but the term is now abandoned. If the patient is having either a prosthetic heart valve or patient is having moderate to severe MS, then NOAC cannot be given. Such patients can be given only warfarin. And if the patient is not having this, then we have to go for Chadwick score. Then as I told, if the score is based on the score, we have to consider either OAC or aspirin. And this is the ACC-AHA recommendation. If the score is 2 or greater in men or 3 or greater in women, oral anticoagulations are recommended. And this again I am stressing because patient with moderate to severe MS or a mechanical heart valve, we can give only warfarin. NOACs are contraindicated. This is a recent trial, Invictus trial, which studied rivaroxaban in RHD associated atrial fibrillation. In this, they have taken into consideration patients having moderate MS. Moderate MS means around mitral valve area between 1.5 to 2.5 centimeter square, and they have given rivaroxaban and compared with warfarin. They have studied around 4,500 patients, but they have concluded that among patients with rheumatic heart disease, warfarin led to a lower rate of events or death than rivaroxaban without a higher rate of bleeding. So, based on this trial, if the patient is having rheumatic heart disease, irrespective of the severity of the lesion, still warfarin has an upper role than NOAC. So, this is the dosage of the NOAC. Dabigatran is usually given at a dose of 150 milligram BD, rivaroxaban at 20 milligram, apixaban at 5 milligram in a BD dosage. Edoxaban, of course, we are not frequently using, it is not freely available, and dose reduction should be used for dabigatran. Dabigatran, one thing you should remember, dabigatran 80% is renal excretion. So dabigatran dose should be reduced in CKD. It is almost not preferred in CKD, and it also should be reduced in elderly and concomitant use of verapamil. And rivaroxaban should be modified in CKD, and apixaban is modified according to a criteria known as ABC criteria. ABC means age more than 80 years, B for body weight, and C for serum creatinine more than 1.5. If any of these are there, we have to reduce the dose of apixaban to 2.5. And one interesting fact about rivaroxaban is that the elimination half-life of rivaroxaban is almost all NOACs is 12 hours. Still it is given in a once daily dosage. That is because the pharmacodynamic effects last longer, and also the bioavailability increases with food. So rivaroxaban should always be given along with food. This is not for other NOACs, only for, this is peculiar for rivaroxaban. And some of the landmark trials we should be knowing. This is a RELY trial that first came with dabigatran. They compared dabigatran with warfarin, and it is a non-inferiority double-blinded trial, and they have found out that the bleeding risk is much lower with dabigatran 150 milligram. That is, cumulative hazard rate is less over time when compared with warfarin. So based on the RELY trial only, we are now prescribing dabigatran in patients with AF. And these are some other trials. Aristotle and Averroes trial have studied apixaban, whereas edoxaban was studied in Engage AF, and rivaroxaban was studied in Rocket AF trial. All of this have reached the end point. The composite of stroke and embolism, and the embolism was less, and the major bleeding was also less with all these NOACs when compared with warfarin. Averroes trial has studied not warfarin, it has compared apixaban and aspirin, whereas all other trials have compared NOAC and warfarin. And this is again one more slide stressing the NOAC. One important, this I already mentioned, bioavailability of rivaroxaban increases with food. And one more thing is the renal elimination. Dabigatran, it is 80% renal elimination, and it can be reversed by hemodialysis. So which NOAC to prefer? If there is very high risk of bleeding, that is has blood score more than 3, we have to consider either apixaban, dabigatran or edoxaban. Rivaroxaban is not preferred. High bleeding risk means omit rivaroxaban. If there is history of previous GI bleed, apixaban is the most preferred. Edoxaban, of course, it's not freely available. So in our setting, we can use apixaban. If there is high risk of ischemic stroke with low bleeding risk, then dabigatran is the most preferred agent. And if there is previous stroke, secondary prevention of stroke, then we can use rivaroxaban or apixaban, because these have been studied in some trials. And if there is concomitant coronary artery disease, then only the role of rivaroxaban. This rivaroxaban has been studied in most of the trials in patients with coronary artery disease. So if the patient is having coronary artery disease, rivaroxaban is the most preferred agent. And in, as I told, all other conditions, valvular heart disease, severe mitral stenosis, prostatic heart valve, APLA syndrome, cancer, and all, warfarin is the recommended. And renal impairment, we should omit dabigatran, because dabigatran is 80% by renal route. And also we should reduce the dose of apixaban to 2.5 and rivaroxaban to 15 and edoxaban to 30 milligram. And also if there is previous history of GI bleed, then also we should omit dabigatran. So this is how to choose NOAC. So there are no studies comparing one NOAC with other NOAC. So our conclusion is, in most of the patient, apixaban may be preferred in AF, except in case of patients with CAD, where rivaroxaban may have an upper role. And also, if there is high risk of ischemic stroke, then studies say that dabigatran may be given. And these are some of the assays which can dictate various NOACs. That is, for dabigatran, it can be dictated by eccarin, because the prothrombin time, thrombin time and all have no effect in this normal or anticoagulation drugs. Only thing is, specific assay should be done, or an eccarin clotting time, that and all is not available. A specific assay of each NOAC may be done, but that also is not widely available. So, how to time the anticoagulant after an episode of stroke? This Dr. Pradesh had already discussed. This is based on the ESC guidelines, that 13612 rule. That is, ischemic stroke or TIA we can start on day 0 itself, and TIA with a non-valvular AF we can start in the first day itself, between 0 and 2. And if there is low risk of hemorrhagic conversion, then we can start between day 2 to 14. And if there is high risk of hemorrhagic conversion or already an hemorrhagic transformation has occurred, then we have to wait for 14 days before starting NOAC. So that is about anticoagulation. So next we'll move on to rate control. This I'll be, there are so many slides, so I'll be rushing. So acute management, rate control, if the patient is not having any hypotension, heart failure or pre-excitation, beta blocker or a CCB can be given. If the patient is having hypotension or heart failure, amiodarone or digoxin is preferred. And this is very important. If the patient is having pre-excitation, all AV nodal blocking drugs should be omitted. The drug of choice is procainamide. That is AF with WPW syndrome. And again, this is an ESC recommendation. Once we have to, we are planning for rhythm control or cardioversion, we have to preferably, we have to know the duration of AF. If the duration of AF it is less than 48 hours, we can go for cardioversion. If the duration is more than 48 hours, we should anticoagulate the patient for 3 weeks and then cardiovert. And the ESC is recommending that after cardioversion, we should continue the anticoagulation for 4 weeks, even if the patient is in sinus rhythm. That is the rule. If the patient is having a duration more than 48 hours, then it is better to go for a transesophageal echo to rule out an LA clot. Then we can safely cardiovert. And then hemodynamically unstable patient, we can go for cardioversion. And if the patient is having no structural heart disease, we can use propafenone, flecainide and ibutylide. And if the patient is stable with the structural heart disease, we can also use amiodarone. That is, if the patient is having any structural heart disease, we should omit all these drugs. Only amiodarone we can give. And there is some terminology called pill in the pocket. If the patient is not having any structural heart disease but getting frequent episodes of AF, the patient can keep a pill in the pocket, that is either propafenone 600 milligram, flecainide 300 milligram. That is for established terminating AF. That is, if the AF terminates with these drugs, we can give these drugs as on an OPD basis. The patient himself can take. That is called pill in the pocket. So coming to long-term management, when to go for rate control, when to go for rhythm control. Numerous studies have shown that there is no difference between rate control or rhythm control, and there is no difference in cardiovascular mortality with either rate or rhythm control. And non-cardiovascular mortality is higher with rhythm control. Stroke, there is no difference. Quality of life also no difference. And rhythm control is more expensive. But some studies like staff and affirm studies favor rhythm control, but most of the studies favor rate control. But of late, some of the articles in our Journal of American Cardiology of JACC and all are preferring rhythm control, but there are no proper studies or randomized control trials still favoring rhythm controls, but of late they are preferring rhythm control. So when to go for rate control? Rate control is given when the patient is having persistent AF, recurrent AF, and also the patient is elderly. When the patient is less symptomatic, or patient is having hypertension or a previous rhythm failure, we can go for rate control. That is, in the natural history, I told when the patient is, as disease has progressed, persistent and recurrent AF, rhythm control may not be suitable. In such patients, we can go for rate control. If the patient is early in the natural history, first diagnosed AF or an early AF, we can go for rhythm control. And the young patients, it is better to achieve rhythm control to prevent thromboembolic complications. And of course, if the patient is symptomatic, then we have to go for rhythm control. And also, if there is heart failure, then also we have to go for rhythm control. So, rhythm control is preferred in young patients, symptomatic patients, and also in patients with heart failure. And there is something called as strict rate control and lenient rate control. Strict rate control means we are keeping a target of heart rate less than 80 in AF, and also lenient means heart rate less than 110. But again, numerous studies have shown that there is no much difference in either in strict control or a lenient control. And the choice of drugs include, if the patient is not having any structural heart disease, you can go for either calcium channel blocker or a beta blocker. And if the patient is having LV dysfunction, then comes the role of digoxin. And in refractory cases, you can go for amiodarone or an AV node ablation. And these are all the doses of this I'll omit. And this is a newer trial, that is that I told the rhythm control may be better. That is catheter ablation for atrial fibrillation with heart failure. In patients with heart failure, rhythm control is obviously better. This came in New England Journal of Medicine. It's called as CASIL-AF trial. CASIL-AF trial has shown that in patients with heart failure, rhythm control may be better. And there is one more trial called Cabana trial. Cabana trial came in patients without heart failure. In patients without heart failure, the trial failed to demonstrate that catheter ablation is superior to drug treatment. So with heart failure, rhythm control is superior. Without heart failure, still rate control may be better. And this amiodarone, once we use for rhythm control, we should start in a dose of 200 milligram thrice daily over 4 weeks. Then we can taper off to 200 milligram daily. And we should be careful with concomitant use with warfarin or digoxin. It has drug interaction, and also use with other QT prolonging drugs should be used with caution. And also regular surveillance for liver function, lung function, and also thyroid toxicity. It is very notorious to cause thyroid toxicity. So all these things should be monitored while the patient is on amiodarone. And other drugs that can be used for rhythm control are flecainide and also sotalol and dronedarone. This is again the slide. All these things I have mentioned, so I'll omit this. And coming to AF ablation. AF ablation means terminating the reentrant circuit that can be done either by transcatheter route or by a surgical route. There are various modalities, trigger ablation, substrate ablation, and nowadays we are more frequently using this pulmonary vein isolation. Just remember these terms. At your level it may not be necessary. Just remember that by pulmonary vein isolation we can ablate the source of AF. Now a few slides on non-pharmacological management of AF. How we can control AF without drugs, and we can, as I told, left atrial appendage and pulmonary veins are the originating site of the reentrant circuit. So by excluding the left atrial appendage from the electrical system, or we can that is, left atrial appendage is a site where thrombus is prone. The thrombus gets collected in the left atrial appendage. So once we occlude the left atrial appendage, we can prevent thrombus formation. This is by a device called as Watchman device. This is done percutaneously. Percutaneously we can introduce the Watchman device into the left atrial appendage, and we can block the left atrial appendage so that the thrombus may not collect. And these are all the procedural steps. And this is another device called as plateau device. It's an umbrella shaped device. We can put in the atrial appendage and we can occlude the atrial appendage. And one more thing of late that has come is permanent bilateral carotid filters. We can keep carotid filters in both the carotid arteries in patients who have high risk of thromboembolism. The thrombus may not propagate further. This is one trial that has studied about the carotid filter, that is CAPTURE AF trial. First in human carotid filter trial. They have enrolled 25 patients with high Chadwa score with prior embolism, multiple prior strokes, and the device could be successfully deployed in 92%. And after 6 months follow-up, there was no thrombus formation, in situ thrombus formation. So this is still under research. This is one of the modality that can be used to prevent AF, one of the non-pharmacological method of preventing AF. So that's about AF. Now about other heart diseases. In infective endocarditis and all, if there is intracranial hemorrhage or major ischemic stroke, there is no role for anticoagulation. Only thing is we have to remove the source, that is by early surgery. If the vegetation is mobile, we have to go for early surgery. And if there is risk of aortic valve rupture and all, we have to go for early surgery. There is no role for anticoagulation in infective endocarditis with stroke. And if the patient is having a mechanical heart valve, then also there is no role for NOAC. And if the patient is in sinus rhythm with any of the valvular heart diseases, then there is no role for anticoagulation. Only antiplatelet may be required. And in patients with cardiomyopathy with a history of stroke, if there is LV or LA thrombus, warfarin is recommended because NOACs, there are no proper studies, only few RCTs. There is no properly done study to recommend that NOAC may be given in patient with an LA clot or LA thrombus. It has not come in any guideline. And also if the patient is having LVAD, patient requires warfarin with aspirin. And in LV, there is one cardiomyopathy called LV non-compaction, which is more prone for thrombus. In such cases also NOACs have not been studied. And one thing is patent foramen valve. In patent foramen valve, there is right to left shunt, and patients are prone for paradoxical embolism and stroke. And if the patient is young and we have a suspicion of a patent foramen valve, then such patients should go for transesophageal echo. And if already the patient is having stroke, then there is no harm in closing the patent foramen valve by a device. And there are various scoring systems like rope score and all that is beyond our talk. And there is one terminology called atrial septal aneurysm. There may not be visible patent foramen valve, but if there is huge atrial septal aneurysm with right to left shunt, then also it should be considered as a patent of foramen valve, and we can still in ASA also we can do a PFO device closure. And in a patient with congenital heart disease with a fond and palliation and all, again NOAC are not recommended. Warfarin is still recommended. And in cyanotic heart disease and other complex lesions also, warfarin is recommended. If the patient is having any cardiac malignancy like LA myxoma, obviously there is no role for anticoagulation. And AF with cancer with stroke, in such a case, NOAC may be preferred over warfarin. And of late, there is one terminology called as ESUS, that is embolic stroke of undetermined source. If a patient is young and we have not got any source of stroke, even in sinus rhythm, we can go for a prolonged cardiac monitoring to detect AF. And also if the patient is very young, we can go for TE. There is no guideline or recommendation when to go for TE, but the patient is young, we can, even if there is no suspicion in transthoracic echo, TE may be advised. But prophylactically giving NOAC in a patient with stroke in sinus rhythm is not recommended by this trial. So to conclude, atrial fibrillation has 5-fold increased risk in stroke, and we should have a proper approach, how to approach AF by our 4S or an ABC, and we should know about the management for primary prevention of stroke, that is anticoagulation and also acute and long-term management, rate control and rhythm control strategies. And anticoagulation should be properly monitored, and also we should have an idea about non-pharmacological methods which may be employed in patients who are having contraindication to anticoagulation, like Watchman device and all are now being frequently done, and in future there may be a role for carotid filter also. Thank you.
Thank you, sir. Any doubts regarding the topic discussed so far?
So, a patient who is around 60-65 years of age in sinus rhythm, he comes with stroke. Is there any recommendation? Is monitoring for an AF is recommended or not? We usually come across references so. What should be
they are telling that in a patient with elderly patient, we should rule out, first we should rule out atherosclerotic causes like carotid Doppler and all should be done initially. And if there are no proper other causes, no comorbidities, Then a prolonged monitoring up to 72 hours can be done. It has been given a class 2B recommendation in ESC, up to 72 hours. But still, to detect a patient in sinus rhythm, to detect an AF, there is no guideline.
I just want to highlight one thing actually. Usually when AF comes to our ED, our routine tendency to give amiodarone. So whenever we talk about cardioversion, that guideline is both for cardioversion and for drug-used cardioversion. So when you say cardioversion, it's not only for defibrillation. So whenever a patient comes to ED with AF, our routine practice to give Cordron actually is not recommended. Actually, like it's a routine trend here. So that is not as per guidelines. Either you should have a assessment of LA appendage before giving Cordron. So it is both for pharmacological and mechanical. So that is one thing we keep doing it actually. I think.
Thank you, Santosh. It's a very nice talk. One doubt regarding the anticoagulation in secondary prevention of stroke in AF. So most of the guidelines recommend direct starting of the anticoagulant, or there is a bridging with heparin, because I was not able to find that bridging. Is there a need to bridge with heparin, or you can directly start the...
We can directly start, sir. There is no recommendation for bridging.
Okay. Second doubt is, suppose somebody is already on warfarin and develops a stroke, you find that the INR is subtherapeutic. What is the next step? You increase the dose, or you change to another oral anticoagulant?
It depends on if the patient is eligible for NOAC. Now NOAC is preferred over warfarin. Some studies have, it is all non-inferiority trial only, but both ACCH and ESC have told that if the patient is eligible for NOAC, NOACs are preferred over warfarin. If the patient is in subtherapeutic INR, we can directly start on NOAC. If the INR is more than 2, we have to wait for INR to come down.
Thank you.
Definitely, that was a fantastic talk. It's a long marathon one, but I think everything was there. So it will be hard for another person to express it better than you. Thank you very much, sir. Santosh. Thank you.
Thank you, sir. I request Dr. Cherian to hand over the token of appreciation to Dr. Santosh. We may continue with the next sessions after a lunch break. So please be back within 20 minutes as soon as possible to chair the session.
Good afternoon. I would first like to thank the organizers for giving me this opportunity to make this talk. So the topic, this is going to be, there is nothing much to learn from this talk regarding data or whatever information you have, semantic data, that you can always read. This is basically related to the philosophy of stroke and how we came about doing this endovascular thrombectomy and understanding what is endovascular thrombectomy. Because most of the time, just reading the guidelines, we will not know. It is just always reading. They are just words. So what actually happens and all we can try to see in this. So for that, a bit of neurovascular anatomy also is needed. So the topic given to me was indications, timings, and complications of this procedure. So this procedure came about with guidelines from 2015 onwards, and before guidelines, this procedure was going on from the 90s to now. So it was there a lot of times before this endovascular thrombectomy in the brain, only that in the guidelines it has come in 2015. So I'll stick to this framework. Before that, I just tell about the anatomy. Some people have already told about the anatomy because it may be of help for me when I'm showing you the images. So this is the internal carotid which comes from the neck, and it divides into the middle cerebral artery here, which is the red, and you have the anterior cerebral artery here. The same thing here, the anterior cerebral artery joins to form the ACOM, and distal to the ACOM you have the A2. The internal carotid artery also gives, just before the division, it gives a PCOM, a posterior communicating artery, which communicates with the PCA on both sides. This PCA comes from two vertebrae which come from the neck, which joins to form the basilar in the medulla, and then it has a lot of branches and it divides here. So this is just the same thing here, where you see the arch of aorta giving the necessary arteries to internal carotid. The internal carotid has a nice C-shaped here or an S-shape here, and then it divides inside the brain into the middle cerebral and anterior cerebral, like a T here. You have a T here, you have a T here, you have a T here, and a C here, and this is the ACA. So this is about the anatomy. If you see the lateral view, this is the AP view. Lateral view, you see the C here or the S, and then you see the middle cerebral artery which winds like this and becomes, then you have the ACA, and you see posterior to the internal carotid artery, you see the vertebral coming here, joining to form the basilar, the PCA, then you have the different branches, the ICA, PICA, superior cerebellar. So these are just the major branches. Just to understand the major branches before we go into the talk, I just wanted to say the internal carotid, the vertebral, the basilar, the internal carotid, and the posterior cerebral connecting to form the PCOM here. You have the ACA here going like this. This is the ACA. So the overview of the talk, indications, timing, and complications, just as given to me in the by the organizers. So the first we will go with indications. So what is the primary indication when you need a mechanical thrombectomy? First, there should be a large vessel occlusion. So that is the first criteria you need to have. It has to be a large vessel occlusion. Stroke, basically, if you're dividing into vessel occlusions, you can divide into large vessel and a small vessel occlusion. And now there is also a medium vessel occlusion. But it is basically large vessel, and all vessels which are not large, you can call it a medium or a small vessel occlusion. So what are the large vessels? By definition, or what interventionists or anyone considers as large vessels are these, and also the vertebral artery which has not come. That is the internal carotid artery. That is a large vessel. The middle cerebral artery, which we call the MCA, that is a large vessel. The anterior cerebral artery, which we call the ACA. The basilar artery, which is formed by the two unions of the vertebral in the spinal canals, and the PCA, the posterior cerebral arteries. Inside this, the vertebral also comes as a large vessel. Basically, the ICA diameters will be around 6, 7. The middle cerebral diameters will be around 2.5, the ACA 2, the basilar 2.5, 3, the PCA is 1, 2 mm. These are all in mm. So the largest diameter is half centimeter of this, that is 6, 7, the ICA. So these are the large arteries. When we tell about small arteries, those are the perforating arteries which we see here. These are actually 1.5 to 1 mm. So these, no material has been existing to take out clots from here till now. So there is no technology for that till now to take out the clots. You can pass a wire if you want. So this is just the angiograph images which we routinely do. Just to tell about this angiographic images, here you have two vertebrae joining. This is the right V4 segment of the right vertebral. The left vertebral, you have the anterior spinal, and now both the vertebrae are joining to form the basilar. The basilar comes at the end and divides into the two posterior cerebral arteries. And the PCOM joins here. The PCOM you cannot see here. And where the PCOM joins, proximal to that is the P1 and P2. You don't have to know that. The ICA, the SCA are all branches coming out here. So these are the large arteries. This I just want to see the vertebral. You can see the difference. This is large. So a catheter can pass through. This is large. This is large. All the other arteries you see, it is small. So the distal you go, when it becomes P2, they say it is medium vessel. And more than that, it is small. So large arteries is what you can see properly with the neck in this is what is large. Here you see the anterior circulation. You see the ICA. This is the C. When it doubles back, there's an end-on view. So you see the C or the S shape like this. It divides. This is the T I was talking earlier. When you see the T, it means it's a division to the anterior cerebral and the middle cerebral. So these are all large. From here, you see it's all small vessels. These are all small vessels. So you do endovascular thrombectomy when these vessels are occluded, because this will cause the maximum mortality, morbidity. If you are getting a stroke here, it's not going to cause that much mortality anyway. Morbidity also with physiotherapy and rehab can improve a lot. So these are the why a large vessel occlusion is selected. So the first thing is a large vessel. So what we see, this is angiogram. We do not do it initially. First approach, even though there are centers now doing an angiogram as a first vascular imaging now. What we do routinely is a CT angiogram. So what you see as a middle cerebral occlusion, you see an occlusion here. So CT angiogram is basically like an ECG for us. But the problem with what it is paralleling cardiac illnesses and stroke, even though they are same, the investigative modalities are different. So because the CT angiogram costs more, difficult to interpret, contrast is involved, and a lot of problems are there where you know an ECG how simple it is. But this is how we know the vessel is occluded. There's no other way that we know other than in the acute period, you do an MRI and see the postmortem, which is the brain parenchyma. What you see the brain parenchyma is the postmortem study of the stroke. This is the antemortem what we can do before. So the occlusion is there, and if already there's an infarct, that means you are already too late to do. So these are the large vessels. This is what you do actually before selecting a patient for a large vessel. Now in the morning talk also I was hearing about the clinical thing of stroke. So this is where the most important thing comes in stroke. Stroke is still a clinical diagnosis especially in the window period, because there is no other way that because a good clinician should say that he is having a stroke. That is the first thing you have to do, because there's no other way to say that he is a stroke, because you're doing a CT, the CT is going to be normal. So which is the investigation? You are doing a potential life-changing therapeutic intervention in this patient with a basic clinical, on your clinical grounds only. So this is one of the few scenarios in clinical medicine where you do a very life-saving therapeutic thing on basis of only clinical grounds. That is the word of a doctor that this is a stroke. Because there is no other thing it is a doctor who is saying it's a stroke. There is no investigation, there is no test which is saying like a tropi. There is no ECG which is going to say. You are going to do a CT in most centers. So CT is not going to say it is a stroke. It is a doctor which is saying it is a stroke. So that is why clinical thing is the most important, and you to have the severity, and for communication between phone or between people, we know that it is a minor, because stroke can be minor, major, moderate, severe. You have to communicate fast because there is only 10 minutes to take decisions. So that is why the NIH stroke scale has come, or otherwise it is not that big. You can have any stroke severity, but this is what world over the trials have used, so people have started using it. You can also communicate that he has grade 0 power, he's not talking, he's not, you know it's a severe stroke. So that is also fair enough. This is for mainly research purpose and people, so that we know that we are doing well. Our outcome after the stroke treatment, how is it improving? It's a standardized scale. So we can use this. This is 1 to 4. This you can go through. I don't have to say. As I said, this is only about the philosophy of stroke. So what we see is when there is a large stroke, or even in a minor stroke, if there's a large vessel, this is what is a large vessel occlusion. You see the ICA which has been here. You see the T here, and you see in the angiogram run, there's a cutoff here. So this is a middle cerebral artery occlusion. This is a large vessel occlusion which we should be intervening. And this correlate radiologically in the CT is here. So this is equivalent to this, this large vessel middle cerebral artery occlusion here, the middle cerebral artery occlusion here. Always when you see the angiographic image, it is more stark and we can identify it well. So after you say that there is a large vessel occlusion, what is the next thing you do? The next thing you tell clinically it is severe stroke. Then you have to also see the radiological severity of stroke. That is by looking at the assess stroke severity by looking at how much of the parenchyma is imaged. Because stroke is all about the clinico-radiological mismatch. That is, clinically the patient is looking bad, but radiologically the patient is, the scan is looking good. That means there is a lot of penumbra to salvage. It can be any way you can assess clinically. It can be any way. You can do a CT, you can do MR, you can do MR perfusion. And the best modality is not all of this. This is a PET scan. But a PET scan cannot be done in the emergency situation. PET scan tells the functional nature of the brain the best, but you do not do PET scan. So the best we have now is CT perfusion and MR perfusion. to do. So here is just about aspect scoring. This has to be scored because if the aspects is high, the aspect scoring is something which we do from 10 to 0, where 10 is the best aspects you can have. That is, no part of the brain is damaged in the MCA territory. And 0 is all parts of the brain is damaged. This is developed in Canada, and this is also just like the NIHS to standardize everything you're doing. You can do it any other way. You can also describe it, you can send a photo, whatever. But here, this is the coordinate, 1 point for each score, and as each part is affected, you minus it from 10. So you have the caudate, large vessel, means the lentiform, the internal capsule, then the cortical areas, M1, M2, M3, then you have I, the insula. So you do it at 2 levels in radiology. If you are becoming a stroke physician, you want to manage stroke, you cannot actually depend on the radiologist to do this for you, because sometimes they may be busy and you have to take these decisions within 10 minutes. So you have to be well versed, and it is easily, you can do it actually. And this is the supracortical level in M4, M5 and M6. So total you have 10. And this is another, when you look at aspects, do not look at the brain window. There's something called the ischemic window where the window length and contrast is put at less than 35. And you can see the stroke better actually. When you put here, actually if you see here, I'll give another example. So this, you cannot make the hypodensity, and you should preferably see it on the CT screen where the machine is. So because there you have more contrast rather than in your computer which you have or the film. So here you see there is some contrast, but if you put at the window of this, you see that you can see the hypodensity. The gray-white differentiation is better in this window. So you do the aspects. So that is one. Then you look at the disability prior to stroke. If he's having significant disability, you do not have to do, because he's not going to be of that much benefit to society, or he will not go forward. So that also is important, though you can do, but guidelines say the MRS, what is that he should be walking, talking. So MRS has to be less than 1 for a good outcome. So that is why this AHA has come out with this guideline. So what we have covered in the previous slides is all these. That is, they should meet these criteria. Pre-stroke MRS score of 0 to 1, a causative occlusion of the internal carotid or the middle cerebral artery, that is the segment 1, the first segment, not the M2, that is more distal to it. And the age should be 18. That is not important because the age can be even less than 18. Trials can only be, it is because of trial design, trials can only be conducted above 18 years. Below 18 years you can, but it's very difficult to get ethical approval and you cannot do it. So that is why it is 18 years. So you can do it even below 18, we have done it also. And NIHS score of greater than 6. This is what I said, the stroke should not be mild. That is, patient is having a mild deficit or a dysarthria, having mild hemiparesis. He can worsen maybe in the next few hours. So, but at that point of time, the NIHS should be more than 6. The aspects, that is the amount of infarcted tissue should be more than 6. And the treatment should be within 6 hours. So this has a level 1 class A recommendation. That is the highest recommendation anyone can give any intervention here. So you have to do it. The benefit grossly outweighs the risk. So now let us look at other things. You can also do it M2 and M3. That is a level 2B. This shows that you can do in distal segments, not the small vessel, but the medium vessel. This is what is the medial vessel. But the level is 2B only. 2B means benefit, maybe risk. You don't have, I don't know properly. Studies have to come out. So it's not necessary that you, but this one you have to. Now, these all may change in the future. These are just guidelines. We go by guidelines, but we can break them if you are confident enough. So this is also the previous one. All the things opposite to this, that is MRS score more than 1. If you have disability, if the patient has a large stroke, if there is mild, if there is causative occlusion of ICH. So that also is 2B. You break all these guidelines and then you get 2B. And then finally, you can also do it with 2B recommendation in the anterior cerebral artery, the vertebral artery, the basilar, all the other large vessels which I've done. So the best recommendation is for the middle cerebral. This is because you can do it in all others. This is because the trials were designed like that, nothing else. So it just shows that the trials were designed. Does not mean you cannot do. But the trials were designed like that. So here you see there is limited data. So C has one thing also, which is CEO, expert opinion, which is a favorite of Indian investigators because we always have expert opinions. So in our expert opinion, we can do most cases. So that is why I said this is always too complicated. Every time we keep forgetting. Just to tell, we have this level A class 1 for the first indications I had told. So there is no class 3 in this. So class 2B's benefit may be also equal to risk, but mostly it will be more than risk. So these are the recommendations.
And I would also say about the concept of bridging thrombectomy. So what is bridging thrombectomy? Bridging thrombectomy is where you give the thrombolysis and immediately shift the patient to thrombectomy in your center or in a center which is outside if your center does not have one. So that is what is the paradigm or what we have to do. We should not wait actually. So this also is a level 1 evidence class A recommendation. That is, give the IV alteplase. Nowadays tenecteplase is used because it's a bolus, so it is easier, and you immediately ship the patient. And this is class 3, that is, you will cause harm. That is, this is sometimes done in some tenders. In patients under consideration, observe after IV alteplase to assess for clinical response. This should not be done. There are reasons why these are also given harm also, because, and this is also a randomized trial saying that. Randomized trial is saying that. So that is because of this chart, this study which was done. You see, this is the length of the occlusion or the clot. That is middle cerebral artery hyperdensity, that is HMCA, in millimeters. So as it goes, this is 1 millimeter, 2, 3, 4, 5, 6, 8, 9, 10, 20. This is the probability of recanalization. Over a lot of recanalization, they have done this with IV alteplase. So see the probability of recanalization when you do it in with 1 mm, very high, 2 mm high, 3 mm high. There is a point here around 8 that it suddenly drops. So more than 8 mm length HMCS, you see the probability of recanalization is like, what do you call, I think it is here. So almost 0. So why do you thrombolyze that patient? So you have to thrombolyze because the patient may not reach the other center. He may differ. He may say, I am not affording that. Or you may not be able to do the procedure due to technical consideration. Because there is still a chance. So you thrombolyze and you shift the patient. Because this patient is less likely to recanalize with alteplase or tenecteplase which you are going to give. So you have to thrombolyze the patient and immediately make provisions for shift and immediately shift, or if you are in there, you thrombolyze and do in the cath lab. In our center, because we have a cath lab with a direct to shoot approach, angio-shoot approach, where we can do a CT in the cath lab, we do the CT and we take up the patient simultaneously on the table itself. We can do that. So otherwise, if a center like DM WIMS, where you may not have an option of thrombectomy, you do this drip and ship hypothesis, where you drip the patient with the drug and you ship immediately, no questions asked. And with telemedicine coming up, you can easily discuss with the patient, and this is already approved in US FDA and also in our stroke guidelines. So this is a word about tenecteplase. Tenecteplase is going to be the future drug because of the bolus which you give, so it is easy to drip and ship, and you're done within 5 seconds, because that drug only takes 5 seconds, while alteplase takes 1 hour, and it has more fibrin sensitivity. And now recently with the ACT-2 trial from Canada, it has come, tenecteplase is extended to 4.5 hours, and the burden of proof, even though they are all non-inferiority trials, I don't think they will be able to design a trial with superiority, because already it is, clinical equipoise is lost, and it is showing that it is superior, tenecteplase. So that is going to come. So now we'll just go to a case which we had. A 78-year-old male with a dengue infection recently with coronary artery disease on double antiplatelets. He presented with right hemiparesis, grade 1 global aphasia. So what do you do first? You know that patient has a stroke. We made a clinical diagnosis. Then we look at the clinical severity. That is, NIHS is more than 21. It's a very severe stroke. His GCS is also low. He's 3 hours into the stroke. So you know this is likely to be a large vessel because there's a large deficits are there. So, so you do the CT first. You rule out a bleed. That is the first priority of a CT. By luck, if you have other clues, like this one, when you have a hyperdense MCA sign, you know that there is a clot already. So even an angio is not needed. You can take directly to the cath lab also. You can thrombolyze. You don't actually need an angio also if you're very confident of your hyperdense MCA. Then you do the aspects. Here you see there are not much infarcts in this area. Even though the window I have not changed here. And then you do the CT angio before we do that. So here you see in the CT angio, you see that there is no visualization of the ICA. There is supposed to be a vessel compared to this here. There is no visualization of a MCA or the ACA. So it is a complete ICA, MCA, ACA is not seen. So most probably it will be in the T I said, because I showed a T, right? The T, the thrombus will be a T-shaped thrombus may be there. So that is the most, and this much severe stroke. So you give bridging thrombectomy is what we have to follow as per guidelines. You give tenecteplase 14 mg at 0.2 milligram per kilogram or 0.25 milligram per kilogram, and then you immediately take to the cath lab. I don't know if this is clear. You keep a catheter or a sheath into the ICA, and you inject the contrast. You can see this ICA, you can just see it flowing, the contrast, very slow, sluggish. The ICA is actually collapsed here, and you can see it reaching here. Actually, it is a bit difficult to see maybe. So then you do something called the stent retriever. A stent retriever is this, where you deploy this device, like how you use a wire, and you deploy this device across the clot. And when you do it across the clot and wait for 1 minute or 2 minutes, this will gradually expand and encase the clot within and grip the clot. And then you do a balloon arrest here so that there is no antegrade flow, so that when you pull out, the thrombus does not go distally, and it is the gradient, the pressure gradient is favoring you. And then you have to pull out the clot. So you can see the pulling out. We are placing the stent retriever. And then you inflate the balloon and you pull out the clot inside. So that is stent retriever thrombectomy. And this patient, we did the same. It is difficult to maybe understand. You can see something going through this here. This is our stent retriever reaching here. And this is the catheter which you had seen previously. Because these are not subtracted images, a bit difficult. Here it is just reaching, it will. It is reached there, it's difficult to see actually. Then you pull it down like this. You can see something being pulled here and into this thing. And then you see this, the previous vessel which you saw, there was no supply here. You see the MCA filling like this. So there was a block there, and this is the thrombus which we got out of this patient. So these type of patients without that much infarcts and all will immediately recover. Some patients may not, depending on the core. When there's a large core, you will not. So this patient made a remarkable recovery. He was walking, talking, and saying everything within 24 hours. Otherwise, this patient would have had a large morbidity or a death. So there are these exquisite cases which improve. There are some cases which do not. It depends on how reliably you have estimated the core initially. If the core is not that is okay, you can do it. And it also depends on the materials and the technique you're using. So next, the timing. So coming to the timing, another case we will just go. So this patient has come 16 hours after stroke onset. So that one was 3 hours. So this patient has come 16 hours with left hemiplegia, grade 0 power, heminephrectic, and NHS 17. Again, a moderate to severe stroke. 78, this is also 78. So here you do an MRI because we want to know the perfusion also. Because it is after 6 hours, you need to know the perfusion as per guidelines. So here you see only small infarct. Patient has a large deficit when we are doing clinically. So that is what I call is the clinico-radiological mismatch. Even without a perfusion scan, you can understand this. You don't need this. Only with these infarcts and its clinical status, you know this patient is a candidate. So you see the perfusion. Blue indicates less blood supply or there's increase. You would have seen the radiology presentation, all these parameters will be increased. This is something else called arterial spin echo labeling. It also can be used. So you see the blue, green is where the blood is coming. So this is a mismatch here. There's a diffusion, small lesions, but so much. So if you don't intervene, these may get infarcted. This is the penumbra. When you minus this and this, you get the penumbra. So you see this patient and you see, this is actually the occlusion actually. There is a stump here. This is the ECA, the external carotid. The ICA is not filling here. And we do an aspiration, you see there is a stenosis here. So this is one of the ways we can understand the mechanism of stroke. You immediately understand this is an atheroembolic stroke. This is an ICA stenosis which has caused the stroke because you see a residual stenosis after aspiration. Then you see, take a shoot because blood will go through this. You see the middle cerebral artery is occluded. This is the ICA, ACA, this is the middle cerebral artery is occluded. So this is what we call a tandem occlusion. They usually do badly because there is occlusion at this site and also this. This, what has happened is the plaque has ruptured here and caused a complete occlusion that day, and immediately a thrombus has also gone up. So you recanalize this and look, the vessel has opened up here. And here, after recanalization, you see this was the perfusion deficit, and this we have taken after thrombectomy, this perfusion. And look, it has all become red and green. So this much area of the brain and perfusion we have restored in this patient. This patient also made a good recovery. And subsequently, to prevent further strokes, after 2 to 3 days, this patient also went a carotid stenting to prevent recurrent stroke. So this is another case. So this case, we have done 16 hours. So there is no, time is not at all that important we see. Here is another case. He has come with stuttering TIAs. A stroke has already been diagnosed. He has gone home. MRI is already showing an infarct, and he has gone home. Loading dose given, gone home. So multiple hospitals he has gone. Then finally he comes to us in 6 a.m. with 12/7 on 20, with a large stroke. So and he comes within 4 hours. So at these instances, it is very important to take the time when he is worsening as the index time sometimes. And not look at the past history of stroke is there, we cannot do management, there is nothing. If the past history of stroke is mild, because all depends on what is the core. If you have, the blood-brain barrier has only broken in a small area of the brain, it is okay, you can go ahead with any management. But if there's a large area of the blood-brain barrier is gone, because then the risk of bleed is high. So this patient, large stroke, NHS 17, aphasic, right UMN. So here again we see the old MRI, you see only small strokes, but he's having a large deficit. Again a clinico-radiological mismatch. You see a SWA, this is not needed. So you see there is no vessel in this side of the brain for this patient. There is no vessel in this side. There's no vessel in this side. So you look at the perfusion again. Here you see a lot of blue. There is no blood coming to the left side of the brain. So you take a shot. So this is, I have taken a shot in this patient of the right side of the brain. So here if you see, this is why this patient has not deteriorated, and some patients deteriorate in the first 6 hours when the initial stroke itself. Because here you see this much blood is coming from this side via the anterior cerebral artery where you call the pia collaterals, and it is supporting this side of the brain. This is what we call an ambu bag in neurology, like an ambu bag it is, because it is going to give the ambu. Just like in medical colleges, we may give the ambu to a relative, and the relative will keep on, and she may overnight, she may sleep, and the patient may die. So this happens, and this can only sustain for some time, because he is just ambuing this side of the hemisphere. So this is the leptomeningeal pia collaterals. So that is, in this patient, this was there. So that is what, and this is the opposite side where there is, this is the block. No, not the block, the blood is not going. It is stagnating, see? It is not going. This artery, it is not going. We are waiting, the blood is still remaining in the neck. So then we did a shoot. This is another ambu bag. So there are a lot of ambu bags in the brain. This is what I wanted to stress, which is called the collateral circulation. This is a collateral circulation from the ophthalmic artery actually. So sometimes patients actually have retrograde flow through the ophthalmic, supplying the ICA and then supplying the brain. These patients may complain of blurring of vision occasionally when they are exerting all this thing. So here this patient has an ambu from the ophthalmic artery coming here. This is the corresponding anatomy. Look, the ophthalmic artery comes from here. So this is this segment is this segment. For better understanding, I have just kept it there. This segment is this segment, and this is the ophthalmic artery. So this is supplying it retrogradely. The ophthalmic is supplied by the external carotid artery. Many collaterals are there. So that is how it comes. And so here you see, we did a thrombectomy here. Prior to this image, and you see there is some opening. So here we can say this is also ICAD. So see this image? So this is slightly opened up. This is actually a severe stenosis. And this is a long-term issue for this patient, and which has completely occluded today. Because of this collateral development, he is still sustaining. It may fail in the next few hours or days, and he may get developed, go on to, these are the strokes which come to you in the hospital, and you say it is okay, and you send them back, and then they come with bad strokes. Not all strokes may come, but these are the strokes which do that. So the ophthalmic, so we did an aspiration. You see this channel opened up, but this channel kept on closing again. Usually this closes. So just like that, we may have to stent it. So we did a stenting also of this. So you can also stent. This is the stent which you see. If you can see the stent here. So stenting also can be done in these patients safely in selected cases. and intracranial stenting can be done, which you can open. So this patient immediately, this was one of the remarkable cases, immediately on table he started talking and this thing. Not all cases are like this, but he was fully normal. This is after the ICU, but on the table itself he started. We know because he will immediately start thrashing about. Till that time he would have been quiet. So this comes to our question, why is the cutoff 6 hours? It is not 6 hours, it is actually 24 hours. But it should be in selected cases. Why it has come like this, you should go back to the history of why it has happened. That is when the initial IMS-3 came in 2013. This is one of the few trials in which actually, when we had, when I was doing my MD, and I had my neurology posting, my neurology HOD, James sir, had asked me this question: is there option of endovascular thrombectomy in stroke? Then I didn't answer. You do not read any journals and all in MD. So he told, no, now the word is out. That is because the IMS-3 trial had come. Then I got admission. I was in Sri Chitra and the stroke specialist there, Shailaja madam, asked me the same question in 2015. Is there any evidence for endovascular thrombectomy in stroke? Then I said no, very confidently, because this thing. Then madam started giving me eyeballs and told, you do not know anything. Because that is how it has flip-flopped. This is something which has flip-flopped from 2013 to 15 to diametrically opposite. That it is a story in itself why it has flip-flopped, but it is because of trial design issues and the people who are doing the trial. So what actually happened in 2015, people who were doing this interventionists got together and put an arbitrary cutoff of 6 hours so that they wanted to beat IV thrombolysis, and that is why the 6 hours cutoff came. Ideally by trial you should actually have for 24 hours, not for all patients, but by assessing 24, because I will show you a graph which will come again, why 24 hours is taken. So this is the diffuse. These are two trials which you need, the diffuse 3, which kept it to 16 hours by using penumbra imaging with perfusion. Then I'm not going into this. I think it will be difficult because these all showed very much. These are trials which had to be stopped midway because the benefit was too huge that they could not randomize. This was also the Dawn trial which extended to 24 hours. These are all stopped midway. So finally we had come to this. So this is the indications coming. So within 4.5 hours, you can give thrombolysis. Within 6 hours, you give if it is within 4.5 hours, you can give thrombolysis with thrombectomy, bridging. Within 6 hours, you have level 1A evidence. Within 16 hours, you have level 1A according to Dawn and diffuse. And according to 24 hours, it is level 2A because only Dawn did till 24. After that, you cannot conduct a trial because when a clinical equipoise is lost, that is the benefit and risk is lost, then you cannot conduct an RCT because you are causing harm and ethically it is wrong. So no one can conduct a trial again in the first 24 hours of stroke using these criteria because it is already proven, and otherwise you would cause harm to the patients. So these are the cutoffs. So till 24 hours, potentially any patient has a potential for an emergency stroke intervention. So that is how we should always be vigilant, especially if it is in the 24 hours. So we come to the time is not entirely brain, and you come to the concept that the collateral is brain. So what actually determines your pace of how the stroke evolves is the collaterals. That is by this graph, you see the patient has a core which will progress over hours, minutes, and the rate of progression is different for different people. This is what is seen. This is the time onset. This is the ischemic core volume. Some people are red, so fast they progress. There are people who progress so slowly. So the fast progressors, the medium progressors, and the slow progressors. So you have to know whether it is slow or a medium or a fast progressor. So these patients can be therapeutically intervened even. But this patient, even if you get this patient at 2 hours, look, the ischemic core is 120. You are not going to actually improve the patient. So those are the patients when you do in 2 hours and say patient has not improved. That means that the core is high and you have not, if you do the aspects properly by windowing and all, you can, a good stroke neurologist or radiologist can tell the aspects properly. If you are seeing in the CT console and you are actually correctly doing it, you can tell the core. It is our inadequacy to identify the core and the penumbra which leads to problems. So this is another graph. You see the time between symptom onset and baseline and the baseline diffusion volume. So if the baseline diffusion volume is large, that means he has a bad prognosis. But if the baseline diffusion, easier said is this sentence. If you have a diffusion volume of 25 ml and you see it at 1 hour after symptom onset, and you see the same diffusion volume after 8 hours, the 8-hour fellow has a good prognosis rather than the 1 hour. That means because after that 1 hour, in 2 hours, he go to 50, 75, and within 3 hours, he would be infarcted completely, whatever. But this is going to progress slowly. Because of why? Because of this collaterals. That is what is shown here. Here you see 2 hours large, and you see the small ones here coming, it progresses slowly. So anyway, it is difficult to understand the graph. And initial diffusion lesion volume is an independent predictor of clinical outcomes. This is one graph which you can try to understand. Here, it is a time from onset here, 20, 40, 60, 80, 100, 120. And this is the lesion volume, that is the diffusion volume. Here, patients who had recanalization, these patients who had not understandably, patients who were not recanalized has a larger stroke. But here you look at where it is plateauing. It is between 20 to 40, roughly between 20 to 30, around 24 hours. So after 24 hours, it's a plateau. The infarct is not progressing. That is why you keep a cutoff of 24 hours. These are from studies. That is, after 24 hours, usually if the patient is remaining in that same clinical status without worsening, he is unlikely to progress if it's a large vessel occlusion, not for lacuna. There are other mechanisms of progression of stroke, so unlikely to progress. So just a few words about collaterals, if you can, I will try to understand. This is, you have an artery, you have a block. Now, many ways this blood can reach post-block. You can have these collaterals, which I showed earlier, the leptomeningeal. Then you can have a flow through the clot. That is called clot perviousness. When you can go through the clot also. So some blood goes through. Some clots are pervious. There are measures from the CT, you can measure the clot perviousness. If the clot is pervious, that means he has a good outcome. Then you can have retrograde flow from the vein. So lot of measures how, so all thrombus is not equal. There is red thrombus, white thrombus, fibrin-rich, multiple. So it depends on that also. So that is why the cutoff is 16 to 24 hours according to Dawn, and 6 to 16 again. So basically you have to do in 24 hours. These are the Dawn and diffuse criteria, because the guidelines also says you have to follow this. So you have to keep this, and if you want to strictly follow the guidelines, these are the guidelines which you have to follow when you are taking between 6 to 24 hours. So just about collaterals and why the collaterals is brain. There are two types of collaterals, the primary collaterals and the secondary collaterals. Why I am saying this is, if the patient is having a primary collateral which is ambuing him, that collateral can ambu for life. While if it's a secondary collateral like the leptomeningeal collateral which is shown earlier, it will not be able to ambu for life. It ambus for maybe 1 to 2 days, maybe few hours. So this is the primary collaterals. The anterior communicating artery, it is an artery given normally when you are born. So that is why it's a primary. This is recruited collaterals, leptomeningeal. So you have PCOM which is given when you are born. So that also is their primary collateral. While these are the secondary collaterals, you have from the external carotid, the posterior cerebral, you have a lot of these communication. So here just an example, I don't know if, look, this is what I said, from the ACA, you have the collaterals here, the leptomeningeal collaterals. Here you see, this is a case of a basilar occlusion. You see the basilar is occluded here. Okay, but this patient has collaterals which are coming from the, see, this is the PCOM. This is the ICA which I told, the PCA is back. So look, it is supplying actually, whatever is supplying distal to this occlusion, this artery is supplying it. So this has a good collaterals. You can intervene and take this clot, he will not worsen. So this artery will supply this, and that is a primary collateral. Now this is another strong. See, you have an occlusion here, you have to understand. There is no blood supply here, we are not taking a shoot. But why this collaterals? This one artery is supplying the entire brain. Not the entire, both the anterior. This is the ACOM primary collaterals, through the ACOM here. So you don't have to intervene in these cases, sometimes if the ICA is occluded. And then you have the ECA collateral which I had shown earlier. This is the ophthalmic artery actually supplying, this is the internal carotid. So this is also a secondary collateral. Then see this case actually, this is a case where patient has no bilateral carotids are occluded. So patient may come with a mild stroke. And what will happen is you will see carotid occlusion, you will try to open it, or you will try to thrombolize, and you will maybe migrate the clot up, or this thing. This patient has only maybe a small infarct because of hemodynamic nature, and the right vertebral is supplying the posterior cerebral, the extreme collaterals, that is the bilateral MCA tertiaries also. So one artery of the brain is supplying. So this patient, if it develops a vertebral occlusion, he dies on the spot because he has no other blood supply to the brain. So that is what is collaterals, where if there's no one road, you take the other road and go. So you have to understand this. I told all this because I know it is difficult to understand the neuroanatomy, but that is why we are actually, because this was one doubt which I also had in MD, because when we in rat experiment models or whenever we are told, you say that within 5 minutes the brain cells die. Then why you are saying 4.5 hours, why you are saying 6 hours, why you are saying 24 hours? Brain cells die in 5 to 10 minutes. And those are some brain cells, but there is some area which does not die, and there is blood coming into it. And if the blood coming to this is going to sustain him for life, that is enough. You don't have to do a procedure itself. So you have to prognosticate whether this will go, which will sustain him in the next few hours, days, or for life. Or you understand, and then you do. Or whether, I'm okay with a small stroke, the collaterals, there may be hemodynamic infarctions, and you go ahead. So understand the concept that collateral is brain rather than time, even though time is important, because whenever you detect, you have to do everything fast. So next, coming to the complications, my last part of the talk. So you can divide complication into access site because we go through the femoral artery, or you can, and what happens in the brain. So the first access site is, everyone knows it's a groin hematoma. You have a hematoma in the groin. It's a bad, it can happen because you have given double antiplatelets, you have thrombolized, you need to give heparin when you're doing the procedure, etc. And a hematoma can open whatever your best. So, and you can lead to pulse, and you can also lead to amputation of the limb itself. Though with current monitoring and all, it is very less. This is one complication which can happen. Then you have a groin pseudoaneurysm, where the vessel can form a swelling. And this also can cause all these complications. So this is just to understand, because I do not have to say too much because there's no use. Then you can have bleeds. Bleeds happen most of the time due to a large infarct core when you are reperfusing the damaged tissues. So otherwise, if there is not much core, bleeding will usually not happen. So so these are all you can see bleeding into the infarct. So that is what is called a SICH. One important thing is, if you take MRI, most of these cases you will see some blooming. That is called reperfusion. There is something called a good bleed for us. A good bleed is that shows that you have opened the vessel and the blood has reached there. It should not cause any mass effect, no rounded feature, etc. So these are all bad bleeds. This is not a bad bleed. It's in the infarcted area. These are all bad bleeds. So that is why we call symptomatic ICH. There is a 4-point drop in NIHS. Then you say it is a symptomatic bleed, because you may have bleeds without any symptoms also, especially when you're doing the procedure. Then you have an SAH. So here you see the SAH here. That is bleed into the subarachnoid space. These are SAH. That can happen because you are doing a procedure, you can dissect the vessel, and that is a known complication of that. So you can have a very bad dissection, where in the angio itself you know this is dissected, like you see a puff like this. That means you have dissected, and most of the time the game is up when you see a large dissection. The small dissection which I had shown earlier, we will not realize during the procedure because it may be due to some rent. This one is a big, you have a large bleed. See, after the procedure, the vessel is looking good from the initial vessel, but the patient has a large bleed, so much this thing, he will not have a good outcome. But you can show angiographically it is good. So many of the time, there is something called futile recanalization. So that also you have to understand that futile recanalization also exists. And this is a dissection. You can see a false lumen here. You have stented the dissection here, actually. False lumen. When you push the catheter, the wire, all these are iatrogenic complications. Some of the time you cannot differentiate if it is iatrogenic or initially there also. We do not say. And as interventionists, we always like to say it was already there. This is another article where another image where this is called spasm. So much spasm is happening here. That is when the vessel constricts. And this is one of the most commonly documented intervention where we call embolism to new tertiary. You go out to see, do a thrombectomy, and when you're taking out the clot goes somewhere else. So it has caused infarct in that tertiary and in a new tertiary. And the new tertiary may be a distal tertiary we will not be able to reach with our devices. So, and sometimes the clot will migrate to an end artery, or what artery was supplying the collaterals, it will migrate. So most of the time when there's an ICA only occlusion, what happens, if you are usually when you only have an ICA occlusion, you are that is in the proximal ICA in the neck, it is not going to cause much problems. He will usually survive. But when you try to take out the clot here, the clot fragments will break and occlude the MCA. So that is a new tertiary infarction. And what commonly happens, another is actually, here, the ACA is always poised like this. So when you take out the MCA clot, the clot becomes, for a brief moment, it comes into this junction where the jet of blood will cause it to go into ACA. So he will have a double whammy of having an MCA and ACA occlusion, and he will not make it. Sometimes if it was only an MCA infarct, maybe he may make it, but once an ACA is also infarcted, all abulia, everything else will come, and he will not go for physio, and everything will be bad. So these also can happen. Small embolism to new tertiary, it will be okay. So, but that can also happen. So this was about thrombectomy, and there are also other indications which we do an endovascular thrombectomy. I would like to end with that case, which we had recently did. A patient present with abrupt onset, I think this patient came from Wayanad itself. Abrupt onset left hemiplegia of 8 hours duration. Recently diagnosed diabetes, associated headache and vomiting. So actually this patient, we had done MRI, and everything was normal. And then only someone had pointed out there is something else, because patient came for mechanical thrombectomy. Then we are not seeing any vessel to do thrombectomy. Then we are taking there's something wrong. He's complaining of headache. When we complain of headache, CVT is one, but we usually, when thrombectomy, it's dissection also causes headache. So, or spasm. So then some radiologist had told us something, and then we looked closely, we did a CT. You see the transverse sinus, you see this white, which is suggestive of a clot. So this was basically a clot. Actually, the infarct was like a ICA dissection. In this, I'm not showing that because of want of time. So there is basically a transverse sinus thrombosis here. So not only the transverse sinus, if you look, you can see the IJV and all is thrombosed. So large, and see here, so there is no contrast filling here. There is no contrast filling in the superior sagittal. So he had thrombosis of, this is a thrombus in the superior sagittal. He had thrombosis of all, and also the left also there was no outflow actually. So he was having severe headache. Every day he used to, only 48 hours, every time when he was having headache, he was going to bradycardia 35, but he was preserved. Usually do this. So what is another option? We were giving heparin infusion, etc. He had early papilledema, and his headache pain score was such that he was not allowing you to touch anyone to do anything. He's young, 24-year-old also, subsequently found to have APLA. So then because he was going to bradycardia, so much raised ICP, we thought we would do what is called a venous thrombectomy. So thrombectomy can be done in the venous side also, though not common, because our medical management is 80 to 85% of the time superior to intervention in venous side, because in short-term outcomes. Long-term we never know, because sometimes the thrombus, everything will not come out with heparin only. So we had all these considered, I'm not going. So this is, I'll just show these and end. So this is his shoot initially, prior to the procedure. Usually this is what we call in an angiogram the arterial phase, this one. Then it goes into a capillary phase where you see the puff. Then it goes into venous phase. So here you are not seeing any much veins. Okay? This is the lateral view of that, where you see the arterial. You are supposed to see a superior sagittal sinus like this here. You are not seeing anything. So we know that it is occluded. Then we went ahead with we punctured the IJV actually in this, because it is easier to reach. You can see the thrombus here actually in the IJV. This is how you see the thrombus in an angio. You can actually visualize it actually in an angio. So this is how you see the thrombus. See this white here? This is the thrombus here. Difficult to this thing, okay. So we took a catheter here. You can see the catheter going up. See it negotiating the IJV. Then you can see it going to the transverse sinus. Then you can see it entering the superior sagittal sinus. And then you are basically aspirating it out. So you aspirate it, and then you see you pass a wire also to go more distally. So this is basically, we do the same procedure of aspiration compared to stent retriever. And then you take a shoot. See, the sinuses have opened up here. These were the sinuses here. So, and you see the image here, which I said the arterial phase, the capillary phase. I see the before and after, so it is easier to understand. So in the before image, you are seeing the arterial, the venous, the capillary, then no venous. Here, see the venous? It has come up. So you have completely opened up. When you give heparin, this does not open up fully. What happens is long term, he may have raised ICP, IH like presentation, because every IH, usually people say, is nothing but a thrombotic episode which was not discovered because of, or some other cause it may be, but it may be that people say. So, these are the, and you will be surprised to see, so this much clots we could get out of this patient for this. So venous thrombectomy, it is routine, this much clots. So with heparin only, this may not come out. And it will take so much time, he may go into cerebral edema. So that is why we intervene. Not in all patients we intervene. Especially with a malignant raised ICP, the patient is having obtunded with medical. So basically endovascular thrombectomy in venous is when medical management fails. That is the guideline. So that is how stroke treatment, the difficulty for understanding stroke treatment is when we were learning, it was only aspirin and lying down. Now it has gone to IVT, mechanical thrombectomy, and also into intracranial stenting, and it has evolved. That is, a lot of people have to take up more, and stroke has changed a lot. This is our team, our neurology team, our cath lab team, and to do all this you need a team, because you cannot institute with only 1%, 2%. So much departments are involved, so many people are involved to shift, and to do it on a regular basis, it requires a lot of economic, technical, lot of things are needed for this. So these are just the clots which we routinely get through all the visions. Thank you.
Thank you, sir. We can have an open discussion on this topic.
Yes, we have what is called the Lazarus effect, which it is documented, and we occasionally have that in cath lab patients, where just like Lazarus in the Bible, when Jesus had gone and asked him to get up, he gets up. So immediately after the thrombectomy, he will get up. So it is documented in literature, and it happens also. That is the best possible outcome.
Be taken up, like
not with large vessel occlusions.
So if somebody has come with 0/5 power, after thrombolysis within 1 hour you are seeing a power of 4/5. Is he a candidate for referral?
If it is a large vessel occlusion, you have to, even if it improves, it may be just a transient improvement. The clot, we have cases of that also. The clot will be partially recanalized, again the clot will come. So if it's a large vessel occlusion, even if improvement, the patient can deteriorate afterwards.
Even if it's 5/5.
Otherwise, what you have to do is you do a CT angio again and show that the clot is not there. Then you can maybe keep the patient.
So if it is a partial clot we are seeing in a CT.
Partial clot is difficult. It is difficult.
It's like then also we have to.
Yeah, you have to because it can again organize. Even for us also to do the procedure also it is difficult when it's a partial clot. So sometimes we may just observe, and whenever the patient deteriorates again we may take, because if you have new materials it is okay. We mostly reuse materials. So when you go up in the brain to capture the lumen etc., clot it is of fear of distal embolization.
Why the use of heparin is so low in like even if you are seeing a partial thrombus, still in neuro you don't give heparin, or is it given?
Yeah, heparin, it all depends on how much of the brain is infarcted. If the brain has not been infarcted, the initial 2 cases I had shown them smart, you give how much heparin you want, it is not going to have a problem. But if the brain is largely infarcted, there is always a risk, because as such, if it's a large infarct, even if you don't give aspirin, any heparin, there will be a hemorrhagic transformation. That happens when spontaneous endogenous recanalization of the vessel takes place a lot actually, which we will never know. And that is the reperfused tissue which we see. So there will be a hemorrhagic, some of the bleeds may be, sometimes the radiology is infarct with hemorrhagic transformation. We wouldn't have realized, especially in the right MCA territory, when it is in a non-eloquent area, and the patient comes with headache after a few days, especially PCA strokes. You see PCA strokes, patient will have some bleed, and it may be an infarct with hemorrhagic transformation. A lot of patients will say it is a CVT, we have misdiagnosed. So it depends on what timeline. That is why a good history on what exactly the patient had. Sometimes PCA you may not be able to see because of visual issues, but still good history on the onset. Stroke as a neurologist, because initially the second talk, so much localization. I hardly rely on localization. I only rely on the onset of time, onset of the symptoms. Because the abruptness of the symptom is the most important thing in diagnosing, I think, any vascular event. Rather than where it is, because multiple territories can be involved. The collaterals may be poor, so the initial stroke can present with a loss of consciousness, seizure, anything, not necessarily a bleed. So a lot of things happen. So the abruptness of the event is the most important thing in diagnosing a stroke, because you have a numbness of the hand also, can be carpal tunnel, but you have to take the history that when the numbness started, so was it on waking up, or so that you have to keep on pointedly asking, because the patient will not say. And always to err on the side of caution nowadays, because when we were learning, taking an MRI was seen as a sign of our lack of knowledge or lack of this thing. But now I feel we should take more MRIs and see whether it is having a stroke, because it is not to prove that you are actually good in clinical this thing. Even if an MRI is not showing a stroke, you immediately tell the patient, okay, it's not going to cause much of a problem, because the patient is coming with that actually, whether I am having. Even when a patient comes with a carpal tunnel syndrome, he is not thinking about carpal tunnel syndrome. He is thinking only about stroke. So I'm not saying for doing for carpal, but I'm saying like whenever you have a suspicion and you have, because nowadays the MRIs in the screening diffusion cost hardly 2,000 rupees. So it is not like the olden time when you have to catch a bus to Trivandrum to do an MRI, because there were times when they were there, when only it was there and you have to do that. It's available. So intracranial stenting can be done in two scenarios. One scenario is when it is an emergency, when we are doing the mechanical thrombectomy, which is called rescue stenting. And then is another scenario is when you do an elective stenting. So when you do a rescue stenting, it is difficult. These are all, you cannot have guidelines, because there are minimal population, you cannot have an RCT. So what we say is, this intracranial stenting, you have to have an atherosclerotic disease initially, or a dissection. So both of that you can stent it, otherwise the lumen will again collapse and cause this thing. So what happens is, when you do a thrombectomy, as I showed in one image, after thrombectomy you will see a faint flow after the aspiration or the stent retriever, whatever you have done, which is making the lumen to just before the worsening picture. This atherosclerotic plaque was there for maybe many years, months or whatever. It has become unstable and ruptured and caused a complete occlusion. So if you have faint flow, then you wait on the table actually and see how the flow it is going. If it is again reoccluding, if the infarct is not that high, and you can go for a intracranial stenting. But the problem is dedicated intracranial stents are costly. So most of the time we use coronary stents. So coronary stent, the risk is high, to navigate is more high, but we do with coronary stents. Then there is, so this is for intracranial. Then if you have caused a dissection, so dissection, the flap will open, the blood will go into the flap and it will keep on occluding the lumen if it is going on. Sometimes the dissection will settle on itself and we don't have to. So if there's a dissection, you may have to stent it. So it all depends when you're stenting how much the patient is infarcted, because you have to give double antiplatelets, especially cardiac stents. So double antiplatelets when you're giving, if there's a large infarct, there will be hemorrhagic transformation, patient has a bad outcome. So either if you do that, there's a chance of killing the patient. The other one, the patient has a large disability only. So you have to, what risk you have to decide on table. And some of these ICAD will have extensive collaterals. So that is when we do the angiogram, we see the collaterals, we will know how much this patient infarct will progress, we will know and we can decide based on that. It's an angiographic understanding of that collateral is how much is there. But elective stenting is when, by guidelines which you see, there was the initial Sampras trial which failed because of using the wingspan stent. Out of that, intracranial stenting went into disrepute at that time. So now it is coming back, and Sampras data also, out of selected data when you are analyzing, it shows benefit. So basically now you have to do intracranial stenting when there is a tight stenosis. Patient has a stroke, you give double antiplatelets. On double antiplatelets, if the patient is again best medical management, if he is again getting a stroke, he can be considered for intracranial stenting.
Dr. Paul, very good talk. One doubt is regarding bridging thrombectomy. So suppose we are giving thrombolysis and then planning for this thing. So is there a time limit within which thrombectomy has to be done, like following thrombolysis?
Immediately.
As early as possible.
Immediately. Because if you have a cath lab, that's what I said, in our cath lab, now we have the latest cath lab, we do the CT inside the cath lab and we do the thrombectomy that time itself.
Okay. So for example, we are sending somebody from here for a thrombectomy. So it anyway will take 2 to 3 hours to reach there.
The thing about sending long distance for thrombectomy, by what we say by dictum, is that the imaging what you have done is valid for 1 hour. It may be even less than that. It may be even more than that. So we always repeat an imaging to see if the patient, our problem is that patients have to benefit. They are paying patients. If you are not paying, you can do thrombectomy for everyone. Because now trials are coming out in even low aspects, which I showed 1, 2. It has come out 2 days back or something, one trial had come saying that there is benefit even for low aspect. But that benefit is a patient lying fully out without talking to some talking and some listening. So that what you call resolution will not be picked up by our population who are poor and this thing. So, but in Western countries where this is entirely paid by the government and the hospital or the insurance system, so those are why the guidelines. So you cannot imply all these. So we do not follow all these as such like this. We have to look at the patient also, how much benefit.
So when we want to send somebody to a different center, we thrombolyze here and then send them there. Yes. So the only thing is you will repeat an imaging there before.
So that is why you have to do a vascular imaging.
Yeah.
That is why always you have to do a vascular imaging. However, how much you go into, how much you, because most of the time they will say sedation issue, this issue, but somehow you have to get it done. Then if the vascular imaging is showing no problem, you don't have to refer. No one is going to do anything more than that. But if the vascular imaging is showing a problem, and then because many other issues can crop up, that has to be offered to the patient. Otherwise, at least tell the patient, this patient is, we are having difficulty to sedate this patient, perform this. If there is a large vessel, this patient may not do that well. Communication and giving option. If they are not taking the option, it's okay. Then you are safe. Because what happens is, even the poorest of the poor patient who comes one day, you think the tribal or whoever is there, well, next day someone else may come. And they may ask the guidelines and this thing. So always in this era, it is always good to offer, not to do maybe, but offer.
Thank you.
This is regarding thrombectomy. What is the smallest arterial diameter where you can do thrombectomy?
So
just because you said posterior cerebral is 2 millimeter or something like that.
You can do in M2 arteries you're doing. The middle cerebral artery from M1 then goes to M2. Then the A1 to A1 to A2. So till A2 and PCA also you are done. That is around 1 to 2 millimeter. There are stent retrievers for that. You can do for, there's a small stent retriever actually for that. The problem is we are always reusing materials. So problem what happens is you have to open the new stent retriever. So when you are opening the new stent retriever, cost will go to, a stent retriever actually costs 2 lakhs. So we are doing actually for 50,000 and all by reusing actually. So when you are, if I am getting a stroke, I will ask them everyone to open the new only, even if I am paying. But if any, I feel doctor or any educated person is doing it. Because that is worth the money. Because you only have one chance when you are taking. Distal embolism can happen. So many things can happen. So that has to be done well like that. So 1 to 2 mm.
Thank you.
The smaller it is, the risk of bleed perforation is higher. So our difference from what cardiology, what you have, because yours is all atherosclerotic, right? Atherosclerotic disease, 99%. We have some other things called small vessel occlusions, lacunar strokes, where hypertension is an etiology, where lipohydrosis is an etiology. That is one. Second, we also have this cardioembolic, where it goes from the cardiac. Then we have the atheroembolic, where it goes from the athero. So those are three other mechanisms. Then in situ thrombus formation by rare, like APL, that may be happening in your also. So no, it is actually, if you tell the percentage, cardioembolic will be 30%. This intracranial atherosclerotic disease, India it is very common, China and India. That is mainly, they say it is genetic. It is not, I don't feel it is genetic. It is due to poor control of vascular risk factors, poor lifestyle choices, and our overall lack of no sleep, more stress, and always working for people. So where Westerners have a better lifestyle. So, that is coming to 30%. Then small vessel around 25. And the other rare again 10, 20. So it is 30, it is fairly equally divided. It is not 95. So there are two mechanisms where there is stenting. One is for the hemodynamic aspect and one is for the atheroembolic aspect. So when the clot actually, it can go from the atheroma when it becomes unstable into a distal vessel. And it can also cause a stenosis. Overall, in brain, even if it is 90-95%, it will not cause any hemodynamic issues that much, usually. To the extreme, it does not cause us. Most of the devastating things come, like if it is the ICA, when the M1 is occluded, when there is atheroembolic, and the target end organ is this thing. When it is, but when you know the stenosis is there, that is a jet of vessel is going through it. So it is like a dagger. So it will keep on injuring the endothelium. It will never be stable. So at any time, you can have a like a embolic phenomenon also in this. That is why it is always good to stent. But actually in cardiac also, in UK and all, guidelines are coming out. Actually, you should not put that much primary. A lot of guidelines are coming. Actually in India, we are aggressive. We here in brain, we cannot afford to be aggressive because of the hemorrhagic risk of complication. And we see a lot of patients are doing well. Our patient, when they see, because even for us, when you do an angio, we show a big stenosis and we say, don't do anything. That is the most important. So, but the patient knows that there is a problem. But in heart, you can safely do it. So you are doing it. But whether it is of benefit, we do not actually know in large population. We will not know, but if you can correct it safely, so that is why the carotid is routinely done, because it can be done safely. Intracranial, it can be done safely, but the materials have to evolve. The cost also has to be acceptable to use that. So everything can be done, but it is just that science also has to catch up.
So it's maybe simple to say. So what is the damage of the carotid artery? What do you have to do stent? I'm a pediatrician, so it's maybe foolish for you.
No, it is not. These are questions which we also have difficulty. So it is 6 to 7 mm.
So you have to minimum 6 to 7 mm?
Yeah, routinely we use 6 mm stents in the carotid artery, in the bifurcation. 6 to 7. It depends. Some people you will actually see it is very small, 4 mm. Some people you see it is very big. So many variations are there, but it is usually we use the 6 to 40. To all these stents, the latest stents are built to accommodate. Like this, it has some expansive and elastic property and all. So we do not use, we use dedicated carotid stents.
So 6 mm damage is there, then perfusion will be fine.
No, perfusion may be fine. That is what, if you see this also, actually, frankly speaking, if you see perfusion deficit also, he may be walking about okay sometimes. Perfusion may be decreased, but that is only needed. Because why you use, no one uses the brain. No one uses the brain. You do not use the brain most of the time. Yeah, we only use that much, and also people are not using the brain most of the time. So it's not like the heart where you have to run and this thing. Brain is less commonly used. No, we always compare with the heart because we are always jealous of the cardiologists because they get to do a lot. We have to. By guidelines, you should not be doing because it will be unethical, they say. But there are protocols where it takes extra 2 minutes CT perfusion. So in centers, I think they do CT perfusion, but perfusion is not needed. But actually in a good stroke setup, I don't feel any harm in doing CT perfusion, that extra 2 minutes. You get a lot of information if you are going. Data is what is important to make the decision. So that is why I always say MRI is always better. Because MRI, you get a lot of data, especially in other Western, all people are doing, they just have to follow guidelines. What complication happened, they don't have to worry. We are not like that. So our Westerners cannot also schedule an MRI like that. Ours, the MOD will be there, stroke is there, you pull out the patient cannot say anything. There they can sue you if your appointment is not met for MRI. So they don't go for MRI protocols unless you have MRI. Here there is no respect for patient. No, not like that. That is good in one way also. You can get the MRI done faster and you have to compromise on quality, 4 or 5 minutes, you can do that. So big centers, they will not dare, like AIMS, Sri Chitra, Nimhans, they will not, Vellore, they may not compromise. They will keep on saying CT. But for poor corporate hospitals like us, we have to.
Thank you, sir. Right now, I welcome Dr. Anish Bashir, sir, to hand over the memento to Dr. Paul. Thank you, sir. Next, we shall have a non-academic session by our...
Good afternoon, everyone. I'll be talking about the neurosurgical management in stroke. For want of time, I'll skip through the definitions. I'll be dealing with the introduction and the usefulness of decompressive craniectomy in cases of stroke management in malignant MCA infarct and in cases of hemorrhagic transformation of stroke, and the post-surgical care, the surgical complications that occur along with post cranioplasty, and give you a flow chart about how to go about it. So these are the definitions that American Stroke Association and American Heart Association define by. It's a sudden occurrence of a focal neurological deficit attributable to a vascular etiology. And as per the World Stroke Organization, there's about 13.7 million new strokes every year, of which ischemic stroke forms a big bulk of them, of about 9.5 million cases. And coming to the classification of the ischemic stroke, we generally follow the TOS classification, in which we classify the ischemic strokes in large artery atherosclerosis, cardioembolism, small vessel occlusion, stroke of unknown and other determined etiologies such as thrombosis and all. So we'll be dealing mainly with the large artery strokes. The in-hospital case fatality rate due to ischemic stroke ranges from about 5 to 15% of all the admitted patients, and most of them are actually due to consequence of malignant artery infarctions, be it MCA. Most often it's an MCA, and it can even be in the AC or in the peripheral circulation strokes. And the most common reason why these only the MCA infarcts go into they have this high mortality is because whenever you have any infarct, the full region is going to become very edematous, and edema is one thing which brain won't tolerate. The incidence of such life-threatening edema is about 10 to 20 per 1 lakh per year. So what is the definition of malignant middle cerebral artery infarction, which is the most common scenario where neurosurgery will be asked to do their work? It's basically an infarct which involves about 50 to 75% of the MCA territory, and it should also include the basal ganglia and the additional characteristics in imaging also should be there, such as a midline shift of more than 4 mm, and should also have, and this generally you see it within 48 hours of the onset. So here is the CT image. On the left you have a CT brain plane. Which is showing you a right-sided MCA infarct. This was taken a little bit earlier. That's why you see that only in the A1 region there's this hypodensity and loss of the gray white this thing. But if it would have been taken a little later, it would have been very evident that it was a malignant MCA infarct. Whereas here in this, there's a contrast CT which is showing that there's no perfusion on the right side. So this is a malignant MCA infarct. So, so how does this malignant MCA infarct transform into this heavy cerebral edema? So as soon as the patient gets the brain gets infarcted, there's this failure of the ATPase pump because there's no oxygenation that's happening, and once the pumps fail, they fail to keep the sodium inside and put the potassium the other way. They fail to put potassium inside and put the sodium outside, which causes cytotoxic edema. And once all this starts, and there's breakup of all the cells that cause the blood-brain barrier, such as the astrocytes and the oligodendrocytes, due to which then it converts into a vasogenic edema, and there will be features of raised intracranial pressure. This is a diagram here, which is showing ionic edema, in which this caused due to the ischemia, wherein there's failure of the pumps. And here, the astrocytes themselves, due to ischemia, they lyse and release all glutamatergic toxins, which then further cause more edema. And here is a vasogenic edema, where there's a breakup of the blood-brain barrier. Sorry? I'm sorry. Okay. Okay, you mean to say the pointer? Yes. Okay, sure. So, vasogenic edema leads to cerebral edema, as I've said, and the breakdown of this blood-brain barrier also causes hemorrhagic transformation, because the foot processes and all do not function properly due to the anatomic breakdown. Here, I just want to review the anatomy of the brain. So here you have the coronal section of the brain model, wherein this part is all the supratentorial, and this is the infratentorial. This is the most important for us as we deal with varying pressures in the different compartments of the brain, due to which it can cause herniation, and that is what we want to avoid when we are going to go in for surgery. Here it's the sagittal section of the brain. Here you see along the plane you have a falx tentorium, and which is dividing here into the right and left halves of the brain. And this is the axial center of the brain, where here the anterior cranial fossa, here the middle cranial fossa, and here you have the posterior cranial fossa. So the main problem, or the main area where we are going to be decompressing, is actually in the medial of the middle cranial fossa. That's where you have your uncus of your temporal lobe, which will be herniating medially, causing all your features of raised ICP. There's this Monroe-Kelly hypothesis which forms a rock bed for most of our procedures, which goes on to state that in an intact skull, the volume of the brain, the CSF and the blood tends to remain constant. It has to remain constant under all physiological conditions. Any increase in one of them causes reduction in one or both of the remaining components, depending on how much time how much time you have since the offending agent has started. Or its corollary is that there is a constantness of the compartments maintained within the brain, mainly in the supratentorial, infratentorial spaces, and in the right and the left half of the brain. So here is a cartoon showing the approximate volume of the brain, in which you have about 1800 ml of the cranium, of which 1400 ml is occupied by the brain parenchyma itself. About 150 ml is then occupied by the blood volume. This includes the arterial and the venous compartments. And you have the CSF, which occupies about 150 ml of the intracranial compartment. So in case of any insult in terms of tumor or in terms of edema, it's going to start compensating. So what first is sacrificed is that your CSF flow, the ventricles start getting squished, and then they start pushing all the CSF downwards into your spinal canal. And once that is done, and then it's your intravascular compartment that starts to compensate by decreasing the perfusion, whereby all the ischemic complications get much worse. So here is a graph which is showing the relation of the intracranial volume with that of the pressure. So as long as we intervene between these two timelines, the brain itself has an autoregulation mechanism by which it can compensate. But once you go from this to this quartile, you can see that there's a very steep increase in the pressure, and that's when most of your complications occur. That's what we refer to as coning of the brain. So what we are more scared of is herniation. So herniation can be either in the form of uncal herniation that happens near the midline. That's where you have uncus along the middle region of the temporal lobe. And once it herniates through the incisura, that's where you have your midbrain and the pons and the medulla, which basically house your reticular activating system. That's when you see that the patients are not responding. And here you have your central herniation or your diencephalic herniation, where your thalamus and all, they start herniating down. And then there's the falcine, subfalcine herniation, where your cingulate lobe and the corpus callosum, they go against underneath the falx cerebrum here. It happens mostly in the anterior part of the brain more than the posterior, because the posterior falx is a very rigid structure in which it resists the brain movement. But anteriorly, it's very visible. It's in the CT images. That's what we keep talking about, midline shift. So that midline shift is basically when your cingulate lobe and your corpus callosum is pushing the brain under the falx anteriorly towards the opposite side. Now this causes another problem, because that's where we have your callosomarginal and your pericallosal arteries, the A3 branches and A4 branches, which start getting squished due to this herniation, and then people tend to develop even ACA infarcts. Though initially they didn't have ACA infarct, but it started out as an MCA infarct causing edema, and then leading into ACA, and then even posteriorly you have PCA infarcts also that occur when you have a high raised intracranial pressure. So, as I said, we divide the brain to supratentorial and infratentorial compartments. In the supratentorial, we generally find that we have a lateral displacement of the diencephalon, which happens around here, along with falcine herniation, and at later stages, it also this contribution of uncal and central herniation. In case of infratentorial strokes, there's mostly tonsillar herniation in which the cerebellar tonsils start herniating through the foramen magnum, and they're in a very close proximity to your medullary respiratory centers, which is the reason why posterior fossa strokes are more notorious in that at least in supratentorial compartment you have some time which the patient has, wherein you can do your investigations and you can they take time to make the decision. But this posterior fossa is not very forgiving for that reason, that you have your tonsils very next to the medullary respiratory and cardiac centers. So in uncal herniation, there is a herniation of the medial edge of the temporal lobe, mainly the uncus, which along the free tent of the tentorium in the incisional notch. That's where you have your oculomotor nerves which get compressed, and that's what translates into your clinical dilation of your finding your dilated pupil. So here is one of the here is a cartoon which is showing what happens in cases of herniation. So what we are very worried about is the presence of a midline shift in radiology and its clinical presentation. This lateral displacement of the diencephalon, which causes the this is where it happens, which causes the shift of the septum pellucidum to the opposite side. Here it's a case of a subdural hematoma, which is representative, but you can have any kind of insult here. It could be a tumor, it could be a large MCA infarct, a malignant infarct, which is causing a lot of edema. And there is a correlation between the amount of midline shift and the sensorium, in which if there is about 2 mm of a midline shift, the patient is still alert and he's not gone so far. But as it increases 3 to 5 mm, they become more drowsy, and at 68 mm, they become more stuporous and they become more difficult to awaken. That's what makes your GCS score also goes down. And at 9 to 13 mm, the patient is comatose, and generally his GCS is very poor, less than 8. Central herniation and rostrocaudal herniation, they have 5 stages pathologically and radiologically, which is the early diencephalic stage, the late diencephalic stage, midbrain stage and pontine, and finally the medullary stage where all the centers are compressed. So tonsillar herniation is where the cerebellar tonsils themselves get pushed down and they block the 4th ventricle, which results in hydrocephalus, upstream hydrocephalus, and downstream there will be compression of the medullary, cardiovascular and respiratory centers. This concept of upward brainstem herniation generally is not seen clinically in an intact de novo patient. Generally it happens when in cases of posterior fossa stroke, we put in an EVD to release the obstructive hydrocephalus, but then there's a lot of time between when we intervene, do a suboccipital craniectomy or a posterior fossa decompression. When there's a lot of time between the insertion of EVD and the craniectomy, that's when you see the upward brainstem herniation, wherein the cerebellar lobes and the midline structure start herniating upwards. This is the supratentorial infarct. In fact, this is a left MCA malignant infarct, which is seen here, which is more evident in the upper portions more towards the vertex. This is an infratentorial infarct, which is involving the left cerebellar hemisphere with this hypodense patch. Some of the clinical features of the supratentorial infarct is that they generally tend to have gaze paresis with a preference towards the side of the lesion, and they also have hemianopia, hemineglect, depending on where exactly which hemisphere is involved. They tend to have aphasias and due to the involvement of MCA in the posterior frontal region, and generally in cases of dominant hemisphere, the NHS scores are generally above 20, and in case of non-dominant, it's above greater than 15. And posterior circulation generally present with ataxia and nystagmus in coordination. What is common to both is that both can present with changes in sensorium, altered sensorium. And in anterior circulation in cases of the symptoms proceed in a rostrocaudal pattern, in that initially you have your pupillary dilation due to the compression of your oculomotor nerve, and they generally start having go into adduction paralysis due to involvement of the corticospinal tract more, and then this worsening weakness, and they go into extensor posturing, and then develop a contralateral Babinski kind due to the compression of the opposite side corticospinal tracts too. In case of posterior circulation strokes, we have lower brainstem signs such as altered respiratory pattern, and your hemodynamic parameters also change. They start getting going into altered. They get into high. They start getting high blood pressure, and since you have your abducens nerve, which gets pressed over the Doralus canal, you even get lateral rectus palsies there. The volume of the infarct, though it's smaller in cases of a posterior fossa, like I said, because there's a very small region that houses some of the most important structures, such as the medulla and the basilar artery, vertebral artery, they're more prone to getting compressed, which results in more clinical deterioration. And it's also more prone for hydrocephalus because that's where your fourth ventricle gets compressed, and then there's an acute hydrocephalus causing a raised ICP. Just this a very brief slide about medical management. So despite all this medical managements and endovascular intervention, still the patient tends to deteriorate in these conditions of all these malignant infarcts, and that's when neurosurgery has something to offer by a decompressive craniectomy. So exploring the history of neurosurgery for stroke conditions. Initially, we used to do something called a carotid excision, in which you just tie off the carotid artery and cut it off, because it gets very atheromatous, and it can again further worsen the stroke by releasing clots. But now no more it's done, except in cases of where you have proximal IC occlusion. In those cases, we do it. Of course, we do it only after doing a bypass surgery on the side. Other procedure that we generally do is doing carotid endarterectomy, which was first done by DBK in Baylor College of Medicine, one of the most famous surgeons. How will the decompressive hemicraniectomy help the patient? This was initially the question which initially it was thought that once a patient gets either a traumatic brain injury or a stroke, there's nothing that can be done when there's a neurological deterioration. That's when one surgeon, Theodore Kocher, he was the first one to tell that this is the time when you have to actually intervene when there's some neurological impairment or when there's worsening. That's when you have to actually intervene and not abandon at that moment. And in fact, he was the first one to actually do decompressive craniectomy, which he had documented in case of traumatic brain injury. And later it was Harvey Cushing, the father of neurosurgery, who had tried this for decreasing ICP in cases of infarcts, and even suggested the subtemporal decompression, wherein only the medial temporal lobes are decompressed. What we do by decompressive craniectomy is basically we unbox the cranium, and which will allow for the normalization of the pressure that has increased due to the edema, and thereby prevent all these life-threatening herniations from happening. There have been multiple trials that have shown that surgical management in these cases are way more beneficial to the patient than medical management alone. There's 3 trials called the Destiny 1, Decimal, and Hamlet, all of which were from various European centers, which all showed that they had they confer a lot of mortality reduction in the mortality. So these are the mortality benefits in case of surgery versus medical management. Here you can see that mortality is about 22% in case of surgically managed group versus the 53 in case of a medical group. And similarly, they showed that it was much less in surgically managed patients. And even your primary outcomes and your secondary outcomes in terms of modified Rankin scores were much better in the surgically managed cases. Like I said, that showed that there is a benefit in the probability of survival, which increases from 30 to 80% in cases of surgically managed cases of infarcts. And they see that in surgical management causes the modified Rankin scale is much higher in these cases. So choosing your patients, American Heart Association or the Stroke Association, they had given a guidelines which has a high level of evidence, which says that when there is deterioration of the when there's neurological deterioration, that's when you'll have to step in. And most patients who are not doing well in terms of neurological outcome, they need to be shifted to centers where there is availability of neurosurgical management. These are similar guidelines here. But however, in India, we generally go by a clinical assessment, in that we see, because there are constraints about time, we have financial constraints, and in case if they are too late before you can offer decompression, we generally tend to dissuade them from undergoing surgery. Here outside, most of the studies have shown that there is actually no difference between the dominant versus non-dominant hemisphere infarcts, but here in India, we generally try to we try to dissuade patients who have got a dominant hemisphere infarcts to not undergo surgery, because their post-surgical conditions are very bad. Here we have patients who cannot express themselves. We have patients who cannot use their right upper and lower limb for most of their activities. So they generally tend to go into bed sores and infections, and they generally tend to die. Even younger individuals of even like 24, 25 age, they die because they weren't managed well in post-dominant hemisphere decompression. When should the patient undergo decompression for optimal results? It's as soon as you know that there is there are features of raised ICP when the patient is going to bradycardia, when they're going to hypertension. That's when you know that your Cushing's reflex has set in, and that's when you start or you offer decompressive craniectomy. And it generally tends to be in the 48-hour period from the time of admission, provided that that sought clinical evaluation early in the course of the illness. Very few people, they generally tend to deteriorate after 48 hours. So even we are not very enthusiastic to offer surgery if the infarct has been about 3 days old. What are the predictors of deterioration? In cases of, in supratentorial strokes, in case of higher scores in the left-sided strokes, if it's 15, and in the right side if it's 20. And when there's early nausea or vomiting, they generally happen because there's a raised ICP. And in case of younger people who have had this malignant MC infarct, because they tend to do well post-operatively, and in female genders, and in cases of patients who have hypertension, because they also tend to convert into hemorrhagic stroke. And they also tend to have a poorer outcomes. In cases where CT brain plane shows more than 50% of the MCA territory involvement, they also tend to do a little poor. And when there's a hyperdense MCA sign in the initial imaging itself, if it is there, then they tend to do not very good. Or if there's involvement of the ACAs, PCAs, and the anterior choroidal artery territories. In cases of CT angiogram, like Dr. Alapat had shown, when there's T-shaped occlusion, generally at the terminal ICS, those are people who don't tend to do good because the full territory, the arterial territory is infarcted, or if there's an proximal MCA in which you have all M1 to M6 regions, they are infarcted. And then they have your other radiology scores like clot burden scores and lesser collaterals opening up, or if there are other embolic and dissection pathologies, they generally don't tend to do well even post decompression. These are experimentally used, but we don't use them in the centers wherein your serum markers, which are basically the markers for edema and your brain death of the brain tissue. This can predict if it's going to have a good course after your decompression. And in case of infratentorial strokes, the level of consciousness is one of the most biggest predictor. As once they start deteriorating, you don't have that much time to take the patient to the theater and do a decompressive craniectomy. And of course, as the herniations start worsening, you have more and more lower cranial nerve involvement, and the volume of infarction also tend to increase. And you also start getting into acute hydrocephalus, due to which there's increase in the ICP. This feature, this compression of the quadrigeminal cistern is one thing which we have to always keep in mind, because that's what guides our decision. So once in the CT we see that the cisternal spaces are they're being lost, that's when you have to refer the patient for neurosurgical decompression. It's been shown that the later the surgery is done, they have poorer outcomes. In cases of patients who are pursuing surgery within the 72 hours from the hospital admission, or much earlier within the 48 hours, they have much better outcomes. In age group, generally the older age group tend not to do well because there are more comorbidities, and the brain itself has lost its plasticity. So the brain doesn't compensate well for the tissue that has already been lost. So they generally have a very poorer outcomes. This has been established in a Destiny 2 trial. The Destiny 1 was for patients who were lesser than 50 in age of 50 to 60, but this had a higher age group, which they showed that in this population you have to be a little aware of that. They generally may not do well. But even then, surgical management has been shown to have a better prognosis. According to ASA guidelines, in patients who are more than 60 years of age and with unilateral MCA infarction and who deteriorate within 48 hours, they tend to not do very well. But we need to give them a chance, because that's I mean, when you explain to the relatives that's what they just want a fighting chance, so they generally agree for surgery. But then most of them are not okay with what happens after the surgery. There is one state which can guide you in terms of choosing craniectomy in your patients. If the timing is within 48 hours of onset, and if your score is greater than 15, or if the 1A part of the score is greater than 1, as in the patient is more uptended, and if the age is between 18 to 60 years, and if your infarct volume is greater than 145 cc, this is done in the MR imaging, or if it's greater than 50% in the MCA infarct. And of course, the patient is aware of what all complications can happen in the post-surgical timing. That's when we go in for surgery. Like I said, a lot of studies have shown that dominant and non-dominant, the functional outcomes remain same, but then it's a very geographical, there's a geographical bias to it. In infratentorial strokes, like I said, we have to go for urgent use of suboccipital decompressive craniectomy and posterior fossa decompression before they deteriorate further. It's been shown in multiple studies, even in cases of posterior fossa decompression, that surgery has a mortality benefit. But of course, it's more. There are more adverse events and post-operative complications, such as CSF leakage. They tend to have very bad pseudomeningocele. They get to have meningitis and ventriculitis because you're actually instrumenting into the ventricle, sometime into the fourth ventricle, and they tend to have multiple episodes of fevers post-operative, and they generally is in the older population in which there are multiple complications. So what they said, even for this case of, in case of posterior fossa, the suggestions were that the earlier the suboccipital decompression is offered, the better it is, and generally younger age people do well. And to tide over the period from the time of deterioration, we always put in a EVD, so that there's a decrease in the ICP, and you have to always follow it up with decompression, or you have to remove the EVD within about 5 to 10 hours. And if you find that even after you decompress, there is some cerebellar tissue which is bulging out, and you're not able to close the scalp, then you also can try sacrificing the infarcted tissue. So this is one of the algorithms to guide in cases of posterior fossa strokes. This is what we do in decompressive craniectomy in cases of supratentorial strokes. The patient is positioned supine with the head turned towards the opposite side. So this patient most probably must have had a right-sided malignant MCI infarct. So we use this inverted question mark sign, which runs from the tragus anterior to the ear, goes behind your parietal eminence, about 5 centimeters behind your parietal eminence, and then runs medially along the midline. So that's what you will first remove the scalp, and then you reflect it outside, and then you put burr holes here along the zygoma, anterior and posterior portions of the zygoma, and then another 3. We also put one more here in the frontal region, and then we connect it together and then remove the bone flap. And this is what you get once you remove the bone flap. So it's some guidelines say that it's better if you have at least a 12 centimeter bone flap that's removed, but then of late people say that the larger the decompression, the better are the benefits. So we do a 15 into 12 centimeters craniectomy. That is what is that's what's advised nowadays. And once you remove the bone flap, we need to make sure that even the dura is also cut, so that there's much better decompression that happens. So you do it in stellate fashion. So here we can see that the spokes of the stellate, these things are here, the dural reflections. So this is what we do. So we remove this part of the portion here, about 2 centimeters from the midline here, lateral part, and here the temporal decompression. So this total portion of the bone, that's what we do in a decompressive craniectomy in cases of a supratentorial infarct. In cases of posterior fossa infarct, we decompress this region. This portion we bite off the bone near the from foramen magnum. Of course, here foramen magnum is not visualized, but this is the portion that we nibble off the bone and give space for the cerebellar tissue to herniate outside instead of compressing on the medullary centers. Here in case of infratentorial, you do a midline incision on the posterior. Here the patient is prone with head on cerebellar headrest, and then we remove this part of the bone. We bite it off, and that's how this is done. So here you can see the amount of the benefit you get from doing a decompressive craniectomy and following it up with dural tears. There's a very precipitous fall in the ICP with even dural incision, which is one of the very major step in decompression. And in cases of in case supratentorial decompressions, we generally put the bone flap in the abdomen itself, in the subcutaneous fat, we create a pocket in the subcutaneous fat so that we don't invade into the peritoneum, and we put the bone flap. If we are planning that we do the cranioplasty about within 3 months. If we are thinking that for any condition the patient is not doing well, then we generally tend to give the bone flap to use it as a model for a 3D printing, and we create a new bone flap when we want to do the surgery and then replace it. In cases of posterior fossa decompression, we don't preserve the bone flap because there's no point in putting back a flap and increasing the pressure again. Of late, there is also one thing called a hinge or a floating craniotomy, in which you don't actually need to remove the brain, remove the piece of skull and put it into your abdomen or anything. We just put some titanium mini plates here. We hinge it to the rest of the skull, and then bite off some part of your temporal bone. That's where you require more of your decompression. So this causes causes a lot of relief in the ICP. But then eventually there are a few studies that have found that they can go into secondary features of raised ICP, in which case you will be forced to remove the rest of the bone piece too. So post-surgical management in this happens in the ICU. We have to intubate the patient, continue intubation so that we give rest for the brain, and there's no further worsening and no further infarct or conversion into a hematoma. And in case of, we need to start them on antiplatelet once we remove the drain, and we need to make sure that we initiate DVT prophylaxis, because most of them tend to be immobile and they tend to be older, so they can start going to DVT, which is another feared post-op complication. And they can even have aspiration pneumonia because they do not have their intact cough reflex, or for whatever reason even their lower cranial nerves dysfunction has set in. And lastly, we have to initiate physiotherapy and make sure that we initiate measures for bedsore prevention. The complications here, early complications post decompression are hemorrhage, conversion to hemorrhaging infarct, cerebral herniation outside of the wound. Wound complications, the wound itself can start getting, it can either get infected or it can start getting dehisced. There's CSF leak, there can be meningitis or post craniectomy seizures. They generally go into electrolyte imbalance. Either it could be an SIDH or it could be a salt wasting syndrome. And late complications, we have the sunken flap syndrome, in which you remove because of the removed flap and the atmosphere acting on the brain, they tend to become very comatose later in the later part of the evenings. This is one of the wound complication where the bone is inserted into the subcutaneous plane and the suturing was not done well. They don't tend to do good. This is where you have your external herniation from the herniation defect. That's why they say that you need to maintain at least a 12 into 15 centimeters craniectomy defect to avoid this kind of herniation. And of course, most of these patients would have already been started on seizure prophylaxis or treatment of any seizures in these decompressions. They can even have subdural hygromas, subgaleal collections, or interhemispheric hematomas, or tamponades due to a very bad case of subgaleal collection. This internal communicating hydrocephalus can be present in about 10 to 40% of the patients, especially those patients who have had intraventricular hemorrhage. They can go into the hydrocephalus, in which they'll require a shunt in the post decompression. This is a case of a sunken flap syndrome, where you can see that the atmospheric pressure has pushes the brain downwards and towards the opposite side, and then they start getting, whenever they ambulate, they get more worse. The sensor, they tell you that as the day goes by, he becomes more and more obtunded. That's when you suspect that they're probably having a sunken flap, which can be remedied by a cranioplasty. So cranioplasty, we have multiple materials that we use. It could be an autologous bone flap that has been inserted into the subcutaneous space, or it can be a pre-fabricated titanium flap, or we can even do it in the theater itself using PMMA, polymethyl methacrylate. And if there is time, we can even have 3D processes that we can print using the model of the skull. Generally, it's done within 6 to 12 weeks, but then it all depends on the patient's clinical condition. Sometimes we do it even after 6 to 8 months or even 1 year if the patient feels that his cosmesis is not good, it's not good for him. Here's the MRS that I was talking about. In cases of post-decompression, they tend to have a better MRS scores. This is another study which has shown the benefits of a decompressive craniectomy for stroke. I just want to end it with the algorithm. In case of patients who present with infarct, and then for surgical management, when you find that there is a malignant supratentorial infarct and patient is very upturned and there is pupillary asymmetry, then it's always better to consult a neurosurgeon and have an opinion as to whether decompression can be considered. And if the patient is alert and is not very upturned and he's got a good NIHS score, then we can give a trial for medical management. This in cases of supratentorial. In case of infratentorial infarct, whenever the patients, they become more drowsy or they start having symptoms of acute hydrocephalus, generally in the younger population, they tend to have vertical gaze paresis. That's when you plan for suboccipital decompression or posterior fossa decompression, in which you first put in the EVD and then go in for the decompressive craniectomy. The other strokes generally are managed medically because they don't cause such a significant edema. So you don't need to intervene to decrease the ICP. Yeah, that's it.
Thank you, sir. Any doubts can be entertained right now?
Sir, what is the outcome of these patients after craniectomy? Because you might have done hundreds. So this is the last resort. Are we considering the quality of the life or just maintaining the life?
So that so generally pre-operatively itself we tell them what we are expecting. So in cases of a non-dominant, they generally tend to do okay because they'll be using, they still have the right side functioning, the upper and lower limb. So if you want to, even if you have got some aphasia, you can tell if you're hungry, you can tell them that you can just sign saying that you're going for, that you want to go for, you want to do your morning ablutions and all. So generally the non-dominant side, we tend to push for decompression. But if it's the dominant side, then they generally tend to have a very bad post-op course because they don't express anything and their dominant side, the right side is paralyzed. So we generally don't tell them to go. But again, in US where you have developed countries and all, they have very good post-op care. So all your post-op physiotherapy, everything, rehabilitation is much better. So there they tend to offer decompression for both the patients. So here it's a very subjective. In Indian population, it's very subjective because you need to consider their status of financial status, whether they have a good family support. So you have to take all that into consideration, and we generally don't. Most of the centers don't. AIMS, NIMHANS, Vellore, we generally tend to tell them that if they're from a poor background, we just tell them that let nature take its course. But of course, if the relatives are still if they want it, then we go in for.
Because they don't know what will happen
after the. Yeah. Exactly. Exactly. So in the different. So in the rehabilitation, yeah, that's when in the rehabilitation they'll come back and tell us you didn't tell us about all this, and also we need to explain it pre-operatively. But they generally do good. Once if they are in a good window period, they generally tend to do good.
How many you have done during this time? Just for information.
No, so I had just joined. It's been about a month.
And in the past history of
in Vellore, so I had finished in Vellore. So there we do it very common. We do it at least once or two every day. Every unit do it. So it's very good. It's very good. Yeah, we get a lot of cases because in that we have a lot of trauma. That's a highway passes through this Vellore region. So you have a lot of trauma cases, and then you have a lot of infarcts and so encephalitis. So a lot of them go into edema, and then we get decompressions a lot.
How was the outcome of those patients in your experience?
Generally, it's very good. If they become functional, I mean, so there are people who come with a GCS score of 6, 7, 8, where there's a huge midline shift and they have all this dense paralysis. But then once you decompress, and the age is also young, they become very functional. I mean, some people have even gone back to their jobs, or they've become very independent like that. But again, it's a very specific population. You have to choose your cases. If they're in the extremes of age, they generally don't tend to do good. And comorbidities and all. Thanks.
Thank you, sir. I would like to welcome Sarfraz sir to hand over the memento to Pradeep sir. Thank you, sir. Now for the final session of the day, I would like to welcome Dr. Babish Chako, Head of Department of the PMR Department, to talk about stroke rehabilitation. And I request Dr. Sarfraz sir to chair the session.
Good evening to one and all. I'm sure that you're all super saturated with all these wonderful talks that you've had. And so it's my duty to limit my talk to probably 15 to 20 minutes, though I've been given an hour. So I shall be talking on post-stroke rehabilitation, the opportunities and challenges. Wayanad, as you know, is filled with lush green hills, breathtaking waterfalls, diverse flora and fauna, and what better place to have to set in your rehab journey for a patient who has stroke. A person who has stroke probably would have lost all the zest in life and has lost functional quality of life. So, and this is our institute where I head in the department as Institute of PMR. Now, the opportunity lies in identifying a patient with stroke and identifying a good candidate for rehabilitation. And that lies in the hands of the primary treating doctor, who could possibly be a general physician, an internal medicine specialist, a neurologist, or a neurosurgeon. Now, in rehab, in neuro rehab, we have both a multidisciplinary as well as an interdisciplinary team approach. And the physical medicine and rehabilitation department consists of a rehab physician, who's also known as a physiatrist. You'll have rehabilitation nurses, physical therapists, occupational therapists, speech and language pathologists, prosthetists and orthotists, social worker, dietitian, prosthetists and orthotists, and the coordinator. So what is stroke rehabilitation? It is a progressive, dynamic, goal-oriented process which is aimed at enabling a person with impairment to reach their optimal physical, cognitive, emotive, communicative, and social functional level. Now, as you've heard in the previous talks, within the ischemic cerebrovascular bed, there are two zones of injury. One is the core ischemic zone that you see here in the center, and surrounding it, you have the ischemic penumbra. So remember that it is ischemic, but still viable cerebral tissue. So if you have around more than 20 ml per 100 gram per minute of cerebral blood flow, it can sustain a neural activity. And if it's less than 10 ml per 100 gram per minute, which can result in cellular death. So as you've heard before, stroke intervention before 4.5 hours saves the penumbra. longer the ischemic time for reperfusion destroys the cells, and longer the delay in activity. So the longer the delay in activity also destroys the functions of the penumbra. And so let's see what happens post-stroke. Early during recovery, you will have resolution of post-stroke edema. You will have reperfusion of the ischemic penumbra, and you will have resorption of the local toxins. And later during recovery, what sets in is neuroplasticity, which is defined as the ability of the nervous system to modify structural and functional organization by collateral sprouting of new synaptic connections and unmasking of previously latent functional pathways. So this is the recovery pattern. Immediately you have loss of voluntary control and deep tendon reflexes. In the next 28 hours, you will see there is an increase in deep tendon reflexes. And during the first 38 days, you will see an increase in the tone in the flexors and the adductors in the upper limb, and the extensors and the adductors in the lower limb. And in 6 to 33 days, you start seeing intentional movements, which such as shoulder flexion, which appears. And then in the upper limb, you see upper limb synergical pattern followed by extensor synergy. So it's a flexor synergy that starts first, and then it's followed by an extensor synergy. So what is synergy? Synergy are primitive movements that dominate a reflex and voluntary effort when spasticity is present following a stroke. Now, coming to the question, Sir was asking a couple of questions regarding the functionality post-stroke, post-decompressive craniectomy. So let's go into that. Majority of the neurological recovery usually happens during the first 1 month. And hence, it is very important to start off early rehabilitation as early as possible. 5% of the patients show continuing recovery for almost up to a year. Now, please note one thing. Return of motor power is not synonymous with recovery of function. So 1 in 10 are functionally independent at this time of stroke, and nearly 1/2 are independent at around 6 months. Now, 10% of patients have complete spontaneous recovery. They don't require any rehabilitation at all. 10% do not benefit from rehab due to the severity of the lesion, and remaining 80% will benefit from rehabilitation. So what are the challenges that we have in stroke rehabilitation? So as you all know, the patient will have cognitive deficits, they'll have difficulty socializing, they'll have difficulty speaking, they'll have difficulty swallowing, they'll have difficulty in bowel, bladder, sexual functions, and most of all, what people ask us for is mobility. So this is what a stroke rehab program consists of. The first one is we have to improve the awareness of the patient and the cognition. If the person is not aware or cognitively not sound, we will not be able to proceed further. Secondly, we will have to manage the behavioral issues, the neurobehavioral issues that are associated with stroke. Thirdly, we work on communication and swallowing. Fourthly, the autonomics, that's the bowel, bladder, and sexual dysfunctions. Fifth is the motor issues, that is spasticity, musculoskeletal pain, difficulty in ambulation. Last but not the least, the sensory defects, that is hemi-neglect and pain. So let's come into all of this one by one. Awareness. The moment the patient comes to the physical medicine and rehabilitation unit, what we do is we will assess the person's cognitive level using an assessment tool known as Addenbrook's cognitive evaluation. And we score them based on their memory, fluency, visuospatial organizations, fluency, and so on. For some people with higher functioning, we'll go for LOTCA or MOCA assessments. Now, based on PSROP database, 80% of patients did not receive any treatment with methylphenidate, modafinil, levodopa, amantadine, or bromocriptine. Some of these drugs are very commonly used in our setting as well. However, what we see is the patients who received neurostimulant medications did not have any more significant changes in the length of the stay. motor recovery, cognitive recovery than patients who did not receive any neurostimulant medications at all. Coming to the behavior. So what we do is we do a neuropsychiatric inventory and find out what the behavioral issues are. So neuropsychiatric inventory is a 13-point system, and what we commonly find is that most of our patients will have depression, anxiety, and apathy. Now, once we find out what the patient has, then thereafter we'll do an antecedent behavioral consequence starting and offer them with behavioral therapy, and of course use of medications such as selective serotonin reuptake inhibitors or TCAs. Communication, I'm not going into the depths of it, but based on the 4 components of language, that is fluency, comprehension, repetition, and naming, you have around 8 combinations. And based on this, we will rehabilitate the patient. So what do we do in speech? So first, we'll do something known as a Western Aphasia Battery Test, find out what the issues are, and following which we will give our rehabilitation measures. Now, I'm just taking, I'll be talking on 2 of them. One is melodic intonation therapy. So this is something that we can do for patients who have an intact right cerebral hemisphere. Why? Because the melodic intonation centers are present in the right side of the brain, and this can be tapped as means of facilitating a verbal response. And the other one is, patients with locked-in syndrome, we use something known as alternative and augmentative communication charting. So I'll just share a video of one of our patients whom I had seen long time back with left MSA infarct, and he was in, he first had Broca's aphasia, and then we saw that he went into transcortical motor. And so this is what we do in melodic intonation therapy. I don't know if the volume is clear. This volume. So what I'm doing is this is a patient by name Mr. Hanifa. Now, he wouldn't speak much, but once, can we play? So yeah, but once his wife starts singing, you see that this man also is able to sing along with this, with the wife. Otherwise, he does not speak, but in this case, he did. So this is the same, I hope all of you know Jagdish Sri Kumar. Do you all know Jagdish Sri Kumar? So Jagdi also had a diffuse axonal injury, and following which, he was also able to... So he was also able to speak using melodic intonation therapy. So now I said in patients with locked-in syndromes, wherein there is a basilar artery infarct, and then the person is just able to communicate through eye movements. Now, in such cases, what we do is we use alternative and augmentative communication chart, something which we do in our institute here as well. So it can be unaided in the form of gestures, in the form of body language, eye blink. So sometimes it is just a yes and no. The most common thing that I do is 1 blink yes and 2 blinks no. And so they communicate with us. And these days we have aided charts, which is in the form of picture books. It can be objects, buzzers, voice output. And how many of you have seen Stephen Hawking's? So Stephen Hawking's, how does he communicate? How does he write all the theories in biophysics? It's all by using a system known as AAC, that is using an E-tron system. Okay, so these are some of the AAC charting that we have. Now, let's come to the next one, and that's swallowing. So 67% of the brainstem, 28% of the left hemispheric, and 21% of the right hemispheric strokes have swallowing difficulty. And hence, if they have swallowing, what will they develop? They'll have aspiration. And hence, what will happen? They'll be malnourished. So, when a patient comes to the physical medicine and rehabilitation unit, we first do a bedside examination, and with the help of our ENT colleagues, as you see over there, we do a fiber optic endoscopic evaluation of swallowing, look for laryngeal penetration or aspiration or pharyngeal pooling, and based on the penetration aspiration scale, we decide on what therapies need to be constituted. And some of the swallowing therapy that we do is oromotor exercise, head turn, head tilt, effortful swallow, multiple swallows, and swallowing using chin tuck maneuver. Those people are not able to tolerate NG tube, they're not able to tolerate puree, thickened puree diet for around 14 to 28 days. Such people are candidates for PEG insertion. Now coming to bowel, bladder, and sexual functions. Now these are less addressed problems in our stroke community. So bowel incontinence can be managed using timed toileting, communication, and toilet transfers, which we would have to train them. If they have constipation, we can hydrate them more, increase the dietary fiber in diet, and use of stool softeners or suppositories, allow commode and bathroom privileges. Most of the patients who come to us, they'll develop UTI. And one thing that I've seen is many of the patients post-stroke, while they are in medicine or in neurology or neurosurgery, there are times when the catheter is removed. Many times that may not be the right step. Actually, what we do in our setting is we do a post-void residual volume. So the patient voids and we see how much urine is remaining in the bladder using ultrasound. If it is more than 100 ml, he or she still needs to be on the catheter. But if it's less than 100 ml, we can change from an indwelling catheter to a convene drain or a urocondom. Now, sexual dysfunction, this is again something that most of them will not ask us, but we as physicians will have to ask our patients regarding the loss of libido and give psychotherapy, do pelvic strengthening exercise, and use of phosphodiesterase 5 inhibitors. Now, I'll be skipping through these slides fast. So for motor strength, we do something known as motricity index and modified clinical outcome variability scale. And please understand that in rehab, we measure all of these at the time of admission. We will keep measuring it every week, and we will quantify each of the scores that we use in physical therapy, occupational, speech, swallowing, psychology, and then by the time of discharge, we see if there is a quantifiable difference. So for balance and coordination, what we use is Berg Balance Score. For activities of daily living, such as modified Barthel's Index and functional independence measure. And for hand functions, it is Boxen block and hand dynamometer. So this is one of our FIM scoring, which shows on the level of independence. And this is the modified Barthel's Index that looks into various components such as ambulation, bathing, bladder, bowel, dressing, feeding, hygiene, stairs, toilet, transfers, and wheelchair. Now, what is instrumental activities of daily living? Should we be happy just because the person is feeding, bathing, grooming? No. We have to train these people in instrumental activities of daily living such as cooking, house cleaning, taking medications, laundry, shopping, personal finances, communication, and transportation. Now, this on the left, what you see is that a patient is doing mirror therapy, in which the affected hand is inside and the non-affected hand is outside the mirror box, and the affected hand is inside the mirror box. And when the person moves his left hand, he makes a fist. The brain is tricked into, or there is a reflective illusion thinking that the affected side is also moving, and that helps in the recovery. And what we do on the right side is constraint induced movement therapy. So the person's right hand is affected, but left hand is normal. So what do? We will constrain the left hand, and we will make the person use the right hand more often. This is the brainstorm stages of recovery and predictors of motor recovery. Those who suffer ischemic strokes have better chance of survival than those who experience hemorrhagic strokes. However, there is better functional prognosis in stroke survivors with hemorrhagic strokes over non-hemorrhagic. But the functional recovery is the same over a period of time. With regards to hand function, if there is complete paralysis at onset, the prognosis of hand function is really poor. Only 9% have good recovery of hand functions. If motor recovery of hand is there within 4 weeks, up to 70% of chance is there for good recovery. again, hemi-neglect in, in patients with the parietal lobe infarct. So they will have, how we do is, again, constraint-induced movement therapy, use of prismatic adaptation, eye patching over the good eye, trunk rotation, video scanning, and other techniques. Now, most of these patients have musculoskeletal issues. Some of them can present with a shoulder pain. So the moment a person has shoulder pain, what all will you think of? So everybody thinks of frozen shoulder, okay? But shoulder pain is not only frozen shoulder. There can be multiple other things. It can be, most of our patients will have shoulder subluxation, for which we need to give a hemi-sling. Some of them will have complex regional pain syndromes. And some of them can have bicipital tendinitis, tendinosis. Now here you see in this MRI arthrography, in the healthy subject, the axillary pouch. You see our axillary pouch in a normal patient, whereas if it is a adhesive capsulitis, we see that the axillary pouch is contracted. Now, all of this, we don't do MRIs for our frozen shoulders and all, it's all clinically. Now, spasticity. So what is spasticity? Spasticity is a velocity-dependent increase in tonic stretch reflex, and it can contribute to motor impairment, pain, and disability after stroke. And in such cases, we manage them with exercise therapy, use of antispastics such as baclofen, tizanidine, diazepam, and or by focal management using botulinum toxin, which we also use in our place over here. And use of static resting handsprints for the hands and ankle can prevent contractures and reduce tone. Now, let me just come to adaptive devices. Now, post-stroke, we have a lot of adaptive devices available. What you see over there is a universal cuff with a palmar pouch, and wherein the utensils can be placed inside the palmar pouch and they can be trained in feeding. You can also use bathing and grooming devices, long-handled bathing devices, socks puller, zip puller, and Velcro coaches, button hooks. For walking, we can use ankle foot orthosis and gaiters, and then with the help of a corded pod. At home, when they go back post-rehab, we also ensure that the environment is modified. They will require railings on the better side, ramps for mobility, grab bars at the bathroom, water faucet on the able side, toilet chairs with armrests, railing on the bed, and chairs with high seat. I'm just showing you a few pictures of some of our patients who have been rehabilitated post-stroke. Somebody with a left MCA infarct who's feeding on her own post-rehab, cooking on her own. We see patients participating in cooking, and they're trained in auto transfers, car transfers. Now, once they are rehabilitated, we also ensure that they are not dependent on others. On the other hand, on the contrary, we would want them to be providers as well. So they will start serving, they will start working on their own and have a source of income for themselves. So this is, as simple as opening up a tap. For us, it seems quite easy, but for patients with stroke, we need to train them in their basic areas. Now, money handling is very important. We know that, as I told earlier itself, we look into their cognitive aspects, train them to the extent that they'll be able to handle money issues, money by themselves. Now here you see again a patient with a left MCA infarct who was trained to walk with. If you see over here, there is a right-sided ankle foot orthosis there on the, he's wearing it as a shoe. He has a shoulder hemi-sling that he's wearing inside. You see that the right side, there's not much of movement, but he's functionally independent. And this is an elderly lady whom we've been training to climb stairs. And now, all of rehab is, it's not a sad atmosphere over there, and we want our patients to have fun. And so here we have one of our patients dancing with GBA staff. So this is in our rehab over here. Now, these are videos of patients playing together. Of course, this is in one of my previous campuses, that was in CNC Vellore Chittoor campus. So one is a patient with a stroke, other with a spinal cord injury, and somebody else with an amputation. So all work in no play makes Jack a dull boy, and hence in rehab we ensure that play, music, all of it is part of their life. And this is what we see here. Humor lightens up the heart. In every event, every festival, be it of whatever religions, it is all celebrated in our institute, in the Physical Medicine Rehabilitation Department. Patient education is very important. Patient education on the condition of the patient, on the rehab aspects, as well as how to follow up post-rehab. And this is one of our follow-up videos, wherein, this is in Andhra Pradesh, wherein I followed that same gentleman who walked. He has a small departmental store and he's handling everything on his own, and he's earning and he's providing for his family, teaching his children. And so I'd also like to share one video of one of my patients who, this is a video made by my patient, Dinesh. Usually I'm not supposed to disclose the name, but he shared this video saying that, "Sir, I would want the world to know what is possible post-rehab." Sorry. So somebody with a pontine stroke who has difficulty in ambulation, he has imbalance, all of which he was here with us for a period of 3 months. So we had to train him in his balance and coordination, which is not a very fast process. It is slow and steady. He was somebody who couldn't be off a catheter, but at the end of the day, we were able to remove his catheter as well. He was trained in auto transfers. And so this is in our rehab institute over here. So once he goes back home, he continues the exercises. Not just that, he also is a marketing executive and does work online as well. So my take-home message is early identification of patients requiring rehabilitation and referral to the physical medicine and rehabilitation unit is very, very important. Mostly what we see is, we don't end up seeing, but a day or two, the patient will undergo therapy and then the patient leaves. So early referral to the PMR department is very important. Second, managing disability is a complex task, and it involves an interdisciplinary as well as a multidisciplinary approach with a lifelong follow-up. Thank you. And this is our department over here. Thank you so much. I'm free to answer questions. I know you're all tired, so time to wind up as well.
Thank you, sir. I welcome Dr. Sarfraz to hand over the memento.
Thank you, Babisha, for coming and giving such a wonderful lecture on PMR. We, especially me, we were not knowing such beautiful things happen over in DMM's physical PMR department. Thank you. So we are wrapping up the session. We have arranged tea. While you go, have your tea and snacks and take your certificates. Thank you.
Few words to your team. Thank you very much for arranging such an excellent topic. Really, it was very useful, and I know that effort behind all those things will be very, very tiring. It was an excellent one, especially in some of the things. And sir, thank you very much. And I know some of the things, people used to do the EVD and then craniotomy, etc. I have attended some patients while I was overseas. But we don't know what was the outcome of the patient. We just say that they take it to the PAP and then I know that they keep it somewhere in the abdomen. Then we don't know what actually happened. Does it, whether they throw it away or whether they replace it back, and when do they replace it, and all those things we learned from your talk. That was an excellent one. It is very simple also. That was thank you very much. And again, sir, when someone is lost hope in the life, and they're coming to you, and you are doing a wonderful job for them. We don't realize that what we do is until we lose that ability. When you do all those things to help replace all those things back to them, it should be really a fantastic. Especially when I saw that person who can talk and sing. Singing. That was, I don't know what was that the technique called. Melodic intonation. Thank you very much. Thank you. Thank you.
Thank you, dignitaries and delegates, for sitting through all these sessions. You may have tea and collect your certificates from the registration counter. Thank you.